patient's better outcome. So what is outreach critical care? What is critical care and where are we providing this care? Critically ill patients, they are not dynamic. That means their physiology is changing time to time. So you have to keep monitoring these patients continuously and very close. And we need invasive monitoring sometimes. I mean, close monitoring like blood pressure, saturation, respiration, cardiovascular, everything, we have to monitor very closely in these patients because at any point you have to face the emergency which need quick action. So it is always, you have to be prepared for this, managing these patients. And they may need, if they go for an emergency, they may need vital organ support. That is all the multi-organ support. Respiratory system that includes non-invasive ventilation or mechanical ventilation. Cardiovascular system-wise, in the ward, you can start them on vasopressors or inotropes. Your renal replacement therapy, central nervous system support with sedation and liver. And it is not only your theory, knowledge, skills, but you have to know when you work as a doctor, this is multidisciplinary care. There are protocols, guidelines you have to follow. Always follow those things, but always make your patient individualized. I mean, good, we do have protocols. I mean, in your wards there would be, and you had learned last 5 years, everything. So follow those things, but make sure you always individualize your patient. That means your management should comfortable for your patient. And very important, communication, because the family patient, they have a right to know about the patient. Plus, you are dealing with many people when you work as intern house officer. Doctors, not only. Your doctors would be your senior house officers, registrars, senior registrars, consultants, and other specialties also. Plus, your nursing staff, your healthcare assistant, in the office, they are administrative people. So the management of your patient is multidisciplinary care, and we have to liaise with everybody when we work in the ICU. Where are we provided this care? I mean, as I mentioned earlier, the critically ill patient could be in the ward, emergency treatment unit, high dependency unit, or in the intensive care unit. Wherever the patient, you have to manage these patients. I mean, there are 4 categories of the patients in your ward. That means in the hospital, there are people who come for just wound or viral fever, whom does not need very much attention, but at 3 times a day, they don't need organ support. Your nurse will go check them. You do the ward rounds once or twice daily and see them. Next, they need close observation Category 1 patients, they are at the nurse's station with continuous monitoring. They may need organ support. Next, the category 2 patient is in the high dependency unit. They too have one organ system damage or support. And your ICU patient is the category 3 patient who need 2 or more vital organ support. So what is an ICU and how would that differ? ICU is a place where critically ill patients with potentially life-threatening illnesses are cared for. That could be septic shock, myocardial infarction, head injury patients. There could be ICUs where specialized like cardiothoracic, neuro, pediatric, but most of the hospital we do have general ICUs. We manage all kind of patients and working with protective gears. Safety measures taken to minimize contamination and protect healthcare workers. We do have follow protocols and guidelines when we manage patients. What you will learn during this short program. We do have 2 days only, but it's critical care and anesthesia are very vast subjects. But we will try to make you as much as possible to learn most of the things you have to know when you work as an intern house officer. We will introduce you to the intensive care, what we do general as management in the ICU, what organ support we do in the high dependency unit and intensive care unit, how should you do record keeping and monitoring of the patients, how to stabilize a critically ill patient. They are very short narrated lectures, so you can concentrate on it. Excuse me for the interruption. So those things we teach you. Then not only your theory knowledge or the skills, we want you other very important things as a doctor you should know. It is teamwork. In an emergency, you would be the team leader for the ward management. So you have to take the leadership at that time to manage your critically ill patient. You have to obey the ethics and your discipline, your mannerism, these are very much important when you work in a team and you are a very important person as a doctor, and your communication skills to be improved. Make sure the most important person in the hospital is your patient. Your respect, your care should be towards the patient. And I hope you would learn and enjoy the program, because we want you to learn everything which I discussed and which you learn next 2 days, because you are a very important person in the ICU multidisciplinary team, because ICU management does not start when the patient is admitted to the ICU, but your critically ill patient management starts in the ward. Your initiation of management makes a big difference for the outcome of the patient. If you start early your management, the outcome would be very much improved. But if you delay your management in the ward, the outcome also would not be that brilliant. So always make sure you identify your critically ill patient and stabilize then and there. This is very much important to uplift critical care in the country. Your young age is dedicated for last 5 years at your medical school. Now you had completed your training and you are going to start your career. A doctor is a very important person. You can do a lot of tour the country. And your parents are very much happy and proud of you to become a doctor. They would be happier if you make changes in the system and apply to the knowledge you gain these 2 days to improve the patient care and outcome, which would change the whole country is happy about you. And I wish you good luck. On behalf of the Faculty of Critical Care Medicine, College of Anesthesiologists and Intensivists of Sri Lanka, and College of Anesthesiologists and Intensivists of Sri Lanka, wish you all good luck and for your future. Thank you. Dr. Hemantha.
Can I start, Dr. Nandika?
I'm creating my, there was a person who is coordinating like, but I think you can. So you can share. Okay, we can see Dr. Harin your screen. Okay. So you can start, Harini, and introduce yourself. Thank you for joining.
Okay. Thank you very much. First of all, thank you very much, College of Anesthesiologists and Intensivists of Sri Lanka, Faculty of Critical Care Medicine. I'm Harini. I will be the first to deliver the talk today to how to do the patient assessment and the initial stabilization, which is something very important thing that you have to know how to do the when you are dealing with a critically ill patient. Right. So my objectives is to know the importance of knowing the patient assessment and how discuss the assessment and how are we going to do the initial stabilization. Right. So why should we assess the patient? Why do you think that it is needing thing to assess the patient? Assess the patients. So it is a thing you to assess the patient is to identify the problem first of all. So there should be a problem set. You have to know there is a problem before you're going to treat. So that is why you have to identify the problem first. Then it is thing that you are dealing with a critical ill patient. So you have to prevent the deterioration of the patients. Same time, you have to ask for the relevant investigations and then you have to give the appropriate treatment. So because of all those things, you have to identify, you have to assess the patients to identify the issues. So by doing that, you can overall, you can prevent or you can reduce the mortality and morbidity of such a critically ill patient. So in a time frame, so the illness and the cause of illness can be like when the patient is presenting to you, it can be the severity would be less. Where we'll say the time period where the patient is presenting to you, or the critical ill patient coming to the ward where you are, might be the less critically ill. But with the time, if we'll say now the 0 time the patient is admitted to, but after 1 or 2 hours, there can be the severity can be goes up. So the severity can be changed. So if you have identified the patient at this point, or at least at this particular time, it is the thing that you can cure the patient, or you can reduce the mortality of the patient. But if further delayed of the patient identification, that's a problem. So there can be a high risk. The severity can be very high, and the patient might be gone into the organ failure. That where you are not able to do much at this time. So still, if you have done something, still the patient is in a reversible stage. But if you have delayed it further, there won't be anything that you would be able to do, which is the irreversible stage of a patient, that you will not be able to do anything, and the patient would go into the organ failure, total shutdown of the systems. So the mortality and morbidity will be very high. So that's why it is very important for you to identify whenever the problem is less before it becoming severe or the irreversible stage. Okay, so why it is important to identify these patients in the early stage? So if you identify in a very early stage, there can be a very simple attention to the patient, very simple maneuvers would have been done to the patient to recover the patient. So if you have identified at this early stage, the non-survivors are very less, but the survivors are very high. We'll say 90% are the survivors, which is less than 10% are the non-survivors. Where the maneuvers can be very simple things, as I said. So it can be just giving you oxygen, just giving IV drugs, so just giving IV fluids, or very simple stuff would have been done for the patient to make him survivable. But if time goes on, the number of non-survivors will be high, and the number of survivors would be less. So that's why it is important for you to identify at the early stage. With the time goes on, there would be the percentage of non-survivors is high, and the percentage of the survivors will be reduced, and the interventions that you are supposed to be done becoming very high. So what is the problem is, when you have not done anything at the early stage, the number of non-survivors very high, and the number of survivors or the number of patients that you are going to save is very low. The very big problem is that they're going to have a higher risk of mortality as well as the higher risk of morbidity. Apart from that, you will need high-fi interventions. For example, and if you have assess the patient, or identify the patient is deteriorating, not early, but in the later stage, so then you might have to admit the patients to the intensive care unit. You might have admitted to the critical care setup. They might need heart support. They might need the inotropes or noradrenaline, vasopressin, whatever, central lines, arterial lines, or they might be intubated. They might need intensive care, the respiratory support machines to attach to it. So the problem is, at that time, there won't be any much availability of the beds in any of the intensive care unit, as well as that will give you the very high cost. Not you, but the system, the whole system, or the government has to pay very huge amount of money to save the patient, if not the patient is identified in the early stage. So that's why, and at the same time, the survivors rate is very less, the non-survivor rate is very high. That's why we need you to identify, because you are the very first person who is encountered the patient. The patients are coming to you. You are the very first contactable person to the patient. So that's why we need you to identify, assess the patient, and identify the risk as early as possible. So that's why I said, so if you identify it in the early stage, there would be just rupees, few hundred of rupees might be there for you to spend for the patient. But if you go at the later stage, there can be millions and millions of money that you have to pay for the patient. Right. So the level of care that you have to be aware. So there can be three, basically, if you say there's 3 levels, that's fine. But there are 4 levels that you can identify. So normally we don't talk about in the 0 level, but that's a level that is coming to your ward where the patient requires hospitalization and needing some sort of a monitoring through the normal ward care base. And simple stuff like IV drugs and 4-hourly observation might be the only treatment is needed for them to be cured. But there might be some patients who need acute care where you have to give them an acute set of bed and should be managed in the first cubicle of the ward-based setup, and may need oxygen support with oxygen face mask or some intravenous fluids. Might be good pain relief or with patient control analgesics or the epidural or whatever the things, but just have to be vigilant observation keep you in a acute care setup, acute care bed to make them assess whether they are deteriorating further or not. So the level 2 care is something that you are supposed to upstand the further care of the patient, where the patient might need HDU care, which is known as a level 2 care, where there is a nursing ratio to there are 2 patients is looked after by the one nurse. So there will be, but it's not 1-to-1 care, it's a 2-to-1 care, which is two patients being looked after by one nurse, where some patients who are not necessarily need the respiratory support. Like patients are not intubated, but patient might need some hi-fi stuff of oxygenation like NIV, non-invasive ventilation, CPAP machines or high flow nasal oxygens, or the patients might be tracheostomy weaning stage, that patients who are downgraded from the ITUs. So that such patients or patients might be needing inotropic support, or patient might be needing such sort of vigilant care, vigilant monitoring, more monitoring, or rather than in the acute base ward care. So that patients needed to be admitted into the HDU, which is that is also the critical care level. And then if the patient is further deteriorated, they might be needing into the ICU care, where it's 1-to-1 nurse, that one patient is looked after by the one nurse, and they might be need advanced ventilator support, like the patient might be intubated and ventilated, they might be need CRRT, that means a continuous renal replacement, and that might needed isolation of further care, the blood pressure monitoring, invasive monitoring. Also, it can be not a single organ support, can be the multiple organ support modalities might be needed. Okay, so there is essential assessment skills for you to be there. It's not only the skills that is needed for you to assess the patient, and there are some non-technical skills also there that you have to be developed as an intern, as you are starting as an intern. So the technical skills that we have developed so far from your medical schools, from time of you have entered the medical school up to now, with your knowledge base development, that you have had know how your anatomy is, how the physiology works, how the pathology going on this patient, that you know how to do some physical assessment, history taking, examination, what sort of investigation that you're supposed to do, because you're not going to do all this investigation under the sun for one single patient. So you are supposed to assess the patient, and you are supposed to do the particular relevant investigations on. So that's why it is important. What is called technical skills comes, which you have been trained so far from the day 1 of entering to the medical faculty to up to you have graduated as doctors. And that is why you are trained to think about the critically applying your knowledge to such patients. In the medical schools that we do our clinicals after the second MBBS, that we get the history examination, investigations, and acute management. We go for the casualties, we go for the on-calls, and we see the patient, how this is managed. So that is the technical skills that we gained during our training period as medical students. Same time, you get some chances to do IV cannula, IV access, how to get an IV access, how to manage airway. Sometimes you have had an opportunity to do the intubations and some other arterial blood gas, taking arterial blood gas, some sort of things that you might have gained the skills. But as these technical skills are important, there are some skills which is called non-technical skills, which are also equally important as the technical skills. So what are these non-technical skills? It can be interpersonal skills or cognitive skills. So what are the interpersonal skills? You have to develop a very good communication skills. So what are the communication skills? It doesn't matter that you have the fully qualified stuff of knowing these technical skills, but if you don't have these interpersonal skills, whereas good communication skills, if you don't know how to communicate with the patient, if you don't know how to communicate your problem or your assessment, your deterioration of the patient with your seniors, might be your senior SHOs, your consultant, registrar, whoever. So if you don't have the good communication, that would be a problem. The communication skills, not only with the patient and your seniors, but you have to communicate with other staff members of the team. Who are the other staff members of the team? You have to communicate with the nurses and the junior staff of the patient, the minor staff people or the midwives, whoever the rest of the team care holders who are there that you have to communicate with. And you have to identify this is not your single the single person drama, that you have to identify this is as a team work. You are one of the important person in the team, but you are not the single person in the team. So even the person who does this taking the blood to the lab is also important as you as a team. If one loop of this team is not doing the job properly, then there won't be have the success at the end of the day. So that's why we want you to be the one of the team members, but you are the team leader, but you are the rest of the people also as important as you. So none is higher up, or the one is not the lower down. So everybody has to work together as a team. In such a team, so you might be the team leader. So that you have to show your leadership until you get the senior help, and you call presence of your consultant or your senior registrar or your house officer, the senior house officer, SHO. So you are the team leader of the team that you have to take the leadership. So you have to be giving you the commands which have to be very clear and closed loop commands you have to be given to them. So you have to know until they comes that you are doing the proper pathway. Until somebody come and take over from you, you are the driver who is of this ship. So you are the captain of the ship. You are the driver of this the vehicle. So that you have to lead them the correct pathway until the success, the help reached or the success reached. So what are the cognitive skills? So then the same time you have to be aware about the situation of awareness. So you have to know what's going on. So that's why you have been trained to see what's happening on the situation. So what is the situation awareness that you have? That you have to know that the patient can go into cardiac arrest if there is a cardiac arrest, that you have to know now what has been done so far. The cardiac massage is started, whether what sort of cardiac compression is going on, what sort of the shockable or non-shockable, such sort of things that you have to know by as a team leader. So that is what is called situational awareness. You have to know everything in and out at that situation. And at the same time, with this situational awareness, you have to make the decisions. So what to do, to call, for example, to call the senior, to take the blood, to send blood for investigation. So giving that drug, or what sort of, or what degree of escalation is needed. That sort of the decisions you have to take until you get the senior help. So that is why it is an essential skills. The technical skills are also important, but I would say the non-technical skills are much more important than the technical skills, or Because if you don't have develop these non-technical skills, there will be no succeed, even though how much you are good at these technical skills. Right. So what is the problems of not failure to rescue this patient? So what will be the problems? There can be failure in planning. So the monitoring and the placing of the patient. So there can be might be failure in this planning, might be ended up with a failure to rescue the patient. So what is the poor planning means? So you have not encountered the proper vital parameter monitoring, which is you have not done the proper assessment of the patient, and you have not placed the 24-hour monitoring of the patient. So continuous monitoring of the patient. That means you will not be able to identify whether the patient is deteriorating with the blood pressure, patient deteriorating with the saturation, or are there any ECG changes, or are there any problems with the heart rate? Patient might be going to tachycardia, going to bradycardia, or any sort of things you will not be able to identify because of not placing proper monitoring. Or there might be the patient might be admitted to the UR ward, but you have placed that patient, you have not identified the patient as a critical ill, so you have put the patient in the very far corner of the bed. So it might be the chronic ward setup bed, where it's very far from the attention area. The patient has gone into cardiac arrest. So that's why what is important is something called the planning. So that's why you have to plan when the patient is admitted to you, when you have seen the patient, when you are assessing the patient. That's why you have to do the proper planning. So it is important for you to do the proper communication. So failure to do proper communication, that invariably going to the failure to rescue this patient. So what is this communication? I told you that there's a non-technical skill as well. So the communication means that you are supposed to communicate properly about this patient, what you are supposed to do, what do you want to do, what do you want get from the rest of the staff. So the one communication that you have to identify, assess, and identify the patient, and you have to inform your senior person, senior SHO, registrar, senior registrar, or the consultant. So that communication is a must. If you have not communicated proper time, the arrival of the help from the senior staff is less, so then you might be late. We'll say now the patient is coming as a myocardial infarction. We'll say the patient is on a acute chest pain, but you have failed to. You have done all the set of things. You have assessed the patient. You have taken the proper history. You have ordered investigations. Everything would have been done, but if you have not communicate properly to the senior, then it would be a problem. We'll say now if you have asked for the ECG, but you have not communicated properly to one of the nurses to get the ECG done at this particular time as urgent basis, then that ECG form would be there in the investigation key hall, and that will not be sent for the ECG person, or you have not called the ECG person to come in if you don't have the acute ECG monitoring the facility in the ward. So then the ECG will not be going to the ECG people, so they will not coming at a proper time. You will get failure to get the adequate ECG done. So then you have not identified, you will not fail to identify the problem as early as possible, that the patient would have a devastating problems. So that is why you have to have the proper communication to prevent rescuing to patient problems. And if there is a failure to recognize a deteriorating patient, so that will be, you can understand that can be a problem, because you have the nicely placed, you have planned everything, monitoring, and you have placed the patient in the acute bed in your ward setup. You have done all the communication with the patient, if you have done communication with your seniors and the nursing staff and everybody, but you have not identified these deterioration episodes of the patient. You have not identified the patient blood pressure is dropping. You have not identified the heart rate is picking up, and that patient going into tachycardia, or the patient getting bradycardia. So if you have not an adequate time, that if you have not identified this deteriorating patient, then the rescue time will be less. So then you will fail to do anything further. And failure to respond clear signs of the deterioration, that is also failure to rescue the patient. So there might be signs. So you will be having the tachycardia as an early sign. So we'll say the road traffic accident. The patient might be in the internal organ bleeding, but the sign would be, the first sign would be the tachycardia. You might be waiting until the blood pressure to come down, but the first thing, the patient might be compensated, but the first thing to responding, the sign would be the tachycardia. But you have failed to respond that clear sign of deterioration at that particular time. So the patient might be deteriorated. So you identify the problem is have gone into the irreversible stage, or the patient might have gone into the cardiac arrest. So that's why this planning, communication, recognizing these deterioration signs and respond to these clear deterioration signs is very important to rescue the patient or reduce the mortality and the morbidity. So when you encounter the patient, when you get the patient, first of all, think. The most important thing for you to think. You're not a clinical staff person. You're not doing just for a clerking job of about the patient. So you have to think rationally, what am I going to do? So when you get the patient, so you have to see what is the problem. So what seems to be the problem there? So whether it's acute case or the chronic case, or just when fever, the patient need the chronic side of the bed, or whether this patient just need the acute side monitoring with the acute attention. So you have to identify the problem, and you have to see what is the organs which have been affected. So whether it's a problem related to heart, problem related to respiratory system, whether it's kidney problem, liver problem, bleeding problem, or whatever the problem, you have to identify, just have an idea about which sort of, or it can be the heart and the lung problem, which sort of a system is affected. And if the patient is having any serious illness condition, do I need to have to pay the attention, or the patient is deteriorating? So should I call my seniors? So those are the problems that should come into your mind when you see an acute critical ill patient. Okay, we'll go in the case by case. So this is a 50-year-old man who is presenting with a central chest pain for last 3 hours. And the patient is in severe pain, retching, and he is complaining of sweating as well. So he seems to be confused. So what would be your problem? So this is where you have to think. So is it seems to be a problem for you? It can be, what sort of organs can be affected for the most of this patient? So you have to see whether the patient, is this a serious condition, or can I wait? Can I go and have a cup of tea and come until the patient is admitted to the ward? Is it that serious, or can I have to attend this patient early as possible, or can I go and have my lunch and come? If the patient is deteriorating, or should I call my seniors as early as possible? So those are the problems. So that should come into your mind. What are you going to do? Right. So are you going to complete routine assessment of this patient with a detailed history, examination, and investigation first, or you need to come into definitive diagnosis? Some sort of a diagnosis might be the definitive diagnosis before initiating of any treatment. Are we allowed to ask any questions? Anybody in the audience would like to attend this? How would you assess this patient? Are you going for the routine assessment and the detailed history examination, or just you are going for a definitive diagnosis before initiating any treatments? Can we ask from the audience? Anybody there to explain? Can you all hear me?
Yes, madam, we can hear you.
Yeah. Is it Dr. Roshan?
Yes. Yeah.
Dr. Roshan, can we ask from the audience or one or two persons to come and answer the questions?
They can always unmute and ask questions. Plus, they can use a chat box as well.
Yeah. So that's fine. That's brilliant. So can we get somebody who is from the audience to answer this question, please? So if such patient, now I said the 50-year-old man with a chest pain who's coming to ward with a central sort of chest pain for last 3 hours with the sweating and retching. So he seems to be a little confused. So are you supposed to do the routine, complete your routine assessment, history examination and investigations, and do the sort of things first, and then going for a definitive diagnosis, initiating this, or what are you going to, what are your plans? Okay, so there's a chat, you can do the chat box thing. So you have clinical diagnosis of possible myocardial infarction and proceed with the initial management and stabilization. Right, okay, so you can do the chat box things. So the question is whether you are doing initial detailed history things? No. So you have to act fast. So you have to get an idea. Now, this is acute coronary syndrome. So the patient anytime can be go into deterioration if you have not done anything at this particular time. So that's why you need to be attended as early as possible. You don't have any time to waste. So you can take a history, but not in detailed manner. But same time, you have to act fast. So that's why you are not supposed to be in a very, very slow manner of doing it. So critical condition is identified. So you have to act fast, and proper treatment has to be initiated as early as possible. So that's why in your initial assessment, you have to do the primary phase assessment early stage, and you can go for the secondary phase of assessment in the once the patient is stabilized and once you have initiated the initial treatment. So what is your primary phase of assessment? So you can do with the ABCD approach. So what is your ABCD approach? I think you know that from your medical school. What is the ABCD approach? So what is the ABCD approach? So it's a airway, breathing, circulation, disability, and exposure. So this is why it is called ABCD approach. Why it is needed to be do this ABCD approach as early as possible? Because you know that this is an emergency condition. This is a acute critically ill condition. So you will not be missed by anything if you have follow this ABCD approach. And apart from that airway kills before the breathing, and the airway breathing kills before the cardiac problem. Airway breathing circulation kills the patient before any D or the central nervous tissue. And then ABCDE is kills before you do the exploration and exposure and sort of thing. So that's why what kills patient first comes first. So that's why you have to have the airway assessment first, and then the breathing assessment, and then C, and then you have to go for the disability assessment or the central nervous system approach, and then expose, and then do the rest of the things. There you have to identify the potential life-threatening conditions and what is the deterioration conditions of there, and then act accordingly. So after that initial stabilization, for example, we'll say now the patient is coming with sudden onset shortness of breath. So there might be tension pneumothorax. So you have to identify this problem as early as possible, and then do whatever the needing thing has to be done. So then thereafter, then you can go for the secondary phase of assessment, like the complete history and monitoring vital signs every 15 minutes up to 1 hour, 2 hours, head-to-toe examination, assessment of the pain and giving sort of painkillers, and then taking the proper history about the socioeconomic problems of the patient. So if you have an idea about what is this, then ABCD has to become first, and then you have to treat the acute setup initiation of the treatment. So in ABCD approach, so that's why I have discussed with. So airway, breathing, circulation, exposure has to be done. So we'll go one by one. So the airway assessment. So in our case, in our patient, I told you the patient is confused, but he can talk. He can talk you with the clear words, but he's confused. He doesn't have any secretions, and there is no swelling of the lips and tongue. So what would you do? So what is your intervention? So what do you think about the airway? So are you going to do any intervention at this particular time? Can somebody unmute yourself and answer me, please? So what is your approach of this patient? Airway. What do you think of the airway?
The airway is patent here.
Yeah. And do you need to do anything in this patient at this particular moment?
No, we can move to the second part, B,
yes.
for breathing.
Exactly. So the patient's airway is patent. So the patient talks means that even though he is confused, he talks. That means the airway is patent. So you don't have to do any interventions that you can clearly go into, as you said, you can go into the next stage. So what are the conditions that you are, not this patient, but there are some conditions that you have to be very vigilant about the airway. So you have to see whether the patient can talk or not. So are there any obstruction sort of things, obstruction or the foreign bodies? There might be dentures which be obstructing. There can be saliva, the soiling of the airway, like vomiters, blood can be there. But that you have to see, are there any obstruction of the airway, the patency of the airway, whether get obstructed or not. Are there any edema of the lip, swelling of the tongue, face? So can be anaphylaxis. So in such conditions, you have to identify, are there any potential obstruction to the airway? For we'll say, now the patient with the inhalation burn injury. So at the initial time, there might be swelling is coming around the face. So then that you have to be vigilant. So you have to go ahead with the airway securing of the patient. And there, in pediatric patients, sometimes we will see some drooling of saliva. So can be a potential problem of going into the airway obstruction. Not even the pediatrics, even adult patients, there are some drooling of saliva because of there are some upper airway obstruction problems. And they might be having abnormal sounds, like stridor is some common problem in an adult patient. They might be having stridor sort of breathing. Stridor means there is a obstruction to the airway. So that's why it is giving you this noisy sort of breathing. So if it is going in the orifice is a very smooth manner, there won't be any sound. So, but if there is any partial obstruction to the airway, so there can be, because of this turbulence of the flow, there can be noisy breathing. So if you have these sort of problems, swelling, edema, drooling, saliva, stridorous breathing, so any sort of obstruction, patient is not talking. So that makes you impression that you have to intervene early as possible airway, because airway can kill the patient before you move into the breathing. So what are your interventions in the airway? So you can clear the secretions. If there is any sort of obstruction, bleeding, you can suck out the secretions. Any vomiting materials, you can remove by suctioning of this. Are there any visible foreign body there? You can remove it. And the same time that you are supposed to make sure the patency of the airway. So one simple maneuver that we can do is the applying of the triple maneuver. If the patient is not a trauma patient and you are not suspecting any cervical injury, you can do this triple maneuver. So what is mean by the triple maneuver? You can do the head tilt, jaw thrust, and the chin lift. So what is head tilt? So you are taking the head towards the upper, and you can do the jaw thrust by getting the angle of the mandible. You can do a jaw thrust and you can do the chin lift. But if the patient is with the cervical injury, so you can't do this head tilt pass and the chin lift. You are only possible to do the jaw thrust because of cervical injury that's suspected. So if you do the head tilt and chin lift, there can be problems. There can be instability of the cervical spine. So that's why you have to do the jaw thrust alone. So by applying this triple maneuver, that you are able to do the some patency, can get the some patency of the airway. So until you help gets, you might be doing this triple maneuver. So until the anesthetist or someone who is very capable of doing the airway, so you can do this. There are some adjuncts are there for you to use. So it can be oral airway, which we call the griddle oral airway, or you can have the nasal airway. By applying this, you can do the bag and mask ventilation until you prepare for a proper intubation. Or sometimes we are not supposed to do the intubation. We might go ahead with the applying with the LMA or the iGel. So as interns, when you go when you're doing your appointments, you will get the chance for go to the theaters. So whenever you go into the theaters, there are anesthetists that you can get an idea about how to do the jaw thrust, chin lift, and the head tilt. You are not supposed to do with intubation and putting an iGel. It's good if you can have a chance, but it is not mandatory. But if you can apply in the triple maneuver, and if you know how to oxygenate the patient, with bag mask, so that is more than enough for you to get the adequate oxygenation of the patient until you go for somebody arrives and you go for the proper intubation or the proper securing of the airway. So if you have a chance, when you go into the theaters, see how the anesthetists are holding the mask, see how the anesthetists are getting oxygenation of the patient, get an idea how to do that. And if any chances, you might be able to call to them, talk to them, and get a chances for you to get these skills done by yourself. Right. So now patient, we don't have to do much. So we'll move to the breathing, next part. So this patient have a difficulty in breathing. So he's tachycardic. He's a tachypneic, respiratory rate is 32. But he's with a good chest expansion. So with the auscultation, and when you see that there is no problems in either sides, trachea is central, percussion note is good. There's no problem to identify. Some bilateral diffuse crepitations, as you have somebody has applied the saturation probe, which seemed to be 89 on the room air. Is it a problem? Is it a problem? So what are the problems that you identify in this patient? So they are fine. Now we are going to the breathing. There is some parameters was given. Are you supposed to do anything? Is the problem have you identified? Can somebody unmute and talk? Okay, so there is a problem, isn't it? So the difficulty in breathing, patient is tachypneic. So this is a problem. And the most problem that you identify, the saturation in the room air is 89. That means you have to do something. So in breathing patients, you have to identify the spontaneous breathing is there or not. So what is the rate and what is the pattern of the breathing, whether it's any obstructed sort of breathing. So you can identify like a seesaw pattern of chest movements or obstructed sort of breathing. They might be they might be tachypneic, or they might be the rate is very less. And there can be symmetry of the chest movement is not there. They might have one side is going up more than the other side. So, and you have to see, are there any nasal flarings, recessions, accessory muscles? Are there any? There might be in the respiratory distress. So you have to identify. And the color, they have gone into cyanosis. Saturation is a very important thing that you have to identify. So what is the normal saturation? You are there to identify in the normal room air saturation. So what is the target that you are worried about? So in this patient, it's 89. So what is the target that you are normally supposed to have it? Any idea? Can somebody type in your chest book? Chat box, can you type? What is the saturation that you are? Yes, somebody has said 94, that's fine. So if something goes beyond 94, that you in a room air saturation, in this patient is 89. Yes, that keeps you vigilant about this. You have to do some intervention of this patient. So normally the saturation we are in the room air is 94 is fine. So if it is something going beyond 92, that is not good. So 95 is something that we are going ahead with seeing the patients to do something. So that we'll say the 95 is a good cutoff point for if patient to have something to be done. So what you have to do, so you have done the breathing assessment of the patient, and then there's a problem of the saturation. So that's why you have to give the oxygen in this patient. So not in our patient, but it can be some life-threatening condition. I told you that there can be pneumothorax, which is a life-threatening that you have to get an intervention has to be done. I'm not going to talk about what is to be done, but you have to know that what are you going to do if there is any tension pneumothorax. So such acute life-threatening conditions. And same time, you have to ask for the appropriate investigation. It can be blood gas comes first before the chest X-ray, because chest X-ray you can't send for the patient for an X-ray department to get the chest X-ray. Such deteriorating patient, the patient going to cardiac arrest during the X-ray department, unless you have the portable X-rays in the ward. So the ABG is a good parameter that you can get an idea about what is oxygenation, pH values, carbon dioxide levels, oxygen partial pressure. So good parameter that you can do. But having said that, you are not supposed to do the blood gas for each and every patient, because blood gas is something very expensive. That the cost is that you're sending for a blood gas each and every patient. So most of the blood gas machines are in the ITUs. You are sending all the patient in so I have experience in my unit, in our hospital, I have received, so the blood gases are sending every 2 minutes. So what's the purpose of sending blood gases in every 2 minutes? No point. So that's why you have to initially assess the patient. Is this patient need the blood gas? Yes, you can send it, but it is not this very serial manner, 2 minutes the blood gases to identify the patient problems. That why in assessment of the patient, you have to plan what is the investigation, most important investigation that you are supposed to do. Unnecessary wasting of the resources is not recommended for you to do. Okay, so in our patient, you have to give the oxygen, and you can do the blood gas if it is needed. And you can do the blood gas in this case. You are not supposed to go for the chest X-ray if it is the inward ones are available. But you have to monitor the patient as much as possible. So give oxygen with the face mask, 10 to 15 liters per minute. And with that, in our patient, the saturation improves up to 94%. Are you happy? In this patient, yes, I'm happy. So we have given oxygen 94%, up to 94 with oxygen with 10 liters. At the moment, I'm happy, but I'm not totally happy about the patient. This patient can be deteriorated because I have not done the proper management yet. So then I move into the circulation. Can I move into the circulation? Yes, I have done A. A is fine. B, I have done intervention. So then I will move into there is no life-threatening conditions in the B. So I can move into the C. So I go into the circulation. The patient is clammy, sweaty, and the capillary refilling time is 3 seconds. He's tachycardic, but regular, low volume pulse. The blood pressure is marginal. Does that mean anything? Yes. So he is tachycardic. So the appropriate history and the examination findings says that the patient is in the acute coronary syndrome event. So you can initiate with the GTN sublingual. You can give the initial management strategies for the patient, aspirin as antiplatelets and the stat dose. You can get an appropriate IV access. With the IV access, same time, you can ask for the blood for full blood count, electrolyte, and you can give some IV morphine because the patient, you know that myocardial infarction pain is a very severe pain. You can give some pain relief to the patient. Morphine is the idea. And the same time, you can order the 12-lead ECG urgently, and you have to communicate with the nurses and the ECG technician well to come and do the ECG urgently, but not the ECG form in the nurse's desk. So you have to send that form early as possible and call them for come and do the ECG. So in our patient, the ECG depressions has noted with the lead 2, 3 AVF. So that means inferior leads are getting affected. So does that gives you the ring the bells for you? Yes. So you have to immediately call for your senior help to attend immediately. So you have done your part. So the rest of the part can be done by the senior colleague of the team. So the same time, you can attach the patient to the multi-monitor. You can, with the presence of your senior, they can start the therapeutic enoxaparin. Sometimes it might need IV furosemide to be administered. So you have already sent full blood count, electrolytes, and you can do the sugar level. You can send the blood for sugar, or you can do the capillary blood sugar level as well. With the time, adequate time, you have to consider sending the troponin I and ask for a serial ECG inspection, 10 minutes, 20 minutes to see how the progression of the patient. So in a circulation, not in a cardiac patient, but we'll say the trauma patient, the capillary refilling time is a very good important parameter to say the delayed perfusion to the peripheries. So if it is going high, more than 2 seconds, so that rings the bell for you. There should be some perfusion defect. Color of the patient is pale, trauma patient, obvious, you have to have an attention. Respiratory rate, tachycardia, bradycardia, That's might be the early warning sign. Rhythm, patient might be going into arrhythmia stage. The volume, low volume steady pulse in a RT road traffic accident. Yes, that is alerting sign for you. The blood pressure, low blood pressure is a problem. High blood pressure is a problem. But blood pressure in a trauma patient is the late sign for you to detect. Before that, you get the high capillary refilling time, patient might be tachycardic. And if there is no pulse, yes, cardiopulmonary massage CPR has to be commenced early as possible. So in relevant investigations has to be done according to the case. You are not supposed to ask for an ECG for all the patients. You are not going to ask for an echo for all the patients. You are not going out for the chest X-rays or the blood gases for all the patients. So investigation has to be done relevant to the case. So have to send for a blood for investigations, IV access, fluids appropriately, trauma patients, initiation of the fluids, sending blood for grouping and saving, giving the blood O negative blood until the blood cross match is available, and appropriate medication has to be done. So like our patient, you have given antiplatelets, sublingual GTN, morphine as a painkillers, oxygenation, everything is done appropriately up to time. And depending on the clinical scenario, you can ask the subspecialty physicians, like cardiologists can be attended. They can further care with escalation. Primary coronary intervention has to be done early as possible, or the thrombolization has to be done. That can be decided by them, or the presence of the medical consultant as well. Right. So then I will go into my disability assessment. So in any disability, you have to do the AVPU's scope, alert, verbal response, to respond to the pain, unresponsive. Or you can go with the GCS with the ICE assessment, V, and the EVM, motor disability assessment. Don't forget the same time do the pupils assessment. So if it is a trauma patient, or even though with not the trauma patient, there can be unequal pupils, means reaction is less, means might be some problem in the head. Can be SH or the intracranial hemorrhage or something might be there. So don't forget to assess the pupil size and the reactivity. Do the blood sugar level of the patient. They might be hypoglycemic or might be hyperglycemic, which the decay as an immediate life-threatening condition that you have to attend early as possible. So most of the patients that we see coming into the I2 admission, so nobody has seen the pupils. So make sure that you have done at least, try to get as a habit to put a torch into the eyes to see whether the pupils are reactive or not, or the size are equal or not. So in our patient is arousable by voice. Capillary refill time is, the patient's reactivity to the light is okay, and the CBS is 178. So then I go for the move to the exposure of the patient to examine, are there any problems that I can identify in our patient. I don't think any problem that I can identify with the exposure of the exposure or the E part of the patient. But you are supposed to do the E part. So the E exposure part, that you can do the temperature monitoring of the patient. Our patient is fine. So when you're examining patient, when you're exposing the patient, make sure that you are maintaining the dignity of the patient, which is one of important things as a junior doctors, that not to expose the patient uncovered. So you have to cover, you have to have the screen, and you have to maintain the dignity of the patient. Before you're going to expose patient, make sure that you get the proper consent, verbal consent from the patient, that you just say that I'm going to do this examining of the patient is a very important thing. So it's not a problem in countries like us. There won't be that much problem of a hypothermia, but if you have going to work in some environment, there can be the problems with the hypothermia that is important for you to prevent hypothermia. For example, if the patient is coming after drowning, so then in such patient, even though in the country like Sri Lanka, so when you are exposing the patient, make sure that you are not making the patient further hypothermic. So in such conditions, prevent hypothermia important. So turn the patient to see are there any posterior aspect problem, not in our patient, but if a trauma patient, log rolling or the turning of the other side might be the problem. So this might be the wound there, might be the laceration part or something might be there. So it is important to see the posterior aspect of the patient as well. In your quick and relevant history, take the ample history, allergies, medications, previous history, past medical history, last meal, events that has leading to this problem. In our patient, he's a diabetic patient who is on metformin, no previous cardiac problems, no allergies, where the event leading to a problem is that while he was watching the TV, he had this chest pain. So once you have done the initial assessment of the patient, the same time that you are going with the initial stabilization, then you have to address or you have to go for the secondary phase of assessment, where you get the detailed history and detail or completing your systemic review and examination, and then order for further relevant investigations. There you can go ahead with the patient's previous drug cards and see what sort of drugs patients are on, whether it's needed to be continued. Yes, you go through it and continue or prescribe the medications. And then there you can decide what frequency of review has to be done in the drugs point of view or secondary assessment of the patient. In our patient was kept in an acute cubicle with monitoring, with the continuous monitoring. We didn't put patient into the chronic cubicle far away, and we identify, the house officers has identified this patient has to be in the under their vigilant monitoring. So cubicle, first cubicle, acute bed, and then the chest X-ray was ordered to be done later, but early as possible, later, but not now. So this assessment of ongoing identify the problem is very important, and then frequent monitoring is important. Depend on the situation, whether 5 minutes monitoring, 15 minutes monitoring, and deterioration of the assessment is important for you to identify any further deterioration. That's why this mu score is come into action. So modified early warning score. So when you are in the ward, you can identify this depending on this score parameters, that it says what sort of interventions that you are supposed to do, whether to call the senior, giving any escalation has to be done. So you have to be little bit of familiarizing with this. It's depend on the cardiovascular system, respiratory system, renal system, the urine output is there, then the central nervous system, AVPU score is there, temperature. So every sort of things that there are, the parameters are there. Then with that parameters, it gives you the score. Just get a familiarization when you're in the ward. So how to see the mu score and how to identify are there any deterioration. The same times when you're coming into sepsis, the patients who are with fever and ongoing inflammatory signs of infection, this magic hat comes very important role. So what is magic hat with the SOFA, where there is something called the Q SOFA, quick SOFA, or the quick sequential organ failure assessment, which comes as a magic hat. So what is magic hat means? H means patient is hypotension, alteration of conscious level, and the T is tachypneic. So if there is then you have to see that the patient is coming into sepsis with the presence of infection, that you have to go ahead with the mu score, and this gives you the very good idea whether the patient is deterioration or not, for you to call early help in critical care setup. So the special populations, I'm not going to about the children.
What is the probable diagnosis of this patient? Probably.
Elderly patients, pediatric patients, obstetric patients, and there you have to modify your assessment. Right. So remember that you have done everything. So your documentation is very important. If you haven't done the documentation, that would be a problem. So do the documentation. And remember, now this is teamwork. I told you earlier, this is a teamwork, and I told you that it's a very good thing that you have to do the good communication. It's not only with your staff, it's not only with your seniors, but make sure that you talk to the patient as well as the family. If you have not done the good communication with the family and the patient, so even though how much you have done, if you not rescue the patient, so the problem will be yours. So everybody, family members, friends, everybody of the family will blame you if you have not done the proper communication with the family as well as the patient friends. So basically the next of the kin, the patient family. So make sure that you treat the patient the same time. Remember to treat the family as well, or the relatives. So that is important thing to remember. And the key point or the summary that I want to tell: in assessment, the primary phase is important ABCD approach. Secondary phase is detailed assessment. So in this sort of a critical patient is coming to identify you, identify the problem. There is a problem, identify there is a problem, think what you're going to do, and find out your solution. So this sort of critical thinking is important when you are dealing with acute critically ill patient, and remember to call for the help early as possible. So at the end of the day, as a house officer, what is expecting for you is to identify initial assessment of the patient, identify the problem, and initiation of the treatment in your level until you get the help or the escalation of the patient. End of the day, what is important to send the patient, live patient home, rather than sending a body with in a coffin to the home. So that is important. That is why we want you to do the initial assessment and initial stabilization of the patient for better outcome. Thank you very much. I hope you have get an idea about the initial assessment and of the stabilization of the patient. Thank you very much. Any questions?
Right. If you all have any questions, please type in, or you can unmute and ask.
So this question if an involved patient develops a stridor following antibiotic administration, assume that the patient is going to anaphylaxis. As a house officer, what works to be the airway management or next step of management other than giving adrenaline? Will a simple airway management be enough if the patient has developed stridor? Well, stridor is a life-threatening that says that the obstructed of the airway. So in such patient, yes, you can do the triple maneuver of the patient. You can tight fitting mask and give the oxygen to the patient. In airway, you are not going to intubate the patient, because stridor's patient, it will be very difficult intubation for you, or it can be difficult intubation even for the experienced anesthetist. So make sure anaphylaxis patient, the stridors is coming, so they give oxygen with the applying with the triple maneuver of the patient. So if somebody is there, then they can ask for the anesthetist is there, the help is there, they can go ahead with the LMA at that particular time. The patient, normally what we do, we take the patients to the theater, have to for under the gas induction, you have to intubate the patient, otherwise it would be a very difficult intubation. So stridor is some difficult intubation scenario. That's why you have to be somebody who is capable, who is experienced of doing such intubation. I'll give you the example. When I was in a medical, when we were doing the medical ward, there was one patient who is with an inhalation injury. So that patient was very difficult intubation. He was stridors, and then we have to take the patient to the theater. So we intubate the patient with the gas induction, and very difficult intubation is anticipated. So stridors patient, until you get the help, therefore make sure that you give the triple maneuver and the giving the oxygen until early call for a help, until early help is arrived. So try to maintain the patency as much as possible of the airway. I think I have answered the question, is it? So are there any other questions? if it is no other questions, so we can move into the next. And the airway maneuvers and the anaphylaxis, there will be a separate two lectures. One from today, airway management, and anaphylaxis will be talked in tomorrow. Thank you very much. I think you have had a going to be enjoyable day for you. Thank you very much. Thank you, Dr. Roshan.
Thank you, Dr. Harini, consultant anesthetist, for the detailed, comprehensive lecture, madam. Right. Thank you once again for waking up early and giving the lecture. I think it's about 4 o'clock in the morning in UK. Right?
Yes, it's 4:30 a.m. in the morning. So
Yeah.
I'm just waking up and doing the lectures for you. Thank you very much.
Thank you very much, madam. So next up is a lecture by Dr. Livon Karivasan, consultant anesthetist at TH Anuradhapura on monitoring. Over to you, sir.
Okay, give me a second. Visual history. Good morning, everyone. Can you hear me? Hello.
Yes, sir. Can see and can hear you, sir. You can continue.
Okay, my slide also you can see, no?
Yes.
Okay, good morning. I'm Dr. Livon Karivasan, anesthetist in Anuradhapura Hospital. My topic is ICU monitoring. Okay. First, we'll go through our objectives. Okay. Our objectives, why important in the monitoring in the ICU. Okay. And other thing is what parameters we need to measure and how frequent. Okay. And how to incorporate our monitoring and the assessment into the management. Okay. And what essential parameters act upon. Okay. These monitoring and vital signs we should need to integrate into our daily assessment and the monitoring. Okay. Importance of the monitoring. We can early recognize of the deterioration patient. Okay. There is a very rarely that's a sudden cardiac arrest can develop, but before that, most of the time, more than 90%, we can see the patient gradually deteriorating. Okay, there's a rapid deterioration also. We can, if more frequent monitoring, then we can detection this deterioration patient, and we can make a plan and management, and we can intervention early. Then that we can monitor that patient response to our management or intervention. For example, if we start the low blood pressure patient, give the IV fluid boluses, blood pressure improving or not, and we can start the iron probes. Like that, we can measure that also. Okay. Parameters, we need to maintain the monitoring chart. ICU there's a different monitoring chart we are a different monitoring chart they are maintaining, but all the monitoring chart contain the same thing, but a different chart. Okay. And clinically, what we can measure, respiratory rate, pulse, and like that, blood pressure, we can several parameters we can measure. Other thing is the equipment. With the equipment also we can enter in the ventilator. We can use to peak airway pressure, and the respiratory rate also we can measure. And other thing is how much FiO2 need, like that. Another thing is investigation. Investigation also biochemically we need to measure, and sometime we can do the blood gas, and we can check that parameters, and other thing is a capillary blood sugar, and we can send to the lab also, and daily we can take the that investigation report also. These monitoring chart that even though we use, we need to what parameters, all the parameters no need to measure, and the frequency also we can change. Most of the time ICU patient we hourly we document the measurement, but sometimes we can need to increase the frequency. For example, if the inotrope patient, we need to continuously monitor the blood pressure, but if not, that we can check the blood pressure every 5 minutes. Like that, we need to individualize. And the target also, that for example, if patient hypertensive patient, we need to go a little bit higher blood pressure. If not hypertensive patient, we can go a little bit lower pressure. And the map, for example, septic patient, we can go to the target 65, like that. Okay, if hypertensive patient, we need to go a little bit higher blood pressure. According to that, we need to individualize that target and the monitoring frequency. Okay, each ICU bedside there's a multi-monitor. Okay, and we need to measure the physiological parameters. Okay, and with this multi-monitor, we connect that the electrode and the sensors, and we can take a continuously a measurement. That we can check cardiac electrical activity via that ECG lead. Okay, normally we are using three lead ECG to monitor, and that 3 lead ECG monitoring, and with that we measure the lead 2. Another thing is sometimes with the ECG lead, it will give the respiratory rate also, okay, in the multi-monitor, and but it's not accurate, but with the capnometer or the ventilator, more accurate. Okay, another thing is the blood pressure. We measure that with the 2 methods. One thing is invasive and the non-invasive. Okay, and we go to more detail later. And body temperature also we can measure. There's a thermistor in the multi-monitor. We can central we can measure using the posterior pharynx insert in the via the nose, and yes, peripheral also we can measure keeping the axilla. And other thing is a cardiac output. Okay, cardiac output we need to special monitor, and with that we can connect the arterial line. There are several methods cardiac output monitoring, PICO, LITCO. We'll discuss that also. And other thing is a saturation. Okay, pulse oximeter we are using for measure the saturation in arterial, that it will give the pulsatile wave saturation, then it will, that means arterial saturation. Okay, that also we discuss. And carbon dioxide give that the capnography, and it will give the wave and the end-tidal carbon dioxide also. Another thing is that ventilator we need to set the alarm. Okay, then if there's a patient deteriorating, then that monitor give the alarm, then we can give the quick attention that the nurse, otherwise that patient so that we are monitoring and deterioration we can't detect. Then when the monitor give the alarm, then we can go and assess the patient. Okay. Okay, this is the multi-monitor picture. You can see that first that show the ECG. Normally we are using the lead 2. Okay, lead 2 we are using. Why? It will show that the cardiac arrhythmia easily. Okay, and after that it will give the heart rate, and that the saturation. There's a group, you say that the wave, and it show the saturation 98, and it give the heart rate also 79. This is same. Okay, after that arterial blood pressure, this get from the invasive arterial blood pressure. That means we insert the arterial catheter, and via that that give the waveform beat to beat, that wave, and the here that blood pressure systolic and diastolic, and the map also it will give. Okay, And after that, there's a pulmonary artery pressure, CVP line. It also give the waveform and actually the pulmonary artery pressure, and that's why it give the wave. And normally, we are rarely measure that this pulmonary artery pressure, and it also give the value. Another thing is EtCO2, that end-tidal carbon dioxide, it will give the 34, and the capnography waveform, you can see square, that means patient on the ventilator. That's why it's coming as a square, and it also give, and respiratory rate with the capnometer 11, that also give and more accurate. This is a mechanical ventilator patient monitoring rate. Okay, we go to the hemodynamic monitoring. Generally, we can measure the get assessment with the mental state. Why? That if the cerebral perfusion reduce, patient mental state deteriorating, and because of the cerebral perfusion reducing. Okay, if when reducing, the patient become confused, and more, then patient become unconscious. Okay, then we need to assess the mental state also. Other thing is a skin temperature. We can with the get assessment with the skin temperature, that peripheral become cold when the cardiac output low. Other thing is a capillary refilling. Capillary refilling, we can measure. We can press that finger bed 5 seconds, and then we can count 1 in 1,000, 2 in 1,000, like that. 5 in 1,000, then we can release and again calculate it 1 in 1,000, 2 in 1,000. Normally, that nail bed appear in the pink color less than 2 seconds. That means that patient had a normal cardiac output. If it's prolonged, that means patient had a low perfusion of low cardiac output. Other thing is we need to assess the pulse. Palpate in the radial pulse. We can calculate the count the rate and the rhythm and volume and character. Okay, if there's a low cardiac output, we can feel the low volume. Atrial fibrillation, irregular rhythm, we can detect like that. We can get the assessment. Another thing is a cyanosis. Okay, cyanosis, we can see that the peripheral cyanosis, if there's a low cardiac output, and if there's a low oxygenation, we can see the central cyanosis also. And pedal and the sacral edema, we can get the idea of the heart failure, and they can develop sacral and the pedal edema, and sometimes that can cause the low protein also. But we can get the hemodynamic assessment with the edema. Okay. Other thing is a lung crepitation. When we are auscultation, then we can see here fine crepitation, mainly in the basal area. That if there's a get worse, we can hear whole lung also fine crepitation. That means patient developing pulmonary edema by that heart failure. Then fluid accumulate in the lung. Okay. Another thing is we can use the equipment to measure the blood pressure, and the ECG we can use heart rate and the rhythm. Okay. Here that ECG, we are connecting the patient with the 3-lead ECG, and to assess the heart rate and the mainly rhythm. Okay. And if there's any rhythm abnormalities, then what normally we are using the previous, as I mentioned, lead 2, and we are monitoring continuously. If there's any rhythm abnormalities or any ECG changes, we need to take failed lead ECG. Okay, with this monitoring, we can't measure that any ischemia or that rhythm abnormality clearly. Okay. We need to take lead ECG, and we can request if there's a rhythm abnormality, rhythm strip also. Rhythm strip, it will give the little bit longer that strip with the lead 2. Okay, with that we can assess any abnormalities clearly. But in the monitor, we can't assess clearly, but we can detect if there's ongoing rhythm abnormalities. Okay. blood pressure monitoring. Why we need to monitor the blood pressure? One thing is that it is a very important thing is that it depends on the that blood pressure mainly determine the organ perfusion. Okay, each organ perfusion determine, but systolic and diastolic blood pressure we can measure here also that give, and the map mean arterial pressure. That the mean arterial pressure is the most important thing. Why? It calculated different calculation, but the monitor also give the mean arterial pressure, and it determine the organ perfusion mainly. Okay, then we can set the target map. For example, the severe septic patient, our main target is to maintain the mean arterial pressure more than 65. Then we can think that we can maintain the organ perfusion with that. Okay. There are two methods we can measure the blood pressure: non-invasive and invasive. Non-invasive, simple, that we can apply the cuff and connect to the monitor. It intermittently, no, most of the time it will we can get the 5 minute each 5 minute blood pressure. Okay. And invasive method, that means we need to insert the arterial that cannula. Okay. And we can measure the beat to beat monitoring arterial blood pressure, and we can take the blood also from this the arterial line to blood gas analysis. That all the patient no need to that ICU patient arterial blood pressure monitoring, but some patient need, and we can insert the peripheral insert the radial artery, and main indication is liable that blood pressure changes and the hemodynamic stability patient, and patient if in the iron probes, multiple iron probes, for example, ways of pressure, noradrenaline, like that, dopamine, like that. If patient, we can titrate when we are measuring the beat to beat, because a non-invasive method every 5 minutes it will give that during that period blood pressure changes we can't measure, but here that the beat to beat give, and we can titrate precisely using this intra-arterial blood pressure. Okay, and if we take need to take frequent blood sampling, then we can take blood from the this arterial line here, that there's a port we can aspirate and take the blood for blood gas or whatever the other investigation. But we need to take a little bit more blood and aspirate because there's a fluid column, no? Until the fluid column disappear, and blood also a little bit need to take out, and after that we can take the sampling. Okay, otherwise this this heparin saline also get contaminated and give the wrong lab value. Okay. Normally we measure using the line inserted in the radial artery. You can see that the line inserted into radial artery. Other thing is dorsalis pedis. Normally this site we inserted into the 20 gauge or less than that, less size 22. Okay, and you can see that it connect to pressure bag, and normally maintain the 300 pressure millimeter mercury, and it connect to this transducer. Okay, and we need to maintain this pressure. Why? It will give hourly 2 to 3 ml flush. Okay, very slowly it will release. Then this line get flushed and there's no clot developing. Okay, if there's this pressure reducing, then backflow can develop the clot. Here, and it connect to the monitor, and it will give the wave. Okay. This is the transducer here, you can see, and it connect the monitor. And normally that whatever the pressure that tension convert to electrical signal, and it will give the this line shift to, and because of this tension, actually it use the Wheatstone bridge. No need that much detail, because of the tension that the resistance change, and it will make this the waveform, arterial waveform. Okay. Other thing is we need to keep this transducer every time when we are the measuring mid-axial line and the fourth intercostal space. Okay, we need to keep transducer in this line. Otherwise, it will not give the correct value. Other thing is here this valve we need to open to airway, the air, that atmosphere. Then we need to press the 0 button. Then atmosphere take as a 0. Then we turn to arterial side and we can measure the blood pressure. Okay. We need to calibration that every shift. Then it will give the more accurate value. Otherwise, value get wrong. Okay. We need to calibrate. Okay. To 0. This valve open to atmosphere air, then it will take as a 0 when we press the button, calibration button. Okay. Arterial line, there are risks when during the insertion. One thing is a vasospasm, okay, and embolizations and the thrombosis during the procedure. Okay, and later can develop infection, bleeding, thrombosis, ischemia, aneurysm, and the hematoma. Okay. These are a lot of complications we can prevent when we are inserting. Before inserting, actually, we can do the, we call the Allen test. How do we do the Allen test? We ask to, with that the fist hand and press that the radial and the ulnar artery. And keep pressing the radial artery and release. Then we check that the arm get pink. We call that the Allen test. If there's a less than 3 seconds, that means ulnar collateral circulation adequate to maintain the arm perfusion. That means even though that radial artery occlusions, but ulnar side maintain the perfusion. Clear? Okay. Other thing is we can visualize the radial artery and insert it. And we shouldn't inject the drug into the arterial line because that can cause the hand ischemia. Okay. What happened recently? We don't have arterial cannula. Okay. Then we are using pink cannula, that vein, whatever they're using the venous cannula. There's a port to inject the drug. Sometimes diagnosis that it's inside the way and can inject the injecting port inside if there's exposed, and there's a chance of the injecting the drug via that. Then we should cover that whatever the injecting port when we are inserting the that venous cannula. Okay, try to find the arterial the catheter or cannula, but if we can't find, then we can't help. Then if you are inserting the IV cannula, you need to cover that injecting port and mention clearly this is the arterial line. Okay, and other thing is we need to check distal perfusion every 8 hours. Okay, other thing I need to tell that no need, don't insert the IV cannula in this area because there's an artery. And the other thing is anterior cubital fossa. Recently also there's a hand amputation in child, I think, because of that accidentally insert the cannula into the artery and give the drug, and hand get necrose and need to amputation. Okay. Yes. Still happening that also. Okay. Another thing is we need to measure the urine output. Okay. With the urine output, it indicator that the one thing is fluid balance and the kidney perfusion, and patient we can detect the any acute kidney injury. Okay, so that sometimes patient had a chronic kidney disease and can on top of that they can develop acute kidney injury. Sometimes what will happen that the renal perfusion also low, because of that sometimes patient can develop abdominal compartment syndrome, and because of the pressure renal perfusion reduce. That's why we need to measure urine output hourly, and we need to balance the fluid intake and the output daily. Okay, daily we need to balance and check positive or negative. Another thing is once I admit to ICU, that the cumulative balance also we need to check whatever the if patient in 3 days or 5 days, during that period also how much the cumulative fluid balance also, then we can take and get idea with the fluid overload or patient fluid balance. Okay. Other thing is we need to maintain urine output. Our target is maintain 0.5 ml per kg per hour. For example, 70 kilos. If we maintain more than 35 ml, then we can think about the patient had adequate urine output of renal perfusion. Okay. Other thing is central venous line, no catheter. This is a special line inserting into the large vein inside the body. Several vein we mainly use for catheter insertion. One thing is neck internal jugular vein. Okay. Other thing is just below the clavicle, we can insert the subclavian. We can get access subclavian vein. Other thing is femoral vein. But with the internal jugular vein and the subclavian vein, it catheter tip in the superior vena cava, we can use to measure the central venous pressure. Okay. Yes. That ICU patient, sometime we need to measure the central venous pressure, and it will give the right side pressure of the heart. Okay. It in the superior vena cava, there's the right side of the pressure transducer, because that the fluid column, continuous fluid column, no? Then we can take an idea of the filling pressure. Other thing is drug administration. Some drugs we can't give the peripherally. Why? That the vasoactive drugs normally, because of that the vasoconstriction. Other thing is parenteral nutrition. Some parenteral nutrition solutions hyposmolality. Then that whatever if we give the peripheral vein, that they can develop thrombophlebitis and the vein can get occluded. Okay. But some parenteral nutrition now they are producing that less osmolality, then we can use that peripherally also. But we need to give some drugs also central venous, because otherwise if we are giving the peripherally, that the irritation can go to thrombophlebitis. Other thing is a fluid administration. Okay. And some patient need to get access CRRT or the hemodialysis because of renal failure. For that, we need to insert a special large the double lumen CVP line, 11 French. Normally, that 3 lumen CVP line we are using for the insertion of the giving the drug and measuring the central venous pressure. That one is a 7.5, 8, sometimes 8.5 also available. Okay. And if sometime venous access, that means patient in the longer period in the hospital, that can cause the that they give the drugs in the peripheral vein, and sometimes because of antibiotic and the other drugs, they can develop the thrombophlebitis, and that vein get fibrosis, and we can't insert the peripherally. Then we need to insert the CVP line. But that when we are measuring the CVP line, normal spontaneous breathing patient, we can say 0 to 6, but we can't say that exact one value. We can't say it adequately pill or not. We need to take a series of the CVP value. With that, we can assess. And ventilator patient that we are using the positive pressure ventilation, then sometimes CVP 8 to 12 we can say acceptable, but single value we can't tell it's adequate or not, but we need to take a series of the value. Okay. Here also it picture show that how to measure the CVP central venous pressure, but now no longer we are using this fluid column. Yes, we can use this fluid column also, but no longer we are using, and we connect same way that the arterial pressure, the measuring same transducer, and measure the CVP also. But that transducer that positioning need to mid-axillary second intercostal space when we are measuring. We need to level that level. Okay, complications during insertions that and the placement, there are some complications can damage the vessels and the near structure. That internal jugular vein, next to that carotid artery, then carotid artery puncture can happen and the hematoma can develop. And arterial puncture also that can happen, that subclavian vein, then subclavian artery, femoral, then femoral artery. Like other thing is then we are inserting the neck, there's a pneumothorax. So pneumothorax can develop. Most of the time there's a subclavian vein when we are inserting, that can happen. Other thing is a cardiac arrhythmia. Cardiac arrhythmia can happen if there's a guide wire inserted too much, then it touches the heart in the right atrium or right ventricle, that can cause a cardiac arrhythmias. And catheter also, if we insert the too long, then can develop cardiac arrhythmia. Other thing is a air embolism, and that can prevent. Air embolism can prevent. How? When we are inserting, we need to keep head low position. Okay, because that if we keep the head up position, then there's a negative pressure can get sucked during the insertion, can develop air embolism. But if we keep the head low position, then we can insert it without complicating with the air embolism. Another thing is a thrombosis. Thrombosis also can happen. We need to frequent flush with the heparin saline, otherwise that the line get thrombosis. If we inserted too long, then there's a chance of the perforation of the other thing is that during insertion also superior vena cava can damage. If a catheter keep inserted too low, then right atrium and the right ventricle can get perforated. Okay, then cardiac tamponade can develop. Other complications, bleeding and the infections. When we are handling the CVP line, we need to use the sterile gloves and the hand washing and the yes, the strict aseptic condition. We need to handle the CVP line, otherwise they can develop infections. Okay, extravasation of the irritation of the gut. When we are inserting this CVP line also, that what we need to do, we need to use the ultrasound and visualize clearly that the vein. And once we inserted the guide wire, again we need to visualize that the guide wire in the vein. And after that we can dilate it and insert the CVP line. After insertion, what we can do, we can take chest X-ray and we can do the blood gas and confirm the placement. Things that may can affect the CVP value. Reduced CVP value, we can see intravascular depletions. Sometimes that the bleeding we can't see most of the time. What happened that the liver laceration or splenic laceration or gastric ulcers or the variceal bleeding inside the gut. Then we can't see the bleeding, but we can see the CVP dropping. Then we can think about the bleeding. Other thing is a fluid redistribution. Fluid redistribution can happen. That septic patient, what happened? That the fluid leaking out and vasodilatation. Capillary permeability also increasing, and the vasodilatation that can cause the fluid redistribution, and we can see the reduced CV. Okay, and okay, and we previous also I mentioned that the single value we can't take idea. What we can do, we can give the fluid boluses. Then we can see the CVP rising and reducing. Then that means patient had that fluid depleted. Okay, if there's a rising and stay there value, for example, if we give the 500 fluid boluses and CVP rise 6 and 8 stay there, then we can think about the adequate fluid. But if increase to 6, drop again, increase to 8 and drop again to 60, that means we can give the more fluid. Other thing is the increased CVP value, that the higher CVP value give, if we use in the ventilated patient, a higher P positive and expirated pressure, that it increase the intrathoracic pressure and it give the higher CVP value. It also transmit. Okay. And hyperdynamic circulation can happen, and right ventricular failure, for example, pulmonary embolism, that also can cause the right ventricular failure and give the higher CVP value. Tricuspid stenosis and the regurgitation it also gives the higher value CVP, and pericardial effusion and constricted pericarditis, and superior vena cava obstruction due to the clot or whatever the reason, then it will also give the higher value. Other thing is a fluid overload. Fluid overload also we can get the higher value, CVP value. Okay, respiration. What parameters we need to measure? Respiratory rate. Okay, respiratory rate is a most sensitive indicator on the critical ill patient, because that they are trying to maintain the body pH 7.4, then the saturation also. Then if there's a hypoxia or the acidosis, there's a respiratory rate can increase. Then if we monitor closely, then we can easily detect deterioration patient. Okay, all the ICU patients should continuously recording, and multiparameter can give that's a 15 give that respiratory rate, but it's not accurate, because of that it will take from the ECG value, thoracic impedance. Okay, sometimes it's accurate, but sometimes it's not accurate. Then we can take from the capnometer or the ventilator. It will give the correct value and the correct respiratory rate. Other thing is a pulse oximeter. Pulse oximeter, that device we are using to that display of the saturation of the arterial oxygen. How it measure that it uses the red and the infrared light both emitting that light high frequency, and it calculates the pulsatile waveform and calculate the pulsatile waveform saturation. Okay, other light absorption, they venous and not pulsatile, and if there's a the venous also pulsatile, then it will give the wrong value, but pulsatile wave it will give the value. Okay, other thing is that we can insert the into fingers, earlobes, and the toes. Okay. That yes, previously I mentioned that light emitting infrared and the red, according to the light absorption, it differ the oxygenated hemoglobin and the deoxygenated hemoglobin light absorption. According to that pulsatile waveform, that calculate the saturation. Okay. Normally, that saturation also that we can change our target ICU patient. We need to monitor the continuously, and if the patient not ARDS or the non-COVID patient, we can maintain the more than 94 saturation. If the COVID patient and the ARDS, we can think about the COPD patient also that more than 90. COPD patient we can go a little bit low, 88 also. And other thing is arterial, but gas will take that sometime that we can't measure that. Sometime that the reagent also not available, but with the saturation we can calculate the FiO2, and that sudden change we can detect with the pulse oximeter if patient desaturation. PF ratio, that means arterial to FiO2 ratio can calculate it and determine the severity of the lung conditions. Okay, with that value we can think that patient lung conditions. Okay, ARDS or acute lung injury also we can detect. Other thing is a capnometer. Okay, entire carbon dioxide we need to measure, and carbon dioxide we can that continuously it will give the waveform. You can see that, and it will give the respiratory rate and the entire carbon dioxide. With that, we can think adequacy of the ventilation, and that because of that, it mainly depend on the minute ventilations, and with that we can change the respiratory settings, increase the minute ventilations. If there's a higher ETCO2, if there's a low, then we can reduce the minute ventilation. Other thing is ETCO2 can drop suddenly, then we need to quick intervention. One thing is sun blood pressure drop, because that one blood pressure can drop because of low cardiac output, then the carbon dioxide taken to the lung reduce. And pulmonary embolism, that blood flow suddenly reduce that because of the pulmonary embolism, then carbon dioxide not going to the lung and the alveolar. And cardiac arrest, there's a suddenly drop we can see. And disconnection of tube dislodging. The main thing is that if that ventilator patient, we need to connect to ETCO2. Then quickly disconnection we can detect with this capnography, and it will give the alarm, and that the waveform also suddenly disappear. Then we need to quickly need intervention. Otherwise, patient develop later. The patient develop hypoxia and the cardiac arrest. Okay, ventilator monitoring, we can take respiratory rate and tidal volume. With that, we can give the minute volume also, and the FiO2 and the airway pressure, peak airway pressure, and the mean pressure, and the peak pressure also. It will, whatever the settings, it will give the peak pressure also. Okay. Mainly, we are that the tidal volume should target at 6 ml per kg ARDS patient, but we can range 4 to 8 with the ideal body weight, not the his actual body weight. Ideal body weight we need to calculate using the height and the gender. Okay. Another thing is FiO2, we can need to titrate with the saturation. Previously, I mentioned that maintain the desaturation more than 94 or more than 90. Okay. And if there's a sun drop, that mid ventilation or the tidal volume, and increase the air pressure, that means tube kinking, or there's a sputum plug or obstruction, or there's a tension pneumothorax also, same thing can happen, or lung collapse. Okay. Yeah, there's a sun air pressure increasing and the reducing the tidal volume, we need quick intervention because that patient can get deteriorated. Okay, advanced monitoring cardiac output, we can use a measure, help to measure the fluid response. Okay, and it measure that you can see that the stroke volume, stroke volume and cardiac output also, and the systemic vascular resistance, and it will give the lot of values. Okay, and with that we can assess the fluid response. Okay. Normally, there's a stroke volume variation value give, and with the stroke volume variation, it actually calculated. With the ventilation, it change stroke volume, and if they maintain stroke volume less than 12, that means patient adequately feel. If there's a more than 12%, that means patient fluid response. We can give the more
excuse
fluid. Okay.
So you have another few minutes, sir.
Okay.
Okay.
Okay. Other thing is that heart rate, that actually it will give the cardiac output. Normal range we can say 4 to 6. And other thing is that we can calculate the cardiac index, normalize that one, that the body size 2.5 to 4.2. Okay, and cardiac output need to that with the, when we are using the vasopressor or iron drops, and the complicated heart surgery also we can use that. And systemic vascular resistance also give that the cardiac output when we are measuring. Actually that we calculated, and we can think about the giving the vasopressor using the systemic vascular resistance. Okay. When patient deterioration unstable, we need to quick intervention, that blood pressure dropping and the heart rate reducing or increasing, and cardiac arrhythmias, and dropping the respiratory rate or pricing, and saturation dropping, and the capnography change. Okay. Neurological, we can use the GCS and the ACVPU. ACVP means alert, confusion, response to voice, response to pain, and unconscious. Quickly we can use that one. Other thing is a Glasgow scale. We can use eye opening and base verbal response and the motor response. With that also we can assess the GCS, that neurological response. Other thing is a pupil reflex also we need to measure. And when we are using the sedation, we need to use the sedation score, Richmond agitation sedation score or scales, and our main target is to maintain 0 to -2. Okay, positive mean that the patient fully awake and combative, and minus mean that a deep sedation and unresponsive. Main target is 0 to 2 we need to maintain. Other thing is a pain assessment. Intubation patient, we can't assess the pain. We can't ask that verbally. Then we can that the behavioral pain scale we can use facial expressions, upper limb, and the compliance with the ventilation. Then we can give the value and assess the pain. And we need to address the pain before increasing the sedation. Every day we need to use the this fast heartbeat. You can see that it's a mnemonic. We can use the fast heart. Every day we need to think about the feeding, parenteral or enteral. If there's we can feed enteral, then we need to enteral. If we can't, we can think about the parenteral. Analgesia and the sedation. We need to start the sedation ventilated patient. Thromboprophylaxis, yes, we need to start enoxaparin, prevention of the deep vein thrombosis. Head up position to prevent the VAP ventilator associated pneumonia. Head up position or tilt at least 35 degrees. Also prophylaxis, yes, proton pump inhibitors we need to use, and glycemic control we need to think about every day. That the spontaneous breathing trial, we need to every day stop the sedations and think that patient suitable for extubation or not. Another thing is a bowel care, that the bowel opening or not, we need to think and giving the things. Indwelling catheter, every day we need to think about the whatever the catheter, that means CVP line or urinary catheter or the ICT, whatever the drain, if we are inserting, we need to think, is it need or we can take out, otherwise it can cause the infection. Other thing is a drug de-escalation. We can do that blood cultures and whatever the suspect of urine culture or the sputum cultures, and that we can narrow down the antibiotic de-escalation and stop once that that patient infection free, and iron prop also we can reduce if there's a blood pressure increasing. Other thing is we can use the deterioration patient ABC assessment. There are a few things that we need to quick intervention, that they are there's an obstruction stridor and dropping is EtCO2, and previous always mentioned respiratory rate tachypnico, reducing respiratory rate, and saturation reducing with the FiO2 60, and tachycardia and bradycardia, and the systolic blood pressure reducing or urine output less than 0.5, and neurological deteriorations reducing the GCS, and if patient develops seizures or the hypoglycemia. Okay. Other thing is that infusion pump that we are using, and it's special pump that infusion we give the IV medication and the IV fluid, and we can program that whatever the rate we need to give the IV fluid or the medication, and closely we can control. Okay, a pump is a very reliable, and if there's any error, it will give the alarm, and we can check and do the intervention. Okay, any questions? Any questions? Do we have any questions? Hello? Hello?
Yes, sir. Right.
No questions. Oh, do we have any questions?
Yes. You can use chat box, or you can unmute. Right. So thank you very much, sir, for the detailed lecture. So
then we conclude the sessions. Okay. No questions.
So we'll go to the next lecture by Dr. Abhila Jayasinghe, consultant anesthetist on acute respiratory failure. Over to you, sir.
Hello, can you
Yeah.
slides? Hello, good morning. Can you see my slides?
Yeah, can see, might have to do it full screen. Okay, that's better. Yeah.
Right, okay. Right, okay. Very good morning to all of you. I'm quickly going to sum up about the acute respiratory failure, especially what is important to you as interns, right? What you have to know is just a bit of physiology of acute respiratory failure, but more importantly, if a patient comes with acute respiratory failure, how you're going to identify that patient and initiate the initial management of that patient, right? Okay, so what is respiratory failure? So if we take the respiratory system, you can see the respiratory system as basically two units. One unit is a gas exchanging unit where carbon dioxide and oxygen diffuse. And the other unit that sometimes you might forget is that the respiratory system is working as a ventilatory unit. So the chest wall and the ribs, the diaphragm, and then the lung mechanics works in such a way that we breathe in and expire the carbon dioxide. And that is how we make sure that our blood carbon dioxide levels are within the normal range. So we have an oxygenating unit as well as a ventilatory unit, right? So if there is a failure in one of these or both of these systems, then it is a respiratory failure, right? So to sum up, we can say the respiratory failure is inability to maintain gas exchange within the normal range, right? So it can be either an oxygenation failure where we cannot maintain our oxygenation within the normal range, or it is a ventilatory failure where the carbon dioxide goes up, right? So because of these two, separate units, the respiratory failure classically is divided into two, as type 1 respiratory failure and type 2 respiratory failure, right? Type 1 respiratory failure is basically there is a problem with oxygenation. There's an oxygenation failure that is by the blood gas, or you can actually measure the saturation as well if you do not have access to the blood gas. Where the PaO2, when you do a blood gas, PaO2 is less than 60, then you identify it as a respiratory failure. But say if you have already started on oxygen, the patient is 15 liters of oxygen and now of PaO2, it doesn't mean that there is no respiratory failure, right? Because this is actually, this value is taken as a baseline if the patient is ventilating on air, breathing room air, and the saturated and the PaO2 is less than 60, then the patient has a respiratory failure, right? Type 2 respiratory failure is problems with the ventilation. So the carbon dioxide levels goes up, and carbon dioxide level usually go beyond 50, and you call it type 2 respiratory failure, right? For you to diagnose this, you of course have to have a blood gas analysis. Otherwise, you cannot diagnose type 2 respiratory failure, right? And sometimes these two coexist, especially in patients with COPD, or even like, even in a patient with pneumonia or some lung pathologies, when it is very, badly affecting the lungs, there is increase in dead space and VQ mismatches and all those things, which makes the patient have both respiratory failures, right? Now, if you just, search in internet or even in your lectures when you were at medical school, sometimes you might have heard 4 types of respiratory failure. This is also like, commonly used in classification, but not the classic classification as such. Type 1 respiratory and type 2 respiratory failure, we have already discussed. Type 3 respiratory failure is a perioperative respiratory failure. Actually, this is a subtype of respiratory failure, but commonly, post-operative patients have desaturation due to numerous reasons, which we will describe. So that is sometimes taken as a different entity. And type 4 respiratory failure is very important, even though sometimes there is no problem in the lung, there's no problem in the ventilatory unit. Sometimes the patients might desaturate. For example, classic example is massive pulmonary embolism. The reason is there is no enough blood supply into the lungs to cause adequate gas exchange. This causes desaturation and hypercapnia. That is taken as type 4 respiratory failure, right? Right. So now we will go to clinical cases, right? A 54-year-old lady with diabetes, she presents with 3 days history of fever, cough, and worsening of her difficulty in breathing, and your consultant, you are the house officer, and your consultant asks you to assess this patient, assess and tell the boss whether this patient can be taken to the ward or whether the patient is so sick that the patient needs to be referred to the intensive care unit. So you're going to assess this patient. What are your thoughts? How are you going to assess this patient? Dr. Harini has already described how you're going to assess a patient who is critically ill. How would you assess? According to the ABCD approach, right? So these patients are critically ill. So assessment and resuscitation should go hand in hand, and you should stabilize the vitals while taking, detailed history and taking bloods for further investigations, right? So in your assessment, what you should mainly focus when it comes to respiratory failure is to see whether the patient is hypoxic, hypercapnic, and how badly they are hypoxic and hypercapnic, and how badly they are trying to breathe, like, how their work of breathing is, right? And are they tiring or are they still in the compensatory mode, right? So these are the basic things that you want to have a look that will tell you, or that will gauge how badly the patient is in respiratory failure, right? So patients might be agitated, or they might be just drowsy, there might be cyanosis, right? And because of the hypoxia, hypercapnia, they will have increased sympathetic surge, so they will be tachycardic, sweaty, hypertensive, and because they are working so hard to breathe, they will show use of accessory muscles, right? Intercostal indrawing, tracheal trunk, nasal flaring, all these signs and symptoms suggest that the patient is trying their hard to breathe. So they are in respiratory failure, and there is a risk that the patient might deteriorate, okay? Right, so our patient was conscious, talking and maintaining airway, but the respiratory rate was 34, tachypnea. Patient is having sweating as well. That is to say, patient is working quite hard to breathe, isn't it? And there is reduced chest expansion on the right side, and the patient is using accessory muscles as well. And when you auscultated, there are bilateral creps, more creps on the right side. And you put the saturation probe and you find the saturation is 84. You are worried. So at the same time, you put some oxygen and the saturation peaks to 94. Cardiovascular system seems to be fine. You have put a cannula, taken blood for investigations, and also you send a sample for blood gas analysis. And patient's conscious level fine. Patient is pyrexial, and you are awaiting your investigations. Right? At this level, what are your differential diagnoses? The patient is having fever and crepitations and reduced chest expansion on one side. It's likely that the patient has pneumonia, which can be bacterial or viral, any infections, right? Or it can be pulmonary edema with acute heart failure, maybe a patient having a pulmonary embolism and desaturating. And pleural effusion is also a differential diagnosis, or maybe patient having lung collapse, patient having some secretions blocking the bronchi and having a lung collapse. The other less likely causes, pneumothorax, also can cause desaturation, lung bleeding into the lung, or we don't know, maybe this patient is having asthma or COPD and an exacerbation, right? So these are the things that are running in your mind now when you're assessing this patient. Now you are going to narrow down your differential diagnosis with your investigation. So you sent a ABG, you have ordered a chest X-ray, going to do a 12V DCG because one of the differential diagnoses is pulmonary edema. So you want to see how the heart is doing. And you are thinking of an infection, so blood investigation sent. Sometimes most of the teaching hospitals now have a ultrasound machine, so you can do a bedside echo to see whether the heart is functioning well or there's fluid collection in the lungs, right? Other bedside peak flow meter, especially in patients with asthma. But bronchoscopy pulmonary function tests are not to be done in an acute stage. But CTPA, CT chest can be done in an acute stage, especially if you CTPA, especially if you suspect a pulmonary embolism. Right. Coming back to our patient, patient's blood gas is with you. You can see the PaO2 is 56. So on room air, if it is less than 60, the patient is in type 1 respiratory failure. But carbon dioxide is 24. Normal carbon dioxide is roughly 40 to 45. So why do you think the patient's carbon dioxide is low? That is mainly because the patient is now trying to compensate for the hypoxia by breathing fast, and the patient is washing out carbon dioxide. So carbon dioxide is low, right? And lactate is fine. Base deficit is not too much of a worry. And in the chest X-ray, you can see that there is a consolidation patch in the right, middle, and lower zone, right? And WBC CRP is also high. It is highly likely that the patient is coming with a right-sided lobar pneumonia and having type 1 respiratory failure, right? So how are you going to treat this patient until your boss comes? So you have to treat the oxygenation failure by, you can start with giving oxygen, right? So there are so many options for you to give oxygen. Your target here, you should know the target, right? Your target here is to maintain the saturation more than 94. If you can maintain more than 94, you're fine. So you can start with 15 liters non-rebreathing mask, but when you have the saturation probe and the blood gas analysis on your hand, you can just wean oxygen to achieve a saturation of 94. I'm not going to discuss about all these devices because you will have a lecture about oxygen therapy later. But if this is a patient with carbon dioxide retention, like, COPD patient, your target saturation is 82 to 92. As you might remember that they have a carbon dioxide driven respiratory stimulation for breathing. So, hypoxia driven stimulation for breathing. So you should not increase their saturation level more than 92. Right, so you have started giving some oxygen. Now you're addressing your type 1 respiratory failure and you have to treat the cause, right? So the patient should be prescribed on antibiotics, give some chest physio to drain the secretions out and clear the lung, give some nebs to open up the bronchi. And sometimes if they are fluid overloaded, the patient might benefit with some furosemide. And if there is an effusion, you can drain it. And you can do a bronch, especially if there's a collapse, and take some sample and, lavage. These are like, not in this patient, but if the patient deteriorates, okay? Right. So moving on to the next patient, it stays again a 56-year-old gentleman coming with ischemic heart disease, history of ischemic heart disease, this time coming with difficulty in breathing. And you find that the patient's respiratory rate is high. There are bibasal crepitations and saturation is 88 on room air. And he is quite hypertensive as well, right? So given the chest X-ray and the clinical history, it is highly likely this patient is coming with acute pulmonary edema, acute cardiogenic pulmonary edema, most likely because of the cardiac history and hypertension. And patient is in type 1 respiratory failure, right? This is why I said sometimes bedside echo is very useful. You can see here that this is the left ventricle. The left ventricle is barely contracting. So the patient is having heart failure and pulmonary edema. Okay. So how are you going to treat this patient? Give some oxygen, deload the patient with furosemide, start a venodilator to control the cardiac, inflow to the heart to reduce the preload. And also it will help to control the blood pressure as well. If the patient is agitated, give some morphine. And if the patient's still not improving, you can contact your seniors to start on some CPAP. Okay, right. I'm going to stop the physiology for the time being because we are a little bit running out of time. Okay, so our patient with pneumonia, on the next day, you remember our very first patient, right, with pneumonia. So you have treated with some oxygen antibiotics. And the next day you see the patient next day morning and you see that the patient's condition is deteriorating. He's still tachypneic despite of oxygen saturation is dropping and patient is exhausting. Patient cannot cope up with the desaturation anymore. He is exhausting, right? the blood gas is now pH 7.27. Patient is becoming a bit acidotic, and PaO2, of course, less than 60, and carbon dioxide has also started to rise. Now there is a type 2 respiratory failure also adding into the picture, and that is causing a bit of acidosis. And the patient's lactate level is also going up probably because patient is now tiring, and also the desaturation is a reason for the high lactate, right? So what do you think now? What do you think? Will this patient be okay to continue just oxygen and antibiotics, or do you think something more needs to be done to this patient? So this patient seems like the patient cannot cope up anymore. So you need to provide some support for the respiration from an external source. You can give mechanical ventilatory support, either as an IV or invasive ventilation. That is where you put a ET tube down and connect the patient to a ventilator, right? You can always start with NIV, but if the patient's GCS is less than 9, if the patient has impending airway obstruction, or the patients who are have progressive neuromuscular disease and their vital capacity is dropping and they cannot cough and they cannot protect their airway, they usually end up being intubated. And severe cardiovascular compromise or patient getting exhausted, these patients are very unlikely to be improving with NIV. They will ultimately end up intubated and ventilated, right? So our patient is exhausting, as you can see. So we will have to start some mechanical ventilatory support to improve the patient's oxygenation as well as ventilation and to maintain normal blood gases. Okay. Right. This is another patient, 13-year-old girl is now admitted to the ETU with after 5 hours of deliberate ingestion of some tablets given for her grandmother for cancer pain relief, right? And the patient's pupils are pinpoint, GCS 7, very bradypneic, respiratory rate is 6, but lungs are clear and hemodynamics are fine, but saturation is also 90. So what's happening here? There is probably the patient is has taken some opioids, probably some morphine, and in overdose, and it is causing respiratory depression and bradypnea. And as a result, what has happened? You've done a blood gas, pH 7.12, quite acidotic. Saturation is also low, as you have already noted with your finger probe. Carbon dioxide 86. The patient is retaining carbon dioxide. So this is to say patient is now in type 2 respiratory failure. But on top of that, of course, there is a mixed respiratory failure because the patient is having hypoxia as well, right? So what is the problem here? The patient's respiratory rate has dropped. As a result, patient's minute ventilation drops and the patient cannot clear out the carbon dioxide. When a lot of carbon dioxide accumulates in the lungs, you might remember the oxygen cascade you learned when you were doing physiology. A lot of carbon dioxide accumulating in the lungs and the saturation also now starts to drop, right? So what are you going to do to this patient? Patient's GCS is 7, not breathing. It is very obvious that the patient will need intubation and ventilation. And we luckily have some antidotes for morphine, which is naloxone, and we can treat with naloxone. And when patient is breathing fine, when the conscious level is normal, we can extubate the patient. Okay? Right. Right. So this graph, this is, I'll just show you this graph. You can see this is the ventilation, minute ventilation. When the minute ventilation increases, the carbon dioxide levels drop, right? So when the minute ventilation drops, the carbon dioxide levels are high. And at the same time, you can see this is the PaO2. When the patient is not breathing well, when there is hypoventilation, you can see that the PaO2 also drops, right? So That is why there is mixed type 1 and type 2 respiratory failure in advanced type 2 respiratory failure. Okay. Moving on to next patient, 74-year-old male who is a chain smoker, non-COPD patient, coming with shortness of breath and fever. It is likely that the patient is having COPD exacerbation. And patients, there's obvious bilateral V's and crepitation, saturation is 82, right? So you do a blood gas, there is desaturation and hypoxia, hypercapnia. And this patient needs some oxygen to maintain the saturation in normal level. But what is the important thing about giving oxygen? The patient oxygen target should be 88 to 92, right? Okay. And the underlying problem looks like infection, so you start treating with some antibiotics as well, but you're a little worried about the carbon dioxide level as well. The carbon dioxide level is high. So with this patient is very likely will need some NIV support to improve the minute ventilation. You give some support, some pressure support to the patient's normal breathing to increase the patient minute ventilation and get some carbon dioxide cleared, right? So you will sometimes, some hospitals in the wards, they might have BiPAP machines. So you will start the patient on BiPAP or you will refer the patient to the intensive care unit for NIV support, right? Okay. Right. Just one slide about another patient. This is a 65-year-old lady coming after a surgery and complains of quite a lot of pain at the surgical site. Hemodynamically stable, but bit tachycardic. Patient is not breathing fine, probably because of the pain. And the patient has had a nephrectomy, so there's an abdominal incision as well. Saturation is quite low, 86 on room air, right? So this patient is having what we initially called as perioperative type 1 respiratory failure, perioperative hypoxia. So what are the causes for this perioperative respiratory failure? This patient is in pain, so patient is not breathing enough. And there is quite a lot of atelectasis. One reason is patient had the general anesthetic, and now the patient is not breathing because of the pain. There can be, diaphragmatic splinting, and the patient might have some secretions which he finds difficult to clear because of the pain. And all these things add together to cause respiratory failure, type 1 respiratory failure. And quite common, especially when you are doing your surgical rotations, you will come across patients like this. So what you should do, of course, you should start with giving some oxygen to treat the desaturation. But more importantly, these patients need incentive spirometry, chest physiotherapy, and very, very importantly, you have to control the pain. You have to give adequate analgesia, preferably opioid-sparing analgesia, to make sure that they are breathing fine. Keep them propped up. If there are fluid collections, let them drain, and ensure they are adequately hydrated but not overhydrated. Okay. Right. So my last slide. So respiratory failure is quite common. You will always encounter these patients when whatever the appointment you will be doing. And what is very important is to identify these patients and to gauge how severely they are affected and initiate the initial investigations like blood gases, chest X-ray, ECGs and stuff, and identify the cause and the type of the respiratory failure they have, because that will determine the treatment pathway. Okay. That is what we expect from you as interns, and we wish you all very good luck during your internship. Okay. Thank you very much. Do you have any questions? Do you have any questions?
Madam, is there any possibility that you could leave these notes to us?
The slides.
Yes, slides, please. They're
Okay.
very beneficial.
Okay, right. I'll send the slides across to the coordinator so he can send you across all these. Huh?
Thank you very much.
Okay, all right. Everything clear? Good.
Right. Thank you, madam, for that comprehensive lecture. So next up, I think Dr. Prabhat Dayaratna. Yeah, Prabhat Dayaratna, consultant anesthesia, DJ at Matale, topic of atrial blood gases. Over to you, sir.
Can you make me the host now? I need to share my slides. Hello? Can
Yes,
you
sir,
all
we
hear
don't
me?
see the slides yet.
All right, okay. Okay. Good morning to all of you. So my name is, first of all, can you all hear me? Yes or no?
Yes, sir.
Right, okay. Right, good. So my name is Dr. Prabhat Dayaratna. I'm consultant anesthetics working in Matale Hospital. So this is regarding the interpretation of blood gases. So this is actually, if I talk about the theory, I could have gone on for hours and hours telling you about the theory. But I'm not going to talk about theory. So I will give you how you interpret a blood gas in a ward setting. So that's what that's the aim of this lecture. So if you have any question, please free to raise your hand then and there. So don't wait until end of the lecture. You can interrupt me at any point and you can clarify the point that you want to clarify then and there. So I hope you are clear up to now, right? So few information to start with. The pH is the negative logarithmic value of the hydrogen ion concentration in the blood. So
You need to make
sure
this
you all know.
full screen.
It is full screen now. Hello? Isn't it full screen now?
Not moving, sir.
I don't know. I really don't know why it's so. I have make it full screen here.
Shall we close it and share it again?
Right, sure.
It's okay. But not full screen.
Is it
It's okay, we
now?
go by this.
Right. It's me. How is it now? Same? It is full screen here. What's the problem now?
Now, okay, sir.
Now it's okay, right? Fine.
Yes, sir.
Right. So then these are the few information that you need to know. So that is the first thing is the pH. You know, it is a negative logarithmic value for the hydrogen ion concentration in the blood. So then we have PaO2, that is partial pressure of oxygen in the arterial blood. The PaCO2, it is a partial pressure of oxygen, carbon dioxide actually in the arterial blood. SaO2 means the percentage of the hemoglobin saturation. That is then so there are the other is bicarbonate, lactate levels, and so on and so forth. And so you will know as we go on with the lecture. Wait, second now. Yeah, please say it, sir. Right. So these are the objective. So first is how you correctly take an arterial blood gas sample. So then how you're going to interpret it, and finally, how you are going to come to a diagnosis and how you manage. So this would be my objective of the lecture. So, right. So tell me, so why you need to do a blood gas? Right. Anyone can talk here. So what are the indications to do blood gas? So there are 300 and actually you can talk rather than time. So there are 373 participants. But none of you are talking.
So what we should do is we'll stop your video and we'll close the presentation and open and reshare it again. Might work. So.
All right, might work. Okay, right. Okay,
Must be
fine.
issue with the signals.
So shall I log off, leave and come?
No, not necessarily.
Right.
You
Okay.
stop your video.
Right. Okay. I stopped the video. Right. Fine. Did it.
You share it again, sir.
All right. Okay. Right. How is it now?
Now much better. Yeah.
Now, right. Okay. Right. Good.
Right. Need to make it full.
So it's a full screen in my. Isn't it full screen?
No, it's okay. So we go without the full screen, minimize screen.
Right.
We go by that. I think there's a connection issue from Atali, I think.
Yeah.
Go by that,
due to a connection issue, I really don't know what's happening. So
now we can see objectives. Yeah.
Is it full screen now?
No, sir.
Still, it's not full screen. I don't know. But anyway, so I don't know what is. So from my side, it is full screen. I don't know why it is not becoming full screen on your side. But anyway, so
okay, so we go by this.
I will go on. Right. Okay. So then these are my objective, and so the uses of the arterial blood gases. So first of thing, it is to establish the diagnosis. So we do blood gas in several situations. For example, so if you think the patient has any sort of acid-base disturbance, like in sepsis, or if you think some sort of other form of metabolic acidosis, or if there are problem with the patient oxygenation, so you can do a blood gas and see. And so this gives an idea about that you can formulate a plan, treatment plan. And so then this will aid in the treatment. So if there is a respiratory issue, you can adjust the ventilation. If there is acid-base problem, you can do necessary treatment there. So then, of course, you can use the blood gas to assess the response to your treatment. So these are the indications or the uses of blood gas analysis. So this is, and I'll tell you one very important practical point here. So, and I have seen the people send blood gas to the ICU just to check the serum electrolyte. Please don't do it, because the serum electrolyte, so you can of course do it again, do it from the lab, and you can send an urgent sample. But doing a blood gas just to see the serum electrolyte is not acceptable, because this is a very expensive investigation, which we can use for a needy patient. So because of that, actually, so I have always asked that, so when you are sending the blood gas to the ICU, you have to clearly mention the indication why you are doing the blood gas. If the indication is not clear, we will send this blood gas, the sample, back to your ward. Right. Right. So then the preparation. I'm sure as medical students, most of you have done at least one blood gas sampling. So first of all, you need to exclude the contraindications. There are many actually. So the local sepsis. So if you think there is arterial occlusion distally, so those kind of things, so you don't really do arterial. But so then once you exclude the contraindications, and bleeding is not really bleeding tendency is not really a contraindication. You can of course do it and apply direct pressure for 5 minutes. That will most of the time settle the bleeding. So you need to have a small syringe, preferably insulin syringe 2 ml one. Then you need to heparinize this syringe. So use 0.5 ml of heparin, so undiluted heparin. And the sites are commonly we use radial artery.
Thank you, sir. We are still on the objective slide. Are you moving or the same slide?
Yeah, I have moved. I don't know what's happened. Yeah.
It's not moving, sir, I think.
Is it moving?
No. So can you move, exit from the full screen and come to normal half? Yeah.
Right. Yeah. Now I'm
Now
in
is
the
use of ABG analysis. That's easy, I think.
Right. Okay. Right. Okay. So. Right. Now, can you see the preparation slide? What can you see now?
Yes, I can see preparation. Yep.
Yeah, preparation. Right. Okay. Yeah. I will make it. So shall I do it? Continue like that. It will be half slides actually. I mean half screen. Is it all right?
Yeah. It's okay.
Yeah. So I have make it full screen now.
Don't make it full screen, sir. We'll go the normal screen. Yeah.
Right. Okay. Yeah.
Preparation. We are on preparation.
Yeah.
Slide.
So that is a slide. So I'm talking now. So it is a preparation. So then, sorry, I'm actually sorry about these technical problems. I think so. There might be a signal problem in the Matale. So that's the only explanations I can think of right now. Right. Okay. So the side wise, so we usually go for the radial artery either side, or it could be brachial or the femoral. Those are the sides. So then, conscious patient, you need to explain the procedure to the patient, and it has to be a sterile procedure. And once you've taken the blood gas sample, so you need to send that sample. So you need to analyze it immediately. If not, you have to keep it at 4 degrees Celsius. So when you are sending the blood gas sample to the ICU, so you need to send with the patient details. So usual demographic details like patient's age, sex, all those things. And especially it is important to mention how much oxygen the patient is on. If it is not, if the patient is not on oxygen, mention room air. Then the temperature is also important, and hemoglobin level, because these things we need to enter into the blood gas machine for the correct measurements. Right. So once you send the blood gas sample, so then you get a blood gas report. So the first one will be the pH value, and it will be between 7.35 and 7.45 if it is normal. Less than 7.35 is acidosis, and more than 7.45 is alkalosis. Then the carbon dioxide will be between 35 to 45 millimeters mercury. In some other countries, they use kilopascal, but in Sri Lanka, we usually use millimeters mercury. So I will concentrate on the millimeters mercury. Right. Oxygen, this value, 80 to 100 millimeters mercury is for anyone breathing room air. Right. The bicarbonate value would be between 22 to 26 millimoles per liter. Then the saturation will be 95 to 100. The base excess will be either plus between -2 to +2 millimoles per liter. Lactate should be less than 2 millimoles per liter. And the serum electrolyte, we go for the same value, preference value as the lab values. Right. These are the steps in interpretation of an ABG. First, you have to determine the sample, whether it is an arterial sample or whether it is a venous sample. So after that, we need to determine whether patient has a normal pH value, or if it is not normal, whether it is acidosis or alkalosis. And so then what kind of acidosis or alkalosis, whether it is metabolic acidosis or respiratory acidosis. And if there is, are there any compensation, either respiratory compensation or metabolic compensation? So then we need to think about the gas exchange as well. So what is the, are there any problem with the carbon dioxide excretion, or is there a problem with oxygen? And so then we go for other parameters like electrolyte, the glucose, and the lactate. Right. So these are, so then, so we are in the determination of whether this is arterial or venous sample. So then these values are important to determine. One thing actually, so I forgot to include here is the saturation value. So it is SaO2. If you look at the SaO2, it will give an idea whether this is an arterial or venous sample. So arterial sample usually have a SaO2 more than 93%. If it is so, so you can you can say with 100% certainty that it is an arterial sample. The venous usually have SaO2 around 65-70, but if the patient is on added oxygen, this value might go up little higher. So remember that. Look at the SaO2. So then, so other thing like the pH value in venous sample, pH is slightly lesser than arterial. The carbon dioxide will be slightly higher. Oxygen will of course be low because the tissue has extracted oxygen, and the bicarbonate will also be low, little low. Right, so we'll skip that slide. And so I'm going to skip that also. Right. Yeah, we'll skip that also. Right. So on the previous presentation, Dr. Amila may told you about so she mentioned that talked to you about the respiratory failure, and I'm sure she must have told about how you diagnose respiratory failure using blood gas. So to reiterate what she has told, so to interpret the oxygenation, we need to know the percentage of oxygen that the patient is breathing. So that is we call FiO2, fraction of inspired oxygen. Right. So anyone breathing room air will have FiO2 of how much? What's the FiO2 in the room air? Yeah, it is 20. Yes, good, 21%. Right. Okay, it is 21%. Right. So then, so that is the lowest that is the lowest value, and others. So if we give added oxygen, so this the FiO2 value go up, and so we can go up to 100% of the oxygen. So you need to have you need to know this value to interpret the oxygenation. So as a rough idea, so what I usually get the oxygenation, suppose that if I say like that, so you look at the blood gas report, and the PaO2 value is 240. So yes, that number looks promising, but to interpret it properly, you need to have an idea about the percentage of oxygen that the patient is breathing. Right. Suppose that a patient is breathing 100% oxygen. Right. So then, so having a PO2 value of 245, what do you think? Is it adequate or inadequate? Anyone? Right. So, if the patient is breathing on a higher percentage of oxygen, so you need to so then you need to have a rough idea how much the PaO2 would be with that percentage. So so it is easy to calculate. So you just multiply FiO2 by 5, you get a rough idea about the percentage, the PaO2 value. For example, if the patient is breathing on 40% oxygen, the patient should have PaO2 of 200. Or if the patient is breathing on 100% oxygen, the patient should have a PaO2 of 500. So I said, so now the patient was breathing on 100% oxygen, but the oxygen was 245. So that means, so patient oxygenation is not adequate, even though number is good. So that you need to, so you need to look, you need to think about that as well when you are interpreting oxygenation. So I'm not going to go further because I'm sure Dr. Amila must have told you about those. Right, so A gradient, so I'm going to skip it. Right. We'll come to we'll talk about the respiratory acidosis. The respiratory acidosis happens when patients accumulate carbon dioxide due to whatever the reason. Right. Okay. So this the accumulation could be due to the several reasons. It could be due to central depression, maybe due to the drugs, head injury, or whatever. It could be some sort of a neurological disorder. It could be a mechanical problems like pain or rib fracture, or it could be the mechanical iatrogenic, something like so the patient being ventilating with a low respiratory rate. Right. So if this is the case, right. So how we are going to manage this? It is by addressing the cause. If it is a central depression due to a sedative like opioids, so we can give the antidote, that is the naloxone, and that will reverse. And other causes like the multiple sclerosis, Guillain-Barré, or the rib fractures, or the pain. So if it is pain, so we'll treat the pain, and some of these causes will need mechanical ventilation. So this is how you manage the respiratory acidosis. The respiratory alkalosis actually, so this is the opposite. The patient is breathing faster than normal due to the whatever the reason. So it could be like the psychiatric patient having the panic episode, they are hysterical, or the patient being ventilating with higher minute per ventilation. So here the treatment would be to address again address the cause. Right. Then coming to the metabolic causes of the acid-base balance. The metabolic acidosis, there are common sepsis, I would say, very high on the card. So it is then diabetic ketoacidosis, any cause that can give rise to hypolemia, diarrhea, or something like, or vomiting, or anything, even this blood loss, whatever due to whatever the cause, then can give rise to the metabolic acidosis. Metabolic alkalosis, of course, the loss of gastric secretions, sometimes over use of antacids. So then, like, or if you have used potassium waste in diabetes, so they can have metabolic alkalosis. Then the respiratory acidosis, we of course talked about the cause previously. Hypoventilation due to whatever the cause, the COPD, airway obstruction, drug overdose, chest trauma, pulmonary edema, etc. Respiratory alkalosis, we mentioned the cause, so I'm not going to talk it again. Right. So this is actually up to now I have not mentioned about the compensation, how the compensation will happen, how you are going to interpret the compensation. So before this summary slide, so we will talk about some blood gases so that you can have an idea about the compensation. Right? Can you all see this the blood gases? Right. I will make it full screen. Can anyone of you see the blood gas? I'm sorry. So somebody says you can't. Right. I really don't know. Wait. How about now? Can't you still see it?
Yeah, can see, sir.
Yeah, you can see now. Right. Right. Okay. So concentrate on the blood gas onto your left side. Right. What do you think this is? Right. Right. This one. So one, it was mentioned 3/26. So that's the date. So what kind of blood gas is that? So obviously it has acidosis, isn't it? Right. So someone mentioned it is metabolic acidosis. Correct. Yes, it is metabolic acidosis. Right. Right. Is there a compensation? No, no. Right. Right. So this is right. If it is a metabolic component, where would the compensation occur? Right. Somebody says partial compensation. Yes, I agree with that one. Right. So remember this. If it is a metabolic derangement, the compensation will occur in lungs. And if it is a respiratory problem, the compensation will occur in the kidneys. So this is the basics that you need to know, right? To this one. So it is a metabolic acidosis. I would say the severe metabolic acidosis. Body is trying to compensate, but compensation has not complete. So it is a partial compensation. Why would we say it is a partial compensation? Anyone has any idea why it is partial compensation? Yes, because the pH is still low. If it is fully compensated, the pH would have been within normal range. So here the pH is within it is not within normal range. So, but body has tried to compensate because the body has this patient was breathing spontaneously. The patient has increased the respiratory rate and so blowing out carbon dioxide and so try to bring the pH back towards the normal. Right. So this is the first blood gas is severe metabolic acidosis with very partial respiratory compensation. Right. The blood gas from middle, what do you think that would be? Any idea? So, right. So somebody has answered, we'll see. Right, it is yes, respiratory alkalosis. Yes, I agree with that one. It is respiratory alkalosis. So lactate is bit high. Other than that, actually other parameters are within normal range. So I fully agree with you. So that is a respiratory alkalosis. The blood gas on your right hand side, it is again like the first panda. It is a metabolic acidosis with the partial respiratory compensation. Okay, sorry about that. Right. So some more blood gases. Right. Can you see these blood gases? All right. So it is same actually. Sorry. Right. So can you see these? Sorry about this poor quality of blood gases, but so can you read the figures?
Bit difficult, sir.
It is bigger difficult, right? Okay. I don't know what's happening. Yeah, let me see. How about now? Is it still the
Yeah,
same?
much better, yes.
Much better now, right? Good. Right. So, okay, the first one, first blood gas. What do you think this blood gas tells you? First one is again on your left side. Anyone? Right. Of course, it is acidosis. I'm sure all of you will agree it is right. Okay, acidosis. Someone has answered. Partially compensated metabolic acidosis. Right. Why you said it is partially compensated metabolic acidosis? Right. So the one says metabolic acidosis with not compensated. Yeah. So that is somewhat correct one. Yes, it is a metabolic acidosis with not compensation actually. So the compensation has not started yet. So because remember the carbon dioxide is still within the normal range. So if it is a if there is a respiratory compensation, the carbon dioxide would have been lower than 35. Here it is within normal range. So this is a metabolic acidosis with without respiratory compensation. Right. Then the second one again, it is the same. Third one actually, so same again, metabolic acidosis. It, this one, this is same. Yeah, it is same. This one. Can you see it? Can you see it now? Hello? Can you all see the slide?
Yes, yes, can see, sir, can see.
Yeah, right. Okay. Right. Now, the slide, the AB on to your left side. What do you think about this one? Is right. Okay. Someone says partially compensated metabolic acidosis. Yeah, I would say yes, because you think because the carbon dioxide is low, so there is so I would say that yeah, if I say it is the metabolic acidosis which has not been compensated, but body is trying to compensate by blowing out carbon dioxide. So that is how I would say this one. This is a severe metabolic acidosis. pH is less than 2. So that is the severe metabolic acidosis. So there is lactate, high lactate of 8.6. Lactate of 8.6. So then bicarbonate has been used to mop up the excess hydrogen ion, and so base excess is extremely high. So this is a severe metabolic acidosis. Right. Then the second one also like is so okay. The second blood gas from the middle. So what kind of acidosis is this? Right. It is actually severe acidosis. It is not entirely metabolic. So sorry, respiratory actually. So it has both. So lactate is also more than 15. So this is a mixed severe acidosis. So carbon dioxide is high. The lactate is also high. So that is a mixed severe acidosis. Right. So then those are the slides actually. So the blood gas samples. Right. Then actually, so then I will talk about the I don't think I have time to talk about some other clinical cases now. So in summary, actually, so a blood gas, it is a bedside test, life-saving test, and so you need to do a proper sampling, yeah, and so need to transfer it, so do it immediately. If not, so you have to store, and so you need to give correct patient data, and also the trend, sometimes the trend is more important than single value, right? So that's about the blood gas, the analysis. So this is the very basics actually. So for your level, I didn't go into the high, so the complicated stuff here. Do you have any questions before I wind up?
Okay, you all have any questions? We can take
Okay.
a few minutes to
Yeah.
answer
If you have
them.
any questions, so that I can have some few minutes If not, so I will stop it and so I will hand over to the next person. Right. So, okay, I think so that's it. So then actually, I hope so you understood this ABG. Sorry about this, the technical problems. So I'm thinking there might be an issue with the signal in Matale. Sorry about that. And so I hope you will be starting the internship very soon. And good luck. Do your internship the better, because this is the time that you learn. And so good luck.
Right.
Thank you.
Thank you, sir, for taking the time and explaining very detailedly. So with difficulties. So next lecture is by Dr. Lilukshi Pereira, consultant anesthetist at BH Varakapala on airway management. Over to you, madam.
Thank you so much. All right. Can you all hear me? You can hear me, no?
Puna?
Yes.
All right. Okay. I think DGHS can you mute the microphone, please? The ministry, the microphone, can you mute, please? All right. Okay. So for the next 30 minutes or so, we are going to talk about airway management. So actually, the objectives would be why we need to manage airway in a patient.
We don't see your slides.
You can't see?
No. You are sharing.
You can't see?
No, we see some other.
Sorry, why you can't see my?
I think you're sharing the Zoom page. So I think you might have to share the presentation instead.
Sorry, give me. All right, sorry. Can you see now?
Yes.
All right, okay, sorry about that. All right, okay, sorry. So the objectives would be in this lecture. So why would we need to manage airway in a patient, and how to manage airway in a compromised patient? Obviously, we would need to manage airway in a compromised patient. Okay. All right. So when a critically ill patient presents to us, we would assess this patient in an ABCD approach. So A, B, C, D, E would stands for A is for airway, B is for breathing, C is for circulation, D disability, and E is for exposure. So here we are going to talk about A, that is for airway. So why we need to manage airway in a patient? Because untreated airway obstruction can rapidly lead to cardiac arrest. That's why we need to manage airway in a patient. So how do we manage in a compromised patient? Initially, almost always we need to open the airway in a patient. You can use triple maneuver to open the airway without any equipment or anything. You can use triple maneuver. I will tell you what is triple maneuver in the next slide. And then what you need to do is to remove any obstructions in the oral cavity. That would be vomit or blood. So you need to suction out those things. Okay. So The airway maneuvers I talked to you about in the previous slide, the triple maneuver, because there are 3: head tilt, chin lift, and jaw thrust. If you ask from an anesthetist, they are usually use these 3 maneuvers in day-to-day basis. So these are the 3 airway maneuvers I talked to you about: chin lift, head tilt, and jaw thrust. So chin lift is that you put 2 fingers below the patient's chin and lifting the chin up. And head tilt is keep your palm in the patient's forehead and tilt the head. Okay. And the jaw thrust means keep your fingers behind the patient's jaw and put the bringing the patient's jaw upwards, that is towards you. All 3 maneuvers will help you to open up the airway, mainly by preventing the patient's own tongue falling back and obstructing the airway. So these 3 maneuvers will help to prevent airway obstruction in most of the time. And after you prevent the obstruction, you have to provide high flow oxygen to the patient. You will come across in next speaker how to provide oxygen to the patient. So I'm not going to talk about providing oxygen in this lecture. So once you manage the airway, open up the airway, you might need to, as I told you, you might need to give somehow the oxygen. So you have to give it through a mask, an ambient mask, if the patient is not breathing or not adequately breathing. So masks come in various sizes and shapes. So if you have to select the correct size. So there are various sizes and colors and shapes. So if you have a transparent mask, it is better to find a transparent mask, because if patient vomit, you will be able to see, because otherwise you won't see. You will see in your, when you become a house officer, you will see rubber mask, black mask. You will not see even the patient vomit. So you will not see any obstruction in the mouth, even a patient vomit. So transparent masks, you will be able to see. That is why transparent masks are better. So you have to see, choose the correct size, that is only tight fitting mask covering mouth and the nose without putting any pressures to the eyes. So when you hold the mask also, you should not put any pressures on the surrounding structures. You can also hold the mask with 2 hands even, with the 2 hands even, like in this picture. Okay. So let's say now you have chosen the triple, you have applied the 2 triple maneuver, and you have got the ambu bag. But even with those 2, you have noticed the patient's lungs are not moving enough, that you suspect your airway obstruction has not relieved. So what you can do, you can move on to other airway adjuncts. One simple thing is oral airway, or what you call Goodell airway. So they also come in various sizes. They are usually color coded from 003 or 333 to size 6. Okay, so they are a bit robust, made in plastics. So when you insert those things, you have to be a bit careful about trauma to oral structures, teeth, gums, and tongue. Okay, so other thing is, if the patient is has GCS around 9 or 10, something around above 8 or that, it can give rise to gag reflex. Sometimes it can give more problems with spasms. So you have to be careful when you insert oral airway. So how do you measure the correct size of the oral airway? So this is how. So you have to take the size, the vertical size from the incisors, frontal incisors to the angle of the mouth, angle of the jaw. So that is how you get the correct size of the oral airway. Then how are you going to insert? So this is how you, this is the picture when you insert the final insertion position. But when you insert it the wrong way. So you insert, when you start to insert, you insert it the wrong way. When you go to the, when you pass the hard palate, you turn it 180 degrees. Okay. So you insert it firstly on the wrong way, and when you come to the hard palate, end of the hard palate, you turn it to the 180 degrees. So you will insert at the end something like this. All right. So let's say that I told you about gag reflex. Some patients will not tolerate oral airways, so they will buck, cough on oral airways when you insert oral airway. So they will not maintain their airway without any airway adjuncts, but they will also not tolerate oral airways. So what is the alternative that we can have? There is something called nasal airways. So same thing, but you can insert it nasally. So when you compare to the oral airways, they are bit rubbery in nature. They are soft because you are going to insert it nasally. So indication would be the patients can't keep their airway by themselves, but they need adjuncts, but they won't be keeping their oral airways. Contraindications would be based off the skull fractures, nasal fractures, because they will disrupt if you insert the airway. Considerations would be the patients who are on anticoagulants, high risk of nasal bleeding, like high vascularity in the mucosal cavity, like pregnant ladies. So they are the considerations if you're going to insert a nasal airway. So if you see these two, they also come in various sizes. And here you see a safety pin attached to the end of the distal end of the nasal airway, because that is, if you insert a nasal airway, they can go and dislodge into the trachea. To prevent that, you can insert a the safety pin, or otherwise it should have a wide base, so it won't go and dislodge into the trachea. So it can go and migrate to the nasopharynx and go to the trachea. So to prevent that, either it should have a wide base or you can insert a safety pin. All right. So you should get the correct size. Sorry. So you should get the correct size. So how to get the correct size? From the tip of the nose to the tragus. That is the correct size. So once you insert, it will look like this. The tip should be in the nasopharynx. So you are going to insert it like this. You need lubrication, gel. You need that. So when you insert, the first insertion should be directly go down. You have to find the patent nostril and directly go down. Okay, with the circular movements. Sorry. Okay, so let's say, so you have tried triple maneuver, your airway obstruction is not that relieved. So you have tried the oral airway. It's not good. So after that, you think you need a more advanced airway method to keep the airway open. So that is when you need a LMA, or a laryngeal mask airway. So what is the importance of laryngeal mask airway? That is a bit of advanced airway. So you need little bit of skills to insert. Not that much, but you need little bit of skills. It also comes in various sizes, usually from size 1 to size 5. They usually size according to the patient weight. Okay. They also have various types, or not only size, various types. So if you consider a LMA, they have various parts. There is a cuff, bar, aperture bar, and the airway tube, a connector to connect to the oxygen tubing, and a pilot balloon, and a valve to inject, and the inflation line. Okay, this is the cuff, the part that go and sits on the larynx, and the other part will go at the opposite side, will go and sits on the palate side. Okay. Okay, so I told you about the sizes from size 1 to size 5, and there are various types, various types that you need in anesthesia. You use various types of LMA, first generation to second generation. You do not need to, I just show you the types. Okay, so you need to choose the correct size, that is usually according to the weight. When you come to adults, usually for a female, it's usually size 3. For an adult male, it's usually size 4. Okay. So you need lubrication for that. So usually we applied lubrication to this part, the outer part, which sits on the palate surface. Okay. The outer space, outer part. The opposite of that part, the outer part. Okay, so this part, you apply lubrication. Okay, and you need to fill, after you insert the LMA, you need to fill the cuff. So let's say how much amount of air to be filled, how can you calculate? So if you think before you insert the LMA, you have taken all the air in the cuff, and you are going to insert size 3 LMA. So how much of air you need to fill this cuff? So that is the size of the LMA, that is size, if you take this is size 3 LMA, size minus 1, that is 2 into 10, that means 20. So you need 20 ml of air to fill this cup. When you think, that is, you have taken all the air before you insert the LM. So size minus 1 into 10, that is the amount you need to fill this LM. Okay. And is there a risk of aspiration? Yes, because these LMAs do not prevent aspiration 100%, but I told you there's first generation of LMAs and second generation LMAs. So the aspiration risk is different from first generation to second generation, but there is a risk of aspiration. Okay, and the LMAs can be used in ongoing cardiac arrest situations. Let's say there is a cardiac arrest in your ward. So you are going to be house officers now. So there is an ongoing cardiac arrest situation in your ward. So we are providing CPR at the moment. So you need to maintain the patient's airway. So you are not going to ambu-ventilate for the whole procedure. You can insert a LMA. You can insert the LMA and ambu-ventilate. You can do that. So that is the, you can free your hands, okay? So that is acceptable. That is actually recommended, not acceptable. It is recommended. All right, then you can apply a carbon dioxide monitor here, and you can monitor the carbon dioxide as well. Okay, that is the standard practice which is recommended by European Resuscitation Council guidelines. Okay. All right. So even with the LMA, you can't manage patient's airway. So last resort is the endotracheal tubes. So endotracheal tubes, just give me a second. Sorry about that. So endotracheal tubes. So these tubes are the definitive airways. So the aspiration risks are minimal. They also can be aspirated in micro aspirations, but very minimal aspirations. So parts of a ET tube. So there is a bevel, there is a Murphy side, there is a cuff, and markings. So there is a vocal cord guide. So vocal cord should be, this mark should be within the vocal cords, okay? And there is the length, which be the length, you can take a guide to your patients. This will be a guide to your tube's length. So you can take a guide where your, actually this length is from this tip, okay? And there is a pilot cuff and the connector, the adapter. Okay. Then, all right. So ET tubes or the nasotracheal or the endotracheal tubes also come in various sizes, 2, 2.5 to usually size 9, depending on the pediatrics or the adult size. Also, there are different types for different types of surgeries. Reinforced tubes, ray tubes, south pole tubes. So there are several types of ET tubes are also there. So when you go in as a house officer, if you go into theaters, you will see different types of tubes and different sizes of tubes. So for insertion of ET tube, you need a bit more skills. You have to be trained for insertion of a ET tube. So usually anesthetist will do, but trained, it's a life-saving skill. So you should actually, as a medical officer, it's a good skill to achieve. Every doctor, I think every doctor should have it, not only an anesthetist. And not only skills, you need to have few other supporting equipments to insert a ET tube. And what about intubation or putting a ET tube, passing ET tube down during a cardiac arrest situation? If I say during a cardiac arrest situation, it is not advisable to do pass a ET tube. Yes, it is very difficult to pass a ET tube during a cardiac arrest situation, even for a very experienced anesthetist. Okay, because there is an ongoing CPR. Someone is providing CPR, chest compressions. It's very hard to do a chest ET tube insertion. If you see this kind of situations, the ET tube insertion person might ask, can you please stop the chest compression? I want to pass down the tube. Is that the correct way to do it? No, chest compression is more important. So how can we manage there? We have LMA. LMA is not that hard to insert. So you can provide the airway, maintain the airway with LMA once patient has spontaneous circulation, then you can insert ET tube. All right. So it is not advisable to pass down the ET tube with ongoing cardiopulmonary resuscitation. Okay. So what are the equipment that you need to need for an intubation? So obviously here you need for different types, different sizes of ET tubes. So usually for adult female, I would say 7 or 7.5. For adult male, I would say 7.5 or 8. Okay, for pediatrics, I can't say there is formulas according to the formula and the age that kind of tubes. Okay, so you have to have the desired type of tubes. Okay, and you need to have working laryngoscope with the desired size of blade. So according to the patient age and the gender, you might need different types of size of blades as well. Okay, so අපි හැම patient එකම blade එක පාවිච්චි කරන්නේ. Pediatric sizes වලට වෙනම blades, for adults different blades. Okay, so you need to have different blade sizes. Okay, so tubes and blades. Okay, and you have to have working suction, because these patients might have vomiting, blood in the mouth. So working suction is needed. And this tube, we intubate this patient not in an ideal environment. In the ward, maybe in the ETU, in a trolley. So we are not intubating these patients not in the ideal environment. So these intubations can be difficult. So we have to be ready with a difficult intubation. That's why we need bougies, stillets. So you need difficult intubation equipments as well. Okay. And what are the other things? So other airway agents, if this patient is going to be a difficult intubation, you need to maintain the airway. So that's why other airway adjuncts, LMA, nasal and oral airways also should be there. Okay. And once the the tube is inserted to fill up the cuff, you need the syringe, and secure the tube, you need the tape. And until the patient is intubated, you need the ambu bag and the mask. And once the patient is intubated, you need the capnometer. With the capnometer, you can get a lot of information. The first thing you will be getting is the confirmation of the intubation with the capnograph. Okay. So these are the equipments that you need to intubate a patient. So when you ask someone to come and help with intubation, that is usually an anesthetist. So they will come from theater or ICU. They also are very busy people. They will come abandoning their work in the theater or ICU. So they will come to help you. So when you are in the ward, okay. So when they come and when they come to intubate, you are the responsible person in the ward. So when you ask someone to come and help you with the intubation, you should be ready with these equipments. Okay, otherwise the person who comes for the intubation get ready with everything. So it will delay your intubation. Okay, so you should be the one who get ready. You can ask the theater, the ward people to see whether these things are in place. Okay, that is your responsibility. So the equipments are ready, but that is not the only thing. For intubation, you need to have drugs, the monitors, everything should be there. So what are the drugs that you need? You need sedative drugs. You need pain reliefs. You need muscle relaxant drugs. So without drugs, sometimes you intubate without anything, but most of the time you need these drugs. So sedatives, I mean, usually midazolam or propofol, pain relief, usually fentanyl or morphine, muscle relaxants, most of the time is succinylcholine or atracurium. So those drugs you need to have ready, okay? And after intubation, you need to, with the intubation and after intubation, you need to monitor vitals, blood pressure, ECG, saturation, all the vitals with the capnography. So you need to monitor the vitals of the patient. And after intubation, you need to continue the above drugs because now you intubated the patient, you need to sedate and pain relieve this patient. Most of the time you intubate this patient to send to a maybe to the theater, maybe to the ICU or to a transfer to another hospital. Okay. So this patient is now intubated on a ventilator or a ambu mask, ambu bagging. So you need to keep this patient stay still. So not only atracurium to paralyze, but you need pain relief medication, sedation to provide sleep to this patient. So please remember, you need all above 3 drugs to be continued if you intubate a patient. Okay. So with these drugs, then you can put this patient to a ventilator. Okay. So you can ask the anesthetist or whoever come to help you in intubation, set up the ventilator that is suitable for this patient. All right. I think this is what I think about, that is about the airway management. The oxygenation and other parts will be dealt with the other speaker who's going to talk to you about oxygenation in the next lecture. Any questions until up to now? Let's see. Can we get the... Yes, of course, you can get the slide lectures. Any other questions? Any questions? If there's no questions, I think I can stop the lecture and I can pass the I can stop sharing, but I will meet you in another lecture after the lunch. Okay, thank you so much.
Right. Thank you, madam. Next lecture is by Dr. Lakmini Pereira, consultant anesthetist at DH Dambadeni on oxygen therapy.
All right. Okay. So good afternoon to everyone. So my lecture, 1 second. Roshan, can you see my screen?
No, you're not hosting, madam, sharing, madam, yet.
Can you see it now?
Yes, can.
Right. Okay. Good afternoon to everyone. So Roshan, I'm getting 40 minutes, right?
Let me see.
Because I was given 12:50 to 1:30 and it's now
Yeah.
12:20.
So we can finish the lecture and go for lunch afterwards, madam. So, okay.
Fine. Right. Okay. So next 40 minutes, we are going to talk about the oxygen therapy. So during these 40 minutes, what we are going to learn about the rational approach of safe oxygen administration in critical ill patients and principle of oxygen therapy, fixed performance, the devices that we can use for giving oxygen to critical ill patients, and what is controlled oxygen therapy. Right. So oxygen is one of the very commonly used drugs in our hospitals. We all have been using it, but to be honest, there are like a wide variety of overprescribing or underusage, or sometimes we don't even prescribe oxygen. So as a drug, are we doing the correct thing with oxygen? And there will be the main objective of the inadequate oxygen, how to recognize patients who are in need of oxygen, and the rational approach to the oxygen delivery, and how to select the proper device for the oxygen therapy. And if oxygen is a drug, how to prescribe oxygen, and assessment and monitoring of patients with oxygen, and how to weaning off oxygen from a patient. Give me 1 second. Sorry about the noises because it's very close to the main road, Colombo 5 main road, so there will be a lot of noises. Right, okay, so if you take the history, who has discovered the oxygen first? So there are a lot of controversies about the discovery of oxygen in that area. So who discovered oxygen first and when? So it is likely, if you go through the history, if you Google the discovery of oxygen, they say the credit should go to a Scottish scientist, Carl Wilhelm Scheele, who isolated oxygen first in 1772, or even a year or two earlier. But most of the time, the credit goes to Joseph Priestley in 1977 for his work on instrumental work. Hello. Can you? Can you message me if you all can hear me properly? Right, okay. So oxygen is right. Oxygen is a tasteless, colorless and odorless gas. It is denser than air and soluble in water and extremely active chemically. If you take oxygen as a therapy in critically ill patients, why oxygen is needed? Because we all know under aerobic conditions at the mitochondria, the glucose will be metabolized into 38 ATPs when oxygen is available in aerobic conditions. But once oxygen is not there, in contrast, under anaerobic conditions, it will produce only 2 ATPs and the rest of the product will be lactic acid, leading the critically ill patients into lactic acidosis. So these critically ill patients are having 1,001 reasons to go into acidosis. On top of that, not providing adequate oxygen will also lead them to continuation of acidosis. Right. So when you take oxygen delivery, to the tissues, that will depend on how much of oxygen that you are giving, that is FiO2, the fractionated of oxygen, and the ventilation, the rate of ventilation and the tidal volume, pulmonary perfusion, and adequacy of pulmonary gas exchange, and capacity of blood to carry oxygen, and how this carried oxygen is being delivered at the tissue level to the mitochondrial level. So when we take normal adults, a person at rest, they have their own reserves of oxygen within their body. So they can compensate with tachycardia, there are sudden adrenaline surges and all. So increasing oxygen requirement can be compensated by the healthy body. But when it comes to the critically ill patient who are now in higher catabolic state due to various reasons with tachycardia, fever, shivering, and a lot of other problems, so they don't have enough reserves in their body. So we need to provide oxygen from outside. The first factor that the oxygen delivery to the tissue depends on alveolar oxygenation. How much of oxygen that you are sending to the alveolar level? How much of pressure, partial pressure of oxygen is created at alveolar level? That will depend on how much of oxygen that you are giving, that is FiO2, and the adequacy of the ventilation and the patency of the airway. So you can increase your oxygen supplementation by increasing FiO2, number one. You need to have a patent airway of the patient to deliver that oxygen. And you need to think about the minute ventilation of the patient, that is tidal volume into respiratory rate. So in a patient who are at risk of requiring higher amount of oxygen, these three factors you need to consider. Now, you thought about those three factors and you optimize the alveolar level of oxygen. Now, what is inside the alveoli need to be go across the pulmonary capillary membrane to the perfusion or the perfusion side to the pulmonary circulation. Now the pulmonary perfusion, when you take the right ventricle pumps out deoxygenated blood into the pulmonary circulation. That deoxygenated blood comes closer and contact with the lungs or the alveolar units. So any problem with the pulmonary circulation, any reduction of blood, any vasoconstriction, any BP dropping, or any factor that is affecting the pulmonary perfusion will affect the oxygen delivery to the tissue ultimately. So we call it a dead space. So the wasted circulation, where wasted ventilation, where your ventilation is fine, your alveoli are filled with oxygen, but because of the perfusion issues, your oxygenation is not taking place. Then, extending to this pulmonary circulation, there is a thing called physiological phenomenon called VQ matching. So to happen this ventilation, to happen this oxygenation perfectly, there should be ventilation perfusion matching. All the alveoli who are ventilated well need to be perfused well in order to have a good oxygenation. So in case where the VQ ratio, normal, if you take normal healthy adult, the VQ ratio is closer to 1.95. But if your VQ ratio is higher, that means something to do with your perfusion. Your fraction of your perfusion is less now, so your VQ ratio is higher. Now, increasing FiO2 won't do anything with this type of increased VQ ratio imbalance, because now already your alveoli are ventilated with high FiO2. Problem with this
Madam,
optimizing.
you're cutting off time to time.
Sorry?
Sorry. You're cutting off time to time. We are unable to hear you. Sorry.
Roshan, it is because I'm getting calls. So I'm logging on with my phone. That's the problem. Are you here now?
Yes, I can hear you.
Right, okay. Right. So but we are at like VQ, higher VQ. So your ventilation is perfect. Your perfusion is affected. So increasing FiO2 won't do anything. Whatever that comes to the better ventilated lungs will be perfused well. But unless you correct your perfusion, you won't be able to achieve the normal VQ ratio. Compared to that, what is happening with low VQ ratios? That is, your ventilation is affected, your perfusion is perfect. So the part above the above is affected. So what will happen there? So you are getting a good perfusion to all of your alveoli. Now the problem is with the airways. So here, if you can increase, so low VQ conditions, if you can increase your FiO2, that will do a little effect on the improving VQ mismatch. Because now, if you, at such point, where the ventilation is affected, if you can send 100% oxygen, whatever comes to the alveoli is 100% oxygen and will be transferred to the circulatory part. But when there's a shunt, where your alveoli are not getting ventilated, so then there won't be any effect by increasing FiO2. So far, what are the factors that is affecting the oxygen delivery to the tissues? It is FiO2, your fraction of inspired oxygen concentration, the patient effort of breathing, respiratory rate, and the tidal volume, patency of the airway, your pulmonary circulation. Because of that, the VQ ratio. Now, your ventilation and perfusion is there. Now, whatever which has come to the alveoli has moved across the pulmonary capillary membrane to the pulmonary circulation. Now, those oxygen has to be carried from the pulmonary, from the alveoli to the tissues, which will be done by the blood. So oxygen is carried in the blood in two main ways, in bounding to hemoglobin and dissolving in the blood. So dissolved portion, which gives the PaO2 and the binding of hemoglobin. We call this oxygen content of the blood. How much is the total oxygen content in the blood available for a patient to be used? That is, there is an equation, depends on what is the hemoglobin content and how much of hemoglobin can bind with the oxygen and what is the percentage of saturation of that hemoglobin plus the dissolved condition. So, sixth factor which determines the oxygen delivery to the tissue will be the hemoglobin, right? So, in this graph, you can see very clearly if a patient is fully is not anemic, HB is 15, and you take a patient with half of that hemoglobin, 7.5. So you can see both are saturated to 100%, but the oxygen content of the blood is double up compared with the anemic patient. So in HB of 7.5, the oxygen content comes to 100, where the HB is optimized to 15, your oxygen content is 200. So it is not only the saturation, it is not only the pulmonary circulation, patency of the airway or the FiO2, but your level of hemoglobin is matters. That is why in septic patients or critically ill patients, optimizing hemoglobin is very important to prevent them going into ischemia, organ ischemia. Right. Why this ODC curve? We all know this ODC curve, which has a sigmoid curve shape. Why it has this sigmoid curve? Because we know hemoglobin can bind with 4 molecules of oxygen. So binding of first molecule of oxygen is difficult. Second, third binding is easy. And the fourth, again, difficult. That gives the sigmoid shape to the ODC curve. Now, once the oxygen is fully saturated, once the hemoglobin is fully saturated at pK of 100 millimeter mercury, so increasing PaO2 above the, like, if you try to send oxygen more by increasing P or anything, gives a very little effect on oxygen transport. Now there's another factor which affects the oxygen delivery to the tissue. However hemoglobin you are having, however, if you are fully saturated with hemoglobin and you're having optimal condition of hemoglobin, but you need to send this fully saturated hemoglobin to the tissue level. That will be done by your cardiac output or the blood pressure. So your cardiac output has to be optimized in order to deliver proper oxygen delivery, amount of oxygen to be delivered to the tissues. So consider, summarizing everything together now, when you take critically ill patient, if you want to give oxygen, it is not only the oxygen that you are giving, you need to think about the factors that will optimize the oxygen delivery to the tissue. What are the factors? FiO2, patient's respiratory effect, rate and the tidal volume, patent airway, pulmonary circulation, optimized hemoglobin, and cardiac output. So if you fail to achieve these standards or these parameters, the patient will go into hypoxia. So how the body will react physiologically to the effects of hypoxia? Respiratory effects. So the patient will go into hyperventilation because acute hypoxia will stimulate aortic and carotid bodies, which will be representing as the hyperventilation of the patient if the patient is breathing spontaneously. Hypoxia is a strong pulmonary vasoconstrictor. So pulmonary vessels go into vasoconstriction and divert the blood to the vital organs. And Haldane effect, which is the carbon dioxide, hemoglobin, deoxygenated hemoglobin has a higher affinity for carbon dioxide. So in peripheral circulation, in systemic venous circulation, deoxygenated hemoglobin will bind with carbon dioxide with higher affinity and brings them to the lung and send it out through the pulmonary ventilation. Bow effect comes with a more chronic exposure where the 2,3-DPG is going up and the ODC curve will be shifted to the right, and it will be easy for the hemoglobin to deliver oxygen at tissue level. So those are the respiratory effect of acute hypoxia. If you take cardiovascular system, in response to acute hypoxia, patients will go into coronary vasodilatation in order to prevent coronary ischemia. Systemic vascular resistance will be decreased purely through this splanchnic vasodilatation, and there will be tachycardia, and they try to maintain cardiac output through tachycardia. Renally, activation of the renin-angiotensin system with hypoxia will indirectly try to control the blood pressure and increase erythropoietin production. We'll try to increase the hemoglobin binding with oxygen. If you take CNS, acute development of hypoxia causes cerebral vasodilatation in order to prevent cerebral hypoxia. When saturation drops to 80s, patient will experience decreased mental functioning and confusion, and they will lose their consciousness if you continue to be the patient to be hypoxic up to 60s or 50s, and there will be irreversible hypoxic brain damage within minutes with the onset of acute hypoxemia. But these effects are less pronounced in patients who are exposed to chronic hypoxia, for an example, patients in high altitude or with chronic hypoxic environment. Right. So if you ever happen to see this type of acutely ill patients who are deteriorating, who are desaturating, you need to give oxygen immediately, because now you have seen, noticed how critically this is affecting almost all the vital systems. So the British Thoracic Society guidelines recommend to give highest possible percentage of oxygen. If the patient is breathing spontaneously, you can use the non-rebreathing bag and mask with 15 liters oxygen. If the patient is in respiratory peri-arrest or cardiac arrest, so you can use the ambu bag to deliver high oxygen to the patients. The target is 98. So in acute situations, you need to give highest possible oxygen to the patient, targeting a saturation of 94 to 98. Once the patient is stabilized, or once the patient is stabilized, you can come down with oxygen, or you can monitor oxygen. Even in a COPD patient, chronic CO2 retention patients, this is the normal target. Initially, you need to go for a higher targets of 94 to 98. Then once the patient is stabilized, by monitoring ABG, looking at the CO2 retention, you can gradually come down to your COPD targets, which is 88 to 92. Right. Then comes the question, when to do a blood gas. So the blood gas can be done, so arterial blood gas analysis can be done in following patients. A patient whose deteriorating initially. Now the patient is not on any oxygen support. The patient presented with pneumonia, and the patient is, during a clinical assessment, you realized patient respiratory wise is deteriorating. So to get a baseline idea, you need an ABG. So the first indication to get an initial baseline understanding about the patient's physiology and the pathology, you need to do an ABG. Then patients who are in unexplained hypoxemia, there's no reason why the patient should be on hypoxemic, but the patient is reporting a saturation less than 94. Then better to do an ABG and see how the other parameters are like. Then patients who have been started on oxygen, but now worsening on the oxygen therapy. So continuation of oxygen therapy, you need to do an ABG. So any previously stable patient who requires oxygen suddenly or requires gradual increasing of O2 suddenly to maintain oxygen saturation, then you need to do an ABG. And patients with hypercapnic respiratory failure, like COPD patients, you need to do ABGs frequently to guide their management. So there are a lot of reasons why you need to do ABGs in critically ill patients, and when. So question, in a shocked patient with severe sepsis, the following may increase your oxygen delivery. So what we have learned. So increasing FiO2, yes, depending on what is the reason for desaturation, but initially you can increase your FiO2 and see. Hypoventilation. Hypoventilation, you don't need to increase your FiO2. Adequate ventilation is required to ensure alveolar ventilation. Fluid challenges will increase your oxygen delivery to the tissue. Inotropes will increase your oxygen delivery to the tissue. By both of them will increase your oxygen delivery to the tissue by increasing cardiac output. Can you all mute your microphones? And blood transfusion, increase oxygen delivery to the tissue by increasing hemoglobin. Okay, right. Now you have started your oxygen. So the people who have not muted your microphones, can you mute it? Right. Okay. So now you have started your Sorry. Prashant,
Yes, madam. Yes.
can you ask these people to switch off, switch off their microphones? Right. Okay. Now you have started your oxygen therapy. Now how to monitor and wean them off. Right. Once you have started your oxygen therapy during the initial hours, you need to monitor at least with a pulse oximeter. So you need to have a continuous monitoring of saturation continuous monitoring of saturation. So the target for normal critical ill patients, except for the COPD or CO2 retention patients, it has to be 98. But for the patient with target saturation, so once the patient stabilized, as we discussed earlier, you can come down to your target saturation of 88 to 92. The patient stable patients, who are stable patients who are stable on oxygen therapy, they need monitoring with oxygen, so you can gradually come down with oxygen. Unstable patients on oxygen therapy, where they need going higher up with their oxygen saturation. These patients, you can't monitor these patients in a ward setup, and you need to consider HDU and ICU setup for oxygen further management. Patients who are on oxygen therapy deteriorating suddenly with saturation and ABG, they need a full clinical assessment back again, and they need to go for ICU. And if these people need increasing oxygen supplementation, again, these patients are patients to be monitored in HDU ICU setup. So as we discussed earlier, who needs frequent ABG monitoring? The patients with COPD or chronic CO2 retention, and patients who are not improving on supplementation of oxygen and deteriorating. These patients should be monitored gradually over a period of time with ABGs. If the patient is stable, you can start coming down with oxygen. You can start coming down with oxygen half an hour or 15 minutes interval, targeting the saturation of 98. So the lowest possible oxygen that you can give through a device is 2 liters from a nasal cannula or 28% oxygen through a venturi mask. So if the patient is tolerating or maintaining saturation with those lowest possible oxygen, you can discontinue oxygen and observe for further management. Now you realized you have a couple of devices where you can give oxygen to the patients in critical ill patients. So what are those devices? You can use invasive devices like intubation, or most commonly at your level ward setup, the non-invasive devices. Non-invasive devices again categorized into 3: low flow devices, high flow devices, and with positive pressure. Low flow devices again categorized into 2: fixed performance devices and variable performance devices. Depending on the oxygen dependency, you can categorize your patients into 2. Low dependency patients are the patients who are on spontaneous breathing, but they need supplemental oxygen, but they are stable. They are low dependency patients. Medium dependency patients are patient needs oxygen. On top of that, they need some ventilator supports. For example, patients who are on CPAP or BiPAP. High dependency patients are patients' respiration is not under control. Now you need to take intubation and ventilation, and they need definitely to be on oxygen. So depending on their dependency, so you can select your device. So there are various devices where you can use. So what are the variable performances? Low flow devices. That means you can't control the FiO2 by these devices. The FiO2 will depend on the patient depth of breathing and the rate of breathing. So what are those devices? Nasal cannula, normal Hudson face mask, and non-rebreathing diaphragm mask. Fixed performance devices are the devices where you can control your FiO2. Those are Venturi devices, right? So variable performance devices, as I told you, your FiO2 depends on the equipment factor, oxygen flow rate, mask volume, and how the mask gets fit into the face, and the patient factors, the rate and the depth of the breathing, and additional factors like presence of additional gases. The commonest variable performance low flow device is a nasal cannula. It's a very good device at ward setup. You can go from 1 liter per minute up to 6 liters per minute with nasal cannula, and you can deliver 24 to 36% of oxygen with this. Why we are not going higher up with nasal cannula more than 6 liters? Because it's very uncomfortable for the patient. Face mask. We all know this, that the face mask, you can go up to 15 liters of, per minute oxygen, and you can deliver 40 to 60% of oxygen through a face mask, depending on the breathing of the patient. Now, you can start off with your nasal cannula, depending on the patient's clinical background and the requirement of oxygen. Monitor the patient. If you feel that the nasal cannula, which can give only up to 36%, is not enough, change the patient into if the flow rate goes more than 6 liters to maintain saturation, change the patient's device into face mask. Then, more than the face mask, maximum you can deliver FiO2 of 60%. Then you have non-rebreathing bag, where there is a valve, unidirectional valve, and a 60 to 100 ml bag connected to the bag, reservoir bag, where the rebreathing won't affect, because whatever the patient is exhaling will go out through the holes of the side holes of the mask because of the unidirectional valve. So the oxygen which is coming into the bag is collecting, 100% oxygen is collecting into the reservoir bag. With next breath, patient will inspire only the 100%. So with this NRBM, you can go very closely to 100% FiO2. Now, other low flow devices are the fixed performance devices. We all are having these in our boards. So they are color coded devices. And in that device, they have mentioned the FiO2 and the rate of oxygen to be delivered. Because if you give that particular rate, only the device will give that particular FiO2. For an example, your green, which gives the 60% of FiO2, needs nearly 30 liters of oxygen per minute. So to give the exact FiO2, you need to give that flow rate, which is mentioned on the device. The Venturi device utilizes the Bernoulli effect, where it says the conservation of the energy. So when the velocity increases, the pressure drops. So you go back to your boards and take a device and see there is a small narrowing of the oxygen inlet. So at this narrowing, the flow rate increases, the velocity increases, so the pressure drops at that particular point. So there are side holes in the Venturi device. So with the pressure drops, it entrains air into the oxygen stream that will come down your 100% FiO2 to the desired FiO2 given by the Venturi device. That is why it is very important to give the particular rate, 15 liters, 30 liters, or 18 liters. That rate, if you give that rate only, it will work properly according to the Bernoulli principle. Then in your high flow devices, you have high flow nasal oxygenation. So this additionally to your nasal cannula, this is again the device similar to a nasal cannula the patient feels, but it can give a small peak, which is not there with the nasal cannula. And compared to the nasal cannula, this will humidify your air. So the additional advantages of using HFNO is you can control your FiO2, you can humidify, and you can deliver a peak. So it's more reliable delivery of FiO2. It causes nasopharyngeal dead space washout. It gives a PEEP effect, And because of the PEEP effect, it causes alveolar recruitment and it causes improved mucociliary clearance. But you can't use HFNOs in following patients. Patients with type 2 respiratory failure and patients with nasal passage abnormalities or nasal surgeries, patients with cerebrospinal fluid leak, patients with base of skull fractures, and patients with severe epistaxis. So those are the contraindications for HFNOs. And this is where you use very high flows to the nostril. So you need to explain the physiology, the physics behind that to the patient. So you need to explain the procedure to the patient and get his consent. And you need to set up the temperature, you need to set up the flow rate, and you need to set up the FiO2 before you put it into the patients. So by putting that in, you can do frequent blood gas analysis at certain intervals, or you can monitor the FiO2, and then escalation or de-escalation can be done accordingly. Then other fixed performance devices are the NIV. So you have the CPAP and the BiPAP. So the advantages of CPAP and BiPAP or the NIV over invasive ventilation are, you don't need to put a tube down, so you don't need a sedation. This allows the patient to communicate with the family, oral intake, so the patient comfort or the patient compliance to the device is very good. So you can set up this at your ward setup, so the unnecessary ICU burden will be prevented. But the disadvantages with NIV is no airway protection, less ventilator control, no direct access to the tracheobronchial toilet. You need to take it off in case of you need to do suctioning and all, and the most probably aerosol generate. This is an aerosol generating procedure. So we have two, as I told you, CPAP and BiPAP. CPAP, where you apply a continuous pressure, which will open up your basal alveoli and apply a PEEP. Compared to that, BiPAP, there will be two pressure settings. One is IPAP, so you give a pressure at inspiration and you maintain a CPAP or EPAP, similar to CPAP. So that will keep your basal alveoli open during your expiration. So especially BiPAP is very commonly used in bronchial asthmatics and COPD patients. Right. Controlled oxygen therapy. Now, whatever these devices that you are using, you need to be cautious with the patients who are with risk of CO2 retention. Who are the patients? Chronic obstructive COPD patients, cystic fibrotic, morbidly obese patients, presence of chest wall deformity, and patients with neuromuscular disorder. The problem, so you have given high oxygen, that will wash out CO2, high flows, which will wash out the CO2, and you will abolish their hypoxic ventilatory drive. So we have to be very cautious with them. So the BTS recommendation with controlled oxygen therapy, start with the lowest possible FiO2, that is 28% Venturi, or if you are using nasal cannula, 2 liters of nasal cannula, and monitor these patients with pHs. So your CO2 and the pH. If the patient is acidotic and the CO2 is rising, that is CO2 retention, the patients are got into respiratory acidosis and patient is tiring. So you may need to think of immediate senior review. They are candidates for invasive ventilation. So you are on controlled oxygen therapy and your pH is now normal, more than 7.35, and the CO2 is washing out less than 45. CO2 is still high, but now you can titrate or reduce the dose of oxygen, and you can have a target of 88 to 92 and continue ABGs and continue monitoring, and you can consider continuing with oxygen therapy unless the patient going into the previous arm, that is CO2 retention. If the CO2 is normal, if the pH is normal, so you are in the correct arm. Sorry, so you can continue your oxygen therapy, targeting your saturation. of 88 to 92. Right. That is it. So the key points of oxygen therapy. First thing, you need to identify whether this is a patient who is in need of oxygen. Secondly, then we need to know our physiology a bit. What are the factors that will affect to the oxygen delivery to the tissues? When to increase FiO2, how these patients' respiration and ventilation affects the oxygen delivery, patency of the airway, what is the role of pulmonary circulation, what is the role of hemoglobin optimization, what is the role of cardiac output or the blood pressure optimization. Then, depending on your assessment, what device that which category this patient is in, whether this patient needs controlled oxygen therapy or not. Whatever it is, if the patient is critically ill and deteriorating, focus on optimizing oxygen saturation to 98 first. Then, once the patient becomes stable, then you can think of coming down to your targets. So when it comes to targets, if the patient is with consideration of chronic CO2 retention, then you have to target a saturation between 88 to 92. Otherwise, you continue to have your target saturation target of 98, do frequent blood gases, and then depending on the patient's stability, you wean your oxygen down, and at some point, you take this oxygen off from the patient. So that brings to the end of the oxygen therapy. So any questions? Okay. If you don't have any questions, I think it is now time for the lunch break. Is it Roshan?
Madam, we can take the lunch break and we can come back at 1:30.
Right. Okay. So it's
Right,
your
thank
time
you.
lunch break now. So back again for the lecture by Dr. Dilrushi again by 1:30. Thank you very much.
Right. Thank you very much, Madam, for that comprehensive lecture. So we'll take a lunch break and come back at 1:30. Right. Welcome back after the lunch break. So we have another interesting topic by Dr. Diluksh Pereira, consultant anesthetics at BH Varakapal on pre-operative preparation. So over to you, madam.
Okay, thank you very much. So next half an hour or so, we are going to talk to you about pre-operative preparation. Okay, so here we are going to talk to you about little things about what is pre-operative preparation, optimization, and why do we need to do those things? And what is your role in it as a house officer? Okay, so pre-operative preparation, you can largely divide into two separate groups. Pre-op assessment, it is actually to see how your patient is and to optimize the patient condition. So two large categorization groups. So, so why do we need to do assessment on the patient? To see whether your patient is fit enough to undergo this surgery or anesthesia. All right. Okay. So when a patient, when you do an assessment, so you have to see the fitness for the surgery. So this fitness for surgery, I think someone is talking in the background. Will you be able to mute your mics, please? Okay. So the fitness for the surgery actually largely depending on two main categories again. The surgery itself and the health status of the patient. The surgery, when you talk about the surgery, again, you can divide it to two subgroups. The grade of the surgery and the whether it is doing it as an elective or an emergency surgery. So here, the grade of the surgery, what you mean by it, whether it's a minor, intermediate, or a major surgery. The other one is elective or emergency. If a patient comes as an emergency surgery, you have very limited time to optimize this patient. So fitness make a major role in this patient. Okay. The second main category is the health status of the patient who comes for your surgery. So when you do an assessment, pre-op assessment in your patient, it will ensure that you will be able to optimize this patient for your surgery. Okay. So you will identify the problems in this patient and you will make sure the problems that will encounter during surgery will be minimized. So you will optimize this patient. And also you will identify the potential complication and you will take precautions to minimize those things. If as example, when you take a placenta percreta like patient, so you will think about what will you do if a patient start to bleed. So you will think about taking precautions with grouping and DT, not to only one pint. You will reserve more blood, more amount of blood. You will have you have to liaise with the blood bank. You might need to have a chat with the surgical team or the vascular team or the balloon pump. So you have to plan about these patients when you identify the complications. Okay. The other thing, when you do pre-op assessment, the patient has to come beforehand to the theater or the team, meet the team involved in the surgeries. So they will be familiarized with the team who involves with the surgery. So their anxiety and fears will be dealt with. So they will be less anxious for the surgery itself. So there are a lot of things you will be come across when you do the pre-operative assessment. So actually, who is going to involve with this pre-operative preparation? Not it is not only the anesthesia team and the parent medical team. It's actually a multidisciplinary team approach. So obviously, anesthetist should be involved and the parent surgical team should be involved, the juniors and senior medical team. And also, apart from those people, the nursing staff of the ward and the theatre, the other specialties also plays a part. Radiology people, cardiology team, the other medical staff, all plays a part in this. So it's a multidisciplinary approach. Okay. All right. So what are the components in a preoperative assessment? You all know it's a history, examination, investigations. Apart from that, you have to assess the risk for this surgery as well. So the very familiar history, examination, investigation. Apart from that, you have to assess the risk as well. Okay, so history. So you have to know about the history. Why this patient coming for this surgery, indication and the related issues, the age of the patient, the past medical history, and the disease control. If the patient, as an example, if the patient is a diabetic, so how controlled is his diabetes? Okay, so as you can see, diabetes, hypertension, ischemic is whatever the patient is having. So how controlled is the patient's disease? So you have to know all about that. And the drug history. So what are the drugs that patient is on? So because you might need to modify the drugs patient currently on. So you might need to increase or decrease the drugs patient is on. So you might need to stop some of the drugs patient is on, because some of the drugs you need to stop or convert into another drugs before patient comes for the surgery. Apart from that, you need to know about allergic history. These days, you for the last few months or so, you have to be very careful with the drug allergy. So you need to know about drug allergic history. And the past surgical and the anesthesia complications, very, very important. And the smoking history, because you know smoking will be hazardous for anesthesia as well, and the post-op complications. So you know, you have to know about the smoking history. And the exercise tolerance, very, very important for anesthetist as well. So you have to know about the exercise tolerance. So you can get an idea about exercise tolerance with the MET value. So that MET stands for metabolic equivalence. So metabolic equivalence, so we as an anesthetist, we will be happy when the metabolic equivalence is more than 4. So what is metabolic equivalence more than 4? This is 4. 4 is climbing stairs at a low space. We can ask from the patient if you can climb 10 steps without stopping in the midway. That is roughly about MET of 4. If it is more than 4, you will get a satisfactory level of exercise tolerance. That doesn't say MET more than 4 is doesn't stand. That means that patient is fit for surgery. That will give a crude idea of good exercise tolerance. Okay, so we will be looking for MET around 4, rough value of MET around 4. So MET value less than 4 is we are not happy with a value of MET less than 4. So when you do the examination, we have to go with general, cardiovascular system, respiratory system. Whenever you indicate, you have to go with the neurological examination as well. So as you know about a medical student, so you have to roughly examine all the system whenever relevant. So you will get a lot of ideas, lot of the clinical findings when you go system-wise. So when you come to the investigations, what to order? Are you going to order everything for each and every patient? No, you do not order all the investigations for each and every patient. So actually it depends on the grade of the surgery and the patient's comorbidities. So let's say there are two patients. One is 18-year-old, one is 70-year-old. They both are coming for inguinal hernia repairs. So 18-year-old patient doesn't have any other comorbidities. 70-year-old patient has ischemic heart disease and diabetes. So are we going to order the same sets of investigation for both patients? No. They both going to have the same grade of surgery, but they are having different comorbids according to their scales. So 18-year-old doesn't have any, but the 70-year-old has ischemic heart disease and diabetes. So depending on their comorbidities, so 70-year-old going to have different sets of investigations. Okay, I'm not going to talk about what are the investigations they are going to have in individual basis, but it's going to be different. So the surgery gates, according to NICE classifications, as I told you earlier, it's minor, intermediate, and major, because I talk you about grades. You can go through. The minor is like abscess draining, skin incision. Intermediate is like inguinal hernias, varicose veins, tonsillectomies. Major is like TAHs, lumbar discectomies, thyroidectomies, laparotomies, something like that. So what are the investigations we do have at the moment? All the investigations we have, usual investigations. So blood investigations like full blood count, blood urea, electrolytes, liver function tests, coagulation screens, fasting blood sugars. So those are the usual blood investigations we have. ECGs, echoes, chest x-rays, ABGs, lung function tests, and other investigations as indicated. So among those, we are going to ask for the investigations depending on the surgery grade and the plus the comorbidities the patient is having. Okay. And I told you about the 3+1. The last one is the risk stratification. We have several methods of risk stratification. I'm not going to go into very much detail, but the simple risk stratification method is ASA classification. Okay. So ASA classification, ASA means American Society of Anesthesiologists. So they have grade patients into 1 to 6. 1 is healthy patients. 5, I will tell you about the 6, but 5 is the moribund patients. So they will not going to survive for the next 24 hours, even you do the surgery or not. So they are gravely ill patients. Even you do the surgery or not, you are not going to do the surgery, they are not going to survive. Okay. So ASA 6 means these patients are already declared brain dead, but we are keeping them in the ICU setup only for purpose of donating organs. So they are the ASA 6. So other patients are in between 1 to 5. Okay, so we can stratify the risk according to ASA classification. This is a very simple risk stratifications. When you are house officer, if you go through anesthetist charts, you will see ASA grading in the pre-medication. You will see. So once you do history, examination, investigation, and risk stratification, the other part is the other part is the optimization. So what we can do the optimization, you can optimize the drugs patient is already on. So you can optimize the blood sugar level. So you might have to optimize the drugs, the oral hypoglycemics, you might need to add on drugs, or you might need to introduce the insulin, okay? And control the blood pressures with antihypertensives. And optimize the chronic lung conditions. You might need to add on bronchodilators, add nebulization. If the patient is having respiratory tract infections, you might need to postpone even the surgery and treat the lower respiratory tract infection sometimes, okay? And the patients with chronic lung diseases and stuff, chest physiotherapy, or the patient is going to have a major surgery, perioperative chest physiotherapy, incentive spirometry will help them to have a shorter stay in hospital setup, okay? And stop smoking is very important. That's why we are taking smoking history in the pre-op assessment, okay? So if the patient is smoking, we have to stop smoking. Even 1 day prior will benefit for the patient, okay? And modify the drugs. I told you we might need to modify the drugs that patient is on. So if the patient is on oral hypoglycemics for diabetes, we might need to stop or withhold the oral hypoglycemic drugs on the morning of the surgery because patient is fasting from the previous day. So we are withholding the morning dose on the day of the surgery. And if the patient is on antiplatelets, especially the clopidogrel, we are withholding it to 5 to 7 days before the spinal or the epidural blocks because it can bleed, okay? And if the patient is on anticoagulants, the patient is on warfarin, we need to convert it to enoxaparin subcut or a heparin infusion. If the patient is on enoxaparin, we need to withhold enoxaparin for 24 hours or heparin infusion 4 hours prior to surgery. So those are the drug modifications, very few examples of drugs modifications we might need to do. And fasting, you all know we need to do fasting for a surgery, okay? So we have few differences when you do fasting. So for solids, we do 6 hours. Clear fluids like water, plain tea, that is 2 hours. Breast milk, that is 4 hours. What about formula milk? That is again 6 hours. Okay, formula feeds go as solids, so it's 6 hours. But keep in mind, better to avoid over fasting. How can you do that? Avoid over fasting. So you, when you send a theater list, you are sending you mark it as 1, 2, 3, 4, 5, 6, 7, 8 like that. So when you send one by one, so you know how much with your senior's help, you might know number 3 patient will take into the theater at 10 a.m. So you can plan around what time this patient could be kept fasting. Okay, so otherwise every patient will be keep fasting at 10 p.m. But the patient can be go into the theater at 4 p.m. in the next day. So you are keep over fasting those patients. So please keep that in your mind. Okay, over fasting can do harm. All right. So other than those things, you have to give drugs to these patients. So you are giving new drugs sometimes to the patients. You are giving anxiolytics. Even though these patients are familiarized with the ward setups, they can be anxious thinking about the surgery. So you have to give anxiolytics, midazolam sometimes, diazepam sometimes, so drugs, and antacids and antiemetics prevent nausea and vomiting, especially with gynecological surgeries, ENT surgeries. You need to give those drugs. And analgesics, you can give paracetamol. 2 hours prior to surgery, you can give drugs, okay? With the clear fluids, you can give drugs. So this will be your last slide. Hope you are not sleeping. So other than those things, what else you can do? So you have to plan for the post-op care period. So you have now, you have done the assessment, you have optimized the patient. During the assessment, thinking about the comorbidities and the grade of the surgeries, the anesthesia team has asked to reserve an ICU bed. So you have to now book an ICU bed, and your responsibility is to check whether this ICU bed is available on the day of the surgery as well. You have to give a quick call and see whether this bed is available or not before sending this patient to theater. Okay, so that is your responsibility. And inform written consent for the surgery and the invasive other procedures when you send a patient to the theater. That is your responsibility. And the grouping and DT, and send a theater list then 1 day prior to the theater, usually before 12 noon to the theater, because then the anesthesia team, the theater team can be ready with the equipment, drugs, the pre-medication, everything can be they can get ready with everything. So 1 day prior, before 12 noon, they can be ready with, okay? And on the day of surgery, when you send the patient to the theater, do a pre-op checklist before sending the patient to the theater. So you have done this and this, you have done this before you send the patient to the theater. And when punctuality is very important when you are sending the patient to the theater, when you come to the theater, because theater time is very, very important. When you go abroad, you will see they will utilize theater time to the maximum. Even they do very. If you compare the cases per day, they do very less cases, but the theater time wastage is very, very minimal. Okay, they do very large paperworks and stuff. They will take time for that, but theater wastage time is very minimal when you compare to Sri Lanka. Okay, so punctuality, keep an in mind, very important even for a house officer. Okay. And the last thing I want to tell you about is, this is a teamwork. You are also a very important team member in this team. Even though you are the junior most, don't think that you are not important in this team. So you may be the one of the most important member in this team. Okay, so this is a teamwork. Keep that in mind. Actually, that is it. Any questions? Thank you for listening, and I wish you all the best on behalf of the Faculty of Critical Care Medicine from the College of Anesthesiologists and Intensivists of Sri Lanka. Any questions?
Mama. There is a question, Dr. Dilrushi, they ask, what if the blood pressure rises on the day of the surgery?
So actually it depends on the patient. So if the patient is a non-patient with hypertensive patient, if the patient is a non-hypertensive patient, we have to consider whether this. So let's say this. The patient's blood pressure rise can be due to patient is anxious. So you can see whether the patient is anxious. So when the patient is anxious, you can see the patient's heart rate can be high. The blood pressure is also high. So you can go through the patient's the blood pressure and the heart rate while the patient is on the ward. So you can obviously see if the both has gone up, the patient is obviously anxious. So patient, you can calm down the patient and see whether it's coming down. So if you, I hope that is the question from you, but if the patient is a non-hypertensive again, and the blood pressure goes up, and you have to go through the charts and see whether the patient has taken the high blood pressure, the drugs in the morning. If it is not, you can give the drugs and see whether it's going down. But you have to delay the surgery for a little bit and see, but you will be able to do the surgery on the same day. But if it is not a patient is not a hypertensive patient, and patient's heart rate is not that very, but still very high blood pressure. Let's say about young patient in 30s, blood pressures are very, very high, about 180s, diastolic about 120s. You are keeping the patient in the side and you have calmed down, but the blood pressure is still high. Patient is come for a maybe cholecystectomy, but blood pressure is still high. I would say you can calm down the patient and see whether it's coming down, but still you have not detected it's during the pre-medication. Maybe you might have to postpone, but it depends on the patient condition at the moment. Most of the time it is due to anxiousness of the patient, but you will be able to keep the patient at the site and reassure the patient and see. That would be my answer. If the patient's blood pressure is very high, but might have to refer the patient to the medical team and control the blood pressure and get the patient back in another day in a rare occasion. Is there any question? Any other questions?
Yeah, that's all in the chat box.
All right. In absence of any other question, I will stop sharing and I will hand over to the next speaker.
Right. Thank you very much, madam. So if you all have any questions, you can type on chat box. So next up is transport of critical ill patient by Dr. Anushika Senimiratna, consultant anesthetist and secretary for the College of Anesthesiologists. Over to you, madam.
Right. Thank you. Thank you, Roshan. Yes, for next half an hour or so, we'll be talking about this transport of critical ill patient. So you will be starting your internship very soon. So if one is wondering why I am learning this topic today, transport of a critical ill patient, actually in your career as a house officer, you will definitely face with one of these situations where you will have to transport a critically ill patient. Whether you are placed in the center or peripheries, you will invariably have to face this. So why we do this is to make sure that you are safe legally and to make sure that the patient is also safe and to reduce morbidity mortality during that will happen during a transport of a critically ill patient. So this why we talk about this is that we have to make sure that you acquire certain skills and you follow the standards or protocols that you're supposed to follow when you transport a critically ill patient. This may be your patient, maybe your parents, your family who has had a critical illness at a different center. So if your friend is following these same skills and standards, your own parents, your own family will have the same protocols being followed up, and their outcome will be successful. So you have guidelines. Global. The College of Anesthesiologists also have set up a guideline on transport of a critically ill patient, and this is based on this UK or NHS guidelines. It is freely available in College of Anesthesiologists and Intensivists of Sri Lanka website. So you can download it and have a look. Tell your friends as well if they are not logged in. So just have a look at it and keep a copy with you in your hospital so that it will save your actually time and life. Why we have developed these guidelines is to reduce the morbidity and mortality of a critically ill patient during the transport. At the end, the goal of critical care transfer would be that you transfer a patient from one end to another end in a safe and expedient manner, making sure that you maintain at least a near normal quality of patient care. That is, you provide the critical care environment, maybe suboptimal, but as much as you can, while transporting the patient safely and quickly from one end to the other. So this transfer could be inter-hospital or intra-hospital. Actually, even though you are placed in the center hospital, maybe in National Hospital of Sri Lanka or National Hospital Kandy, Colombo Kandy, you may face with one of these transport of a critical ill patient. So it could be inter-hospital, within the hospital, from one end to the other, from a ward to the ICU, or intra-hospital, intra-hospital, that is within the hospital, or inter-hospital from one hospital to another. So why we transfer a patient? Obviously, the main reason is maybe for a ICU care setup or availability of the ICU beds. But even though we have ICU beds in our setup, we may not have specialized care, say neurosurgical opinions or interventions, or primary PCI interventions may not be available in the hospital where you work at. And also we transfer the patient for investigations from ICU. We send the patients for CTs, MRIs for investigation purposes. So you may take the patient, hand him over, come back, or you will have to bring the patient back after the, say, certain procedure, investigation, or expert opinion has been sorted out. Right. So why we talk about critically ill patients transfer is because they are at high risk of instability. They are at high risk of instability even in ICU setup. So the risk is increased during a transport because we have suboptimal conditions during transport. They may tend to deteriorate because of the disease status itself. Suppose it is a full-blown ST elevation MI, and you are taking the patient for, say, primary PCI. So the patient has an increased risk of going into congestive cardiac failure, left ventricular failure, or arrhythmias, maybe a cardiac arrest. And on the other hand, we may have started him on medications such as inotropes, adrenaline, or adrenaline. So if you don't give the optimum care for these medications as in the protocols, the patient may lead into instability. Over treatment, under treatment, both may lead to instability of the patient. Why this happens is because they have a very poor compensatory abilities. Most of the people have low intravascular volume status, and whatever the physiological changes that takes place during this transport will aggravate their disease status and conditions. And as I said, we have suboptimal conditions for optimization, and also there will be suboptimal conditions for detection if the patient is being unstable or deteriorating during the transport. Just to touch about these physiological changes in transport, I think you may have had a lecture on this, but suppose if the ambulance may go at a constant velocity or may accelerate and decelerate. These definitely will happen during a transport. You can't avoid these because we are running in normal roads. So acceleration, what will happen is the patient will have less venous return because of these forces. So already a hypotensive patient will have a compromised venous return, and this hypotension will further aggravate. So the mean arterial pressure is reduced. This will further lead to reduction in the cerebral perfusion pressures. So they will have improper conditions in their central nervous system. And if it is a deceleration, that if it is a break, there will be massive rise of venous return suddenly to the heart. If it is a poorly compensated heart, the patient may push to a ventricular failure and will have a lot of consequences. And in the same time, this will lead to increased rise in the intracranial pressures. Especially one of the reasons for us to transfer patients from peripheries to center is for neurosurgical opinions with head injuries. So these patients will have devastating features. So that is why we have to know these the physiological changes could take place in transport. We'll have to try our best to minimize these things. So when you come into a transfer process, there are certain things that has to be fulfilled. That is, you have to identify the need of a transfer patient. There has to be a definite indication. And second thing is you have to make sure that there has to be agreement between the referring and the accepting ends. So this has to be a senior consultant or senior clinician's decisions by both ends. And you have to make sure the proper communication has taken place. Otherwise, you will be in trouble as well as the patient. It's unfair by the patient as well. And then there has to be handover from, if the patient is going from the ICU to the other hospital or maybe the ward to the other hospital, it may not be the same staff who will be going on. So the commonest example is if the patient is going from ICU, the HO is called for the transfer. Unfortunately, you will be the team leader for this transfer of critical ill patient. So you will have to hand it over from the ICU team, and then the transfer process takes place. And then you hand it over to the receiving end, and then the final part is you coming back to the base with the transfer team and the equipment. So certain guidelines have been laid out related to these segments. We will go through them in detail. So communication, as I've said, there has to be a communication, standard communication, written, documented before you take the patient. Otherwise, you will have a lot of legal issues and the patient will suffer as well. These had been happening. Transferring had been happening without proper communication. So make sure you have to ask your seniors if there is a proper communication has been done before the transfer. And apart from that, you may use this intensive care bed information system to transfer, but still the receiving end has to be informed about the patient because they have to prepare. Then second most important thing is you stabilize the patient before transfer. There is no point you rushing a deteriorating patient to another center, even if it is the ward setup. If you're taking the patient to ICU, if the patient is deteriorating, you have to resuscitate. And you have to balance the time taken to achieve this between resuscitating and taking him for the immediate transfer. And we have this pre-transfer checklist in our guidelines. So before that, you have to make sure that all these tick boxes are checked and the patient is stable. So you can use this ABCDE approach to resuscitate the patient. Well, starting with airway is to see if the patient has a patent or stable airway. If the airway is compromised or if it is at risk, if you are in doubt, don't take the patient on the transfer, because intervention during a transfer process would be actually nightmare. So if it is in doubt, you always consult your seniors and have a proper secured airway, tracheal intubation. That is the secured airway, because otherwise the patient will have complications and you will also fall into trouble. Examples for intubation could be a GCS, and you have certain guidelines to when to intubate in a trauma setup, airway trauma, facial injuries, and so certain burn injuries. Even though you think the patient's airway is stable, if you have facial burns and nasal soothes and then nasal hair curling, you will have to intubate this patient, because like on the way the airway swelling may take place. And if there is a risk of inhalational injuries, you won't have any features outside. But if the history is as such, you have to make sure you intubate. Otherwise, it will be a nightmare to intubate during the transfer. And head injuries, I've told you have guidelines. And once intubated, make sure you sedate the patient. Paralysis may not be necessary. You sedate the patient. And this is to make sure the patient is comfortable and to prevent any accidental extubation. You have to secure the tube safely and transfer. Breathing is, you have to make sure that the patient is either spontaneously breathing or mechanically ventilated, making sure that he is able to maintain his oxygenation and ventilation. So if the patient is mechanically ventilated, you have certain these maneuvers which you have to do with the ventilator. So as I've said, sedation if the patient is intubated, and you have to make sure you monitor the oxygen saturation and the end-tidal carbon dioxide if the patient is ventilated, to make sure that their oxygenation and ventilation or carbon dioxide removal is satisfactory. If pneumothorax is present, or if the patient requires prophylactic IC tubes, say in trauma situations, you have to make sure that they are patent and they are below the level of the patient and unclamped during the journey. You have to make sure they are unclamped. And nasogastric tubes, have to keep it unclamped as well. Coming into circulation, he has to have minimal 2 IV accesses. If it is a difficult cannulation patient, make sure that you have a central line, because if it is difficult, you will never be able to put a cannula in case of an emergency during the journey. And you may need to have arterial cannulas in compromised patients, which will be placed from the ICU setup. And you have to make sure that the patient is continuously monitored with blood pressure, heart rate, and maybe pre-transfer hemoglobin levels. And of course, you have to control the continuous bleeding points and the fractures. If it is there, it has to be splintered to make sure that the bleeding doesn't take place. And transfusion, you may transfuse on the way as well, where the grouping and cross-matching has been done from your center. You may start it on the way, or you may take the blood products with you. You may not feed during the transfer. So disability is this blood sugar, pupils, and JCS. But I would say this commonest indication for this transfer is the head injuries. So you have to make sure that the patient's oxygen levels are fine, the carbon dioxide levels are fine. Otherwise, the patient will have unwanted secondary brain injuries. You sedate if needed. You paralyze the patient. You make sure the blood pressure levels are stable, and control of seizures, temperature management, and blood sugar management. And of course, if C-spine injury is suspected, you will have to stabilize the C-spine, its cervical collar, and spinal injury is suspected. The patient may be transferred in a spinal board, but you have to make sure that the duration of this journey, because you can't transfer the patient for about 6 hours in a spinal board. You may have to talk with the seniors what the alternative options you could do when you're transferring these patients. Apart from that, you have to make sure these electrolytes, acid balances are looked into before transfer. This is just a picture of cervical collar and patient's spinal board where you have to log row. Right, now we have had a look at the patient, has done this initial resuscitation, and then after that, we are ticking this pre-transfer checklist and to make sure that the patient is stable before the transport. Right, and with that, you have to make sure that you have all the equipment and drugs which is required for this transport. This is an appendix which you can find in our guideline. It is extensive. You have to make sure you check with your nurse who is going on the transport on the journey with you that the patient, the emergency bag has all these equipment. You can categorize it as ARV equipment, breathing, circulation equipment, and other additional equipment. Whatever it is, you have to make sure that this emergency bag which you are carrying has to be tailor-made to the patient. If it is an adult patient, no need of carrying out all this pediatric equipment. So make it a habit that you have a peep at the emergency bag which the nurses have prepared and take off all unnecessary drug and equipment, because it will lead to a lot of hassle if you had to open the bag on the way and to see you will find it difficult to find the relevant things if there are a lot of jargons. So clean it and tailor it according to the patient. So these are the certain equipment that you will have to take with you, the self-inflating bag and the circulation items. And then this drug and equipment has to be stored nicely so that the operator can maneuver it, as well as it has less hassle to these travelers, and then they are properly secured and their optimal or estimated function is being done. So if you have a trolley like this, which is in the picture, and if you can organize your stuff like this, it will be much easier and your life will be easy. And the drugs, you can check if these drugs are available. You have to make sure all these emergency drugs, and apart from any other drugs which is relevant to the patient has to be taken off. Apart from emergency drugs, you have to take these sedatives and paralysis analgesics as well. And you have to make sure the resuscitation drugs, that is basically your adrenaline and atropine, is drawn up. And if the patient is on inotropes, make sure you calculate the requirement and prepare this 50 cc infusion syringes accordingly, because it is difficult to make it on the way. You ask the nurse if we have everything in handy prepared, especially resuscitation and the inotropes. I told you, you can take the blood if you think it is necessary, a cross match from your center. Fluids, you may need to take fluids with you. And then the other drug, which is most important thing, is the oxygen. Right. Now, you should have a basic idea about these oxygen cylinder types, oxygen regulators, and about these oxygen keys and humidifiers in your setup. And then you should know how to calculate your oxygen requirement as well for the patient to prevent getting into trouble on the way. All right, this is just a description of types of cylinders. You may know this, the biggest size we have is the jumbo cylinders, and the standard size which is used in the ward setup is size E cylinder. The nurses usually call it 4.7 liter cylinders, that is the internal capacity. But if a cylinder is full, oxygen cylinder is full, it may liberate E cylinder. I'm talking about E cylinder. It may liberate 680 liters of oxygen once it comes to the outside pressure. So this is the E cylinder which you have to be familiar with, and its height is about 31 inches. Right, now how are you going to calculate? Usually you need twice the patient requirement, and some ventilators would require some basal basal oxygen flows for it to function. It is actually minimal, we will keep it aside. Then you'll have to calculate the patient requirement and take twice. If you are going to come back with the patient, so you'll have to take actually 4 times. Right. Say for an example, now you are transporting a patient who is mechanically ventilated. Tidal volume is 500 and the respiratory rate is 10. He's on 100% oxygen. So whatever he breathes in, he needs oxygen. Right. Now, I'll give you 10 seconds to think how much of oxygen would you need. And just think how are you going to calculate. Right. So unfortunately, this is not a interactive session. When you think of calculation, this is actually one of the very simplest example. So the patient's tidal volume being ventilated is 500, rate respiratory rate is 10. So when you calculate the minute volume, it will be 5 liters per minute. So he will need 5 liters of oxygen per minute. So if the patient is going on a 2-hour journey, 120 minutes, so he would need 5 liters into 120 minutes, that is 600 liters for the whole journey. Right. So if you can remember this E-cylinder, if it is full, we'll have about 680 liters. So if you can take twice the requirement, that is two full E-cylinders, that would be adequate. But mind you, these cylinders has to be full, that is at 137 bars, 137 for you to calculate according to this. If it is less than 137, there are certain other calculations, but it's complicated. But for you, just make sure you calculate it from the full cylinders and you open the cylinder full and see if it indicates 137 at the pressure regulator. Sorry, pressure gauge, right? And we will come on to another situation. This is inside the hospital, you are transferring the patient for a CT from ICU. Total journey is 30 minutes. And they have opened the oxygen regulator at 10 liters per minute. So you would need 300 liters. Twice the requirement is 600 liters. So you have to make sure you take 1 full E-cylinder. Right. So the other thing is, now I have told you, you have to be familiar with these oxygen keys. You have to make sure that these certain oxygen cylinders, you need keys to open the cylinder if there is no handheld wheel. So you have to make sure you discuss with your supportive staff if the key is available, otherwise no point taking the oxygen cylinder. And also you have these regulators, whether it's a full nose one or the other one which you have to connect to a ventilator. So you have to make sure that according to the patient's requirement, you can discuss with the anesthetist whether the correct regulator part is being mounted to this cylinder. Right. And then the other part is monitoring. The minimum monitoring standards are availability of appropriate trained staff, because we are transporting a level 3 patients, that is critical care patients. With that, there has to be continuous, must be ECG, blood pressure, saturation, must have ETCO2 if the patient is ventilated, and temperature monitoring. And the ventilator which you are going to monitor should be able to measure this fracture inspired oxygen concentration, ventilator settings, and airway pressures, which I'm not going to talk into details. And make sure get it to a habit that you have alarms visible and audible, and it has to be tailored to the patient. Suppose the patient's heart rate is 110, and if the alarm setup is at 100, if the highest heart rate alarm is 100, it will start to beep throughout your journey. So you have to make sure it adjusts according to the patient, so that you are vigilant and when a new alarm is summoned, something wrong is happening. I'm sorry if this person who has opened the mic, can I mute her? I can mute her. Right. Okay. Okay. And the other thing is Now we have discussed about monitoring and the personnel. Unfortunately, the guideline says the transfer has to go with a senior experienced doctor, but still up to date the practice is we send the house officer with the transfer. This has to be changed actually, depending on the patient's requirement. It is better that a senior person is being accompanying the patient, but if you are the person which will have to go on the journey, you have to make sure that you are competent with all this patient's history and his condition, and whether all these necessary equipment are there for you to accompany a safe journey. And you have to make sure that you have this appropriate experienced nurse and this supportive staff, and you and the team should be familiar with whatever the equipment which is mounted to your ambulance. And mobile phones is a must these days, and you may need money for the transport. Just have some pocket money in hand, right? And we have discussed all these, and the last one is this documentation. Before that, this is the checklist too. Now we have done the patient resuscitation checklist, and just before transfer, we have to make sure this checklist is fulfilled, checklist 2, and this will make sure or ensure that you are safe just before the transfer, right? And then the documentation. The recommendation is to document the patient's vitals during the transfer in duplicate, and may be difficult, challenging, but make out your own way how to do this documentation. It must be there for legal purposes as well, right? And then safety, of course, you have to make sure that the patient is secured safely in the transfer trolley. All the equipment is safe. And if emergency takes place, no point trying to resuscitate while the ambulance is being ridden. You stop the vehicle and then administer the treatment. And then you may bypass to a nearest hospital. And high-speed travel is not necessary. Mind you, all these ambulances, drivers, they will have to obey the normal law, the road or this traffic law of Sri Lanka. You may use the siren to bypass this traffic, but otherwise the driver will be sued if they are breaking the normal traffic rules unnecessarily, because they are meant to follow these normal rules, right? And then if you have this specific accident insurances and membership of a defense organization, you may proceed with that, because these may lead to legal implications. And if it is a child, you can have a parent, one parent for the transfer, and you may allow them to see the child after transfer. You may accommodate them in the ambulance. And once the patient is transferred, you hand over. Certain handing over has been done at pre-transfer setup as well during this decision. And then at the end, at the receiving end, you have to do the transfer, separate the medical and the nursing officers. And the patient should have all this summary of what happened and all the investigations which had been done. And the method of communication back to this base hospital, the base station, and also the relatives information. Right. So certain ambulances are fully equipped. So it is best get yourself familiarized with the ambulances available in the setup where you work, so that you are familiar and confident about the things which are there. And some ambulances are very well equipped, and then so in these situations you don't have to worry about this equipment, but you have to make sure that they are in the proper working condition. And then you have to make sure this post-transport decontamination also takes place. Just talk to this ambulance assistant and the driver if they are being done properly. So, to improve this safe transfer, we have to get this knowledge into practice, maybe by simulation setups, maybe with a discussion, maybe participating as an assistant in transfer team. You may gain experience. And as I've told, this will be the last slide. As I've told, you will be the team leader in this transfer. So just before the departure, you take about 5 minutes and you know who is going to be with you, the nurse and the supportive staff. And then you brief them what the patient's condition is, why we are taking this patient, and what are we going to do if an emergency takes place, what are the possible emergencies that this patient could face. Likewise, you brief the team, and then once the transfer is done, it is always nice to thank this team, especially the ambulance drivers and the assistants, so that you will continue to have a great bond between them for your further transfers as well. Right, and that's about it. Dr. Roshan, are you there? I'm done with the pitch.
Yeah.
I don't know if
Yeah, thank you very much, madam. So if you all have any question regarding transport, we can take few minutes to answer those. Okay, so next up lecture is by Dr. Queenie Veerasingham, consultant anesthetist Abhisavella, initial management and resuscitation of patient with head injury. So until she starts up the lecture, so we can take this time to answer questions. So we have about 5 minutes. So if you all have any questions regarding today's lecture topics and current lecture, we can take this time to ask questions from Dr. Anushika as well. Okay. So tomorrow lecture starts at 9 a.m. So we have starting from anaphylaxis, communication, and so these are the lectures for tomorrow. Anaphylaxis, communication, general management in ICU, then shock and inotropes, cardiopulmonary resuscitation, sepsis, fluid management, acute kidney injury, and management of massive hemorrhage, and acute pain management. So those are the very interesting topics tomorrow. So that's that. So make sure that you'll ask question, use this opportunity to update your knowledge and all that. So that's that.
Okay. Just me. Hello, can you all hear me? Can somebody say whether you can hear me, please?
Can hear, madam. Yes.
Okay. Okay. So I'm Dr. Veera Singham. Good afternoon to everybody. We are talking about the initial management and resuscitation of a patient with traumatic brain injury or head injury. My lecture has 50 slides, but most of them are pictures, and I talk fast. So at the end of the lectures, you can ask me questions. Okay. Right. Okay. So I'm going into some statistics in Sri Lanka regarding traumatic brain injury. It's a leading cause of hospitalization in Sri Lanka, that is trauma, but trauma counts for about 600,000 patients per year, patients getting treated in government hospitals. Okay. So most of these traumas result from road traffic crashes, road traffic accidents, right? So actually the road traffic accidents have increased by 249% between 1977 to 2004. So I have got data only up to 2004, right? Right. So also road traffic fatalities have increased by 160%. That's mainly because of the number of vehicles that we are using. Okay, so those are all trauma Secretary Ministry of Health, Sri Lanka. Right. Now we'll come to head injury. Out of the road traffic traumas and out of all traumas, deaths. 1/3 of deaths are caused by head trauma. Right. So if you get a head injury, the death rates are higher. Large number of patients are treated for traumatic brain injuries in emergency rooms everywhere in the country, and nearly 1/4 of them are hospitalized each year. And the pathetic part is that their age group is from 15 to 24 years. Right? So the peak admission age group is that. So if you look at the progress of traumatic brain injury in 1980s, there was 36% of mortality, but in 2000 mortalities have reduced to 12 to 14%. But we are just wondering what the functional neurological recovery of all these patients. Right. So in this presentation, we are trying to answer some of the questions relevant to traumatic brain injury. What are the primary brain injury and secondary brain injury? What happens in a traumatic brain injury? We must know a little bit of pathology, and how to prevent secondary brain injury with resuscitation of a traumatic brain injured patient with oxygenation, ventilation, fluids, certain maneuvers and drugs, and also how to stabilize a patient with traumatic brain injury before transfer to a neurotrauma center. Right. So classification of traumatic brain injury, we use the GCS score, Glasgow Coma Scale. We say that, so you know that the GCS, the maximum number you will have is 15. So a mild injury of a traumatic brain injury is a GCS being 13 to 15. A moderate injury is a GCS 9 to 12, and severe injury is a GCS 8 or less. Right? We need this classification to do certain maneuvers for these patients. Again, traumatic brain injury is classified into primary injuries and secondary injuries. Primary injury is the one which happens during the impact. Right, so we might not be able to modify that primary injury unless we do surgery, right? But the secondary injuries are subsequent brain injuries which happen after the primary injury, which we can prevent. Right. So as I said, the primary brain injury can be closed head injuries, blunt traumas, or open head injuries. Right. So the closed head injuries, you will not see any injury from outside.
you might not see a skull fracture or laceration or even a CT showing CT films, which they might not show any hematomas or cerebral edema, but these are, for example, these are called diffuse axonal injury. So you can't see any obvious lesion of a trauma. Open head injuries are the ones which we say penetrating injuries, depressed skull fractures, and basal skull fractures. But apart from that, you have got intracranial injuries like intracerebral hemorrhages, which are called ICH, extradural hemorrhages, EDH, or subdural hemorrhages, SDHs, and subarachnoid hemorrhages, SAH. Right? Okay. So in this picture, you can see an EDH. I'm just showing these pictures. You don't have to diagnose this, but you must be a little bit familiar of them and know what will happen to these patients, right? So this is an EDH. You will have your hemorrhage or hematoma beyond the dura. So there is a crescent-shaped hemorrhage, white area in the CT, right? That's a subdural hemorrhage. So you will see a hematoma beneath the durameter, and that is not crescent shaped, but you will see that in a CT film in this manner, right? Diffuse one. So these are all intracerebral hemorrhages. They are inside the brain matter. They might even extend to the ventricle, as in the CT film here, or they might not. Right? Okay, this is a subarachnoid hemorrhage. Now you can see all the sulci are filled with hemorrhages, and it might cause brain pathology. But if you in a postmortem brain, you will see the subarachnoid hemorrhage as such. Right. So looking at all these hemorrhages and the primary brain injuries, we'll just look at the pathophysiology of traumatic brain injury. Now you need a little bit of physiology to know. So just remember certain things. The brain has a blood flow of 50 milliliters per 100 grams per minute, right? The normal intracranial pressure is about 7 to 50 millimeters mercury. So if we have a ICP of more than 15, we call it abnormal. And if it is more than 20 or 25, we call it pathological, right? Cerebral perfusion pressure, you must know this equation, equals mean arterial pressure minus intracranial pressure and intracranial venous pressure, right? So for example, regarding the map, you know, mean arterial pressure is calculated as diastolic blood pressure plus 1/3 of pulse pressure. Pulse pressure is systolic blood pressure minus diastolic blood pressure. So if you have a blood pressure of say 120/80, your mean arterial pressure is somewhere around 90. So I have given an example in the 4th row. CPP equals 90. That's our normal mean arterial pressure minus, usually our intracranial pressure is less than 10. So 10 minus, usually our intracranial venous pressure is 0 when we are seated up, because the venous drainage is towards the heart, so that is 0, right? So your cerebral perfusion pressure, if you have a systolic diastolic blood pressure 120/80, is about 8, right? Cerebral perfusion pressure is very important because that's the pressure causing the blood flow to the brain. If you don't perfuse the brain, it's going to die, right? So cerebral perfusion pressure is normally constantly maintained because of autoregulator mechanisms inside the brain. So cerebral perfusion pressure is calculated by deducting the intracranial pressure by our mean arterial pressure. So you will, I'm enforcing the value of the mean arterial pressure or maintaining a normal or a little bit higher blood pressure in a person, right? Especially in a person who has increased intracranial pressure. So if your patient's traumatic brain injured patient's intracranial pressure is high, you must have a higher mean arterial pressure. That's one point I want to highlight. Right. So I just said that the cerebral blood flow is auto-regulated throughout a range of mean arterial pressures. So if you take the cerebral perfusion pressure on the x-axis and cerebral blood flow on the y-axis, you can see between a cerebral perfusion pressure of 40 and 140, the cerebral blood flow is regulated, a straight line, right? But if your patients got a high intracranial pressure, the cerebral perfusion pressure is increased, right? And that curve will shift to the right side. And I have said there that injured brain patient will have that dotted line of cerebral autoregulation and cerebral perfusion pressure. Right. This is a hypothesis that you should know if you are going to treat a traumatic brain injured patient, the Monro-Kelly hypothesis. In this hypothesis, the pressure volume relationship between intracranial pressure, the volume of CSF, blood and brain tissue, and cerebral pressure is depicted. So it's known as the Monro-Kelly doctrine or Monro-Kelly hypothesis, which states that the cranial compartment is incompressible. That's true for adults, right? And the volume inside the cranium is a fixed volume, not capable of expanding. So the cranium and its contents, for example, the intracranial blood, CSF, and the brain tissue creates a state of volume equilibrium, right? So that any increase in volume of one of the cranial constituents must be compensated by a decrease of volume in another. For example, in a traumatic brain injury, if there is a hematoma, initially what your body does is to push off the CSF and the blood in the brain of the traumatic brain injured patient, right? Because our cranium cannot expand like other parts of our body. Right. So here in this chart, I'm showing the intracranial volume in x-axis and the pressure in the right axis. Initially, in a compliant state, you will see that whatever the volume increase, your intracranial pressure is going to be constant. That is called the compliant period, or that is the time when your brain pushes out the CSF and the blood from inside of the brain constituents to compensate for the intracranial pressure, because increasing in intracranial pressure is deleterious. And during a reduced compensatory phase, you will see that your intracranial pressure is rising. And in a very poor compensatory phase, the third phase towards the right side, you will see a sudden increase in the intracranial pressure, which is not good and which will cause bad effects on your brain. Right. So what happens if you increase your intracranial pressure? Increase of this intracranial pressure can happen with intracranial hematomas or brain edema. Those can either crush your brain tissue, which is not good, shift the brain structures, contribute to hydrocephalus because of the compression, cause the brain to herniate, and restrict blood supply to the brain. So if your brain is going to herniate, it will be like this. If you have a skull fracture, you can have extracranial cranial herniations. The brain matter will come out of the defect of the skull outside, right? Then there is what is called, you might have heard, midline shift, or what we call as subfalcian herniation, which is herniation of one side of the brain matter to another side, right? That happens when there is a hematoma or either edema on one side, the brain matter will shift onto the other side beneath the falx cerebrum, right? So that we call midline shift or subfalcian herniation. Again, you can have descending tentorial herniation, right? DTH, which can be in the central part or which can be on the lateral side. The brain herniates down through the tentorium cerebelli, right? So it could be the brain stem or the temporal lobe, the part of the temporal lobe, right? Another herniation is what is called tonsillar herniation. Cerebellar tonsils can herniate through the foramen magnum. Right? So all these herniations can have bad effects on your respiration and the cardiovascular system. Okay. So if you look at the response to head trauma, now again I'm coming to the Monro-Killing hypothesis. The cranial vault is a fixed space. It's a closed box. Brain tissue, CSF, extracellular fluid, and blood are there. Right? Expansion of one compartment has to be compensated by reducing volume of another compartment. So that's the compensatory response needed, right? So initially there might be vasoconstriction, reduced blood flow, and movement of CSF out. But eventually, further expansion of this intracranial contents results in increasing ICP because there's a limit to putting out CSF or blood. So there will ultimately, when there is a high pressure, you will not perfuse your brain, and the perfusion is compromised. There will be cerebral ischemia because there is no perfusion, and ischemia affects your neurons badly. So there will be neuronal injury. And when there is injury, there will be cerebral edema and further increase in the intracranial pressure. And then your herniations, as I said earlier, will start, and herniations can lead to death because herniations can compress your vital centers like respiratory center and cardiovascular center. Right. So brain trauma and ICP is one of the most damaging aspects of brain trauma, and other conditions directly correlate with poor outcome is the elevated intracranial pressure. So increased ICP is no good. ICP is very likely to cause severe harm if it rises too high, and very high intracranial pressures are usually fatal if prolonged. But children, because their skull vault is not fused, they can tolerate higher pressures for longer period, not like adults. Right. So we come to this vicious cycle. Increased intracranial pressure reduces cerebral perfusion pressure, and because there is a reduced cerebral perfusion pressure, our body develops a reflex called Cushing reflex, which tries to cause a hypertension so that you increase your MAP, right? So reduced CPP causes a hypertension. Because of the hypertension, you get a bradycardia. That is the Barrow reflex, right? So all these patients with increased ICP, you will see a high blood pressure and a bradycardia. So please don't go to treat that high blood pressure or the bradycardia. Okay, that's a internal reflex mechanism for increased intracranial pressure. And the bradycardia and the hypertension tries to increase the cerebral blood volume. It tries to pump more blood to the brain because the brain is suffering ischemia. So anyhow, though that tries to pump blood, the intracranial pressure rises further. So at one time, because of the reduced cerebral perfusion pressure, neurons can suffer ischemia and then infarction and then death. Right. So we'll come to the management of traumatic brain injury. Right. So basic principles, you have to address the primary insult, which is neurosurgery. So you have to transfer the patient to neurotrauma unit, or if you're lucky if you have a neurosurgeon in your hospital. But before that, you have to prevent secondary insults. So secondary insults are due to hypoxia, hypercarbia, hypovolemia, hypotension, acidosis, etc. So you have to avoid them. So you can do that at any hospital, right? Even if you don't have a neurotrauma unit. Okay. Right. So now I said you have to transfer these patients to a neurotrauma unit. So a transfer should be what is called a high quality transfer. So in this lecture, we teach that how to transfer patient to a neurotrauma unit with proper things, right? So high quality transfers will improve your outcome. Yeah, but this transfer is often very urgent. Right? So any brain trauma patient needs cervical spine stabilization till you rule out cervical spine injury. So cervical spine immobilization should be maintained until full risk assessment and indicates it's safe to remove, right? So till you take x-rays or till you do imaging studies properly, you have to have the cervical spine stabilized, right? So these transfers to the neurotrauma unit can be primary transfers or secondary transfers. Primary transfer is a one which you promptly transport people with suspected traumatic brain injury directly to center where traumatic brain injury is managed, right? So suddenly you get this patient and then transfer. But that might not be possible in all places, and that might not be possible when patients have to be resuscitated. So secondary transfer is if you have the primary transfer impossible, from transfer of these patients of suspected traumatic brain injury directed to a center where stabilization and resuscitation can happen before transferring to the traumatic brain center, injured center, right? So secondary and primary transfers, many of us will do a secondary transfer. Before transferring the patient to a neurotrauma center, you have to stabilize the patient, resuscitate. Okay. So how do you do this secondary transfer? In this secondary transfer, decision to transfer should be made by senior medical staff at the referring hospital in consultation with senior staff at neurosurgical unit. So you have to usually tell that this sort of a patient is coming so that they will be prepared to cater for this patient immediately. And also, before you transfer, you must resuscitate and stabilize the patient because during your transfer, certain things can happen during the physiology. So to avoid all that, all complications en route, you have to stabilize and prepare the patient for transfer. Fine. So I highlight on preventing secondary insults. I said earlier, some of the secondary insults which can increase intracranial pressure. So they are hypovolemia, hypotension, hypoxemia, hypercarbia, and acidosis, and also brain edema, seizures, hypothermia, hyponatremia, hypoglycemia, and extreme hypocarbia, carbon dioxide below 27 millimeters mercury. Right? So all these things, insults, can cause further cerebral edema and increase your intracranial pressure, which we don't want. Okay. Okay, so I'm coming back to our basic equation. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. Right. Our goal is to maintain a cerebral perfusion pressure above 70. So I taught you now example of 120/80 systolic diastolic blood pressure. We have a cerebral perfusion pressure of about 80. So at least we have to maintain a goal of cerebral perfusion pressure above 70, right? So this is achieved by one, vascular volume expansion, right? Second is by CSF drainage, because here the ICP will be high. And third is by systemic vasopressors after adequate fluid resuscitation, right? Now, if you lower the cerebral perfusion pressure less than 70, it's associated with poor outcome. So coming back to resuscitation in traumatic brain injury, avoid hypovolemia, hypotension, and hypoxia, right? So initially, please give oxygen. You have to give adequate oxygen to have PaO2 of more than 100 millimeters mercury in your blood gas. So most of the hospitals now have blood gas machines. Even if you don't have a blood gas machine, please make sure that the patient's saturation is above 95 millimeters mercury, right? Also, you must have a mean blood pressure, mean arterial pressure more than 80, right? So your targets is to have a mean arterial pressure more than 80. So please give IV fluids. If you think volume is enough, please start on vasopressors, right, to increase the mean arterial pressure, right? Also, you must have carbon dioxide around 35 millimeters mercury. Now the recent Brain Trauma Foundation worldwide recommends to have a carbon dioxide 35 to 45, not to go above 45, because if you have more carbon dioxide, you will cause cerebral vasodilation and increase the intracranial pressure, right? If you drop the carbon dioxide below 27, there will be cerebral vasoconstriction and poor blood supply to the brain, right? So if you have a blood gas, I think it's better always to have a carbon dioxide around 35 millimeters mercury. Right? So we'll come to airway breathing and oxygenation. You must have appropriate respiratory support, right? If the patient needs intubation, you must intubate early after your primary survey resuscitation. Okay, so patients who need intubations are GCS less than or equals 8, or if your GCS has fallen by 2 points since admission, right? Or if a motor score has fallen by more than 2 points since admission, right? Or even some don't say, even if the GCS is above 8, but you're planning to transfer, say for example, GCS is 10 or 11, but you're planning a journey, a transfer journey for more than 1 hour, where you will think that this patient's GCS might drop below 8, right? Then also you can intubate, right? So intubate requires sedation and muscle relaxation. Without sedation or muscle relaxation, we are not intubating this patient, because if you try that intubation without sedation and muscle relaxation on this unconscious patient, you might increase the intracranial pressure and have a herniation or cerebral edema getting. Intubation, as I said earlier, has to be done after primary survey and resuscitation is completed, right? So in the primary survey, you will look at the airway, cervical spine stabilization, breathing, circulation of the patient and establishing circulation, neurological dysfunction assessment, AVPU, and exposure. And once you have stabilized the patient after primary survey and resuscitation only, this intubation happens, not before that. Okay. So resuscitating the patient before intubation is very important, right? Because you must have a satisfactory peripheral perfusion, a BP, and a urine output. So it should be normal or supranormal before transfer, meaning hematocrit more than 30% is very good, right? So that means an HB above 10. If you think that a patient needs central venous catheter, yes, after stabilizing the patient, but not always. It's all okay to have 2 large bore cannulas placed in the periphery before transfer. And don't transfer patients who are hypotensive despite resuscitation until the cause of the hypertension is identified and treated, right? So these patients who are coming after a road traffic accident with head injury, severe head injury, might be having a legal laceration and needs laparotomy before transfer. So laparotomy comes before the head injury part, okay? Right, and the control of bleeding comes before head injury part, right? So correction of major hemorrhages take place over transfer, especially if you have scalp lacerations and bleeding. Please mend them. Please suture them, because scalp has a rich blood supply. So you have to stop the bleeding before transfer. If patients have seizures, please consider giving anticonvulsants like phenytoin sodium. So also unstable compound long bone fractures have to be toileted and splintered before transfers, because they will get worse and they will bleed. Especially a femur fracture can bleed about 2 liters. Okay. Regarding these patients' fluids, fluid restriction is very dangerous. Why I say that is, some might think that these patients are having hypertension, so we don't give fluids. No, hypertension comes for head injured patients when there are increased intracranial pressure. There is a Cushing's reflex, right? So Cushing's reflex tries to maintain a cerebral perfusion pressure. So fluid restriction is dangerous in these patients. Please give fluids. The goal is to have a euvolemia, normal volume. It's always better to use isotonic fluids like normal saline. Normal saline is a little bit hypertonic actually, and it's very much better in head injury resuscitation. And also we can give ringolactate, but ringolactate is a little bit hypotonic. Ringolactate has a osmolality of 270. Our normal body osmolality is 280 to 290 milliosmoles per liter. Right. Hypertonic saline is very good for traumatic brain injury registration, it improves survival. So there are regimes to give hypertonic saline. If you ask the neurotrauma unit, they will say 150 milliliters BD. Okay. And avoid dextrose solutions because they are hypotonic, right? So they will worsen the cerebral edema. They also cause hyperglycemia, which can worsen cerebral edema. These patients should not have a low sodium, right? So avoid hyponatremia and give blood and blood products if required. Like if you have a scalp laceration which has bled a lot, or if the patient is pale, please give blood and blood products, right? Some of them might be on anticoagulants or antiplatelets. If you have to do platelet count and PT-INR, if the traumatic brain injured patient's INR is deranged, you have to rapidly normalize with vitamin K, FFP, whatsoever. Otherwise, the hemorrhage will worsen. Right? You must know certain cerebral protective drugs which we use on these patients, which are good to use. So for sedation, it's good to use benzodiazepines, midazolam, and you will also see if you call an anesthetist to intubate, they will use propofol or tapentone sodium. So tapentone sodium is a barbiturate, which protects the brain. Propofol is a brain protecting drug, so those are good. We don't use ketamine. Ketamine increases intracranial pressure, so please don't use ketamine. Analgesics, you can use opioids like fentanyl and morphine. Muscle relaxation, vecuronium is a cerebral protective muscle relaxant. People for easiness use atracurium, but more than atracurium, there are no contraindications like vecuronium is excreted by kidney. If the patient doesn't have CKD, you can use vecuronium, right? Vecuronium is the best drug for traumatic. Maintaining G8, or if you do surgery, you can use isoflurane, which is a cerebrum. So all are cerebral protective drugs, like phenytoin, tapentone sodium, infusion, or even
Right. Any questions you all have, you can ask. Okay, so if you all don't have any questions, we can
hello.
wind up today's
Hello,
program.
can you hear?
Hello.
Microphone.
Dr. Roshan, I think she got disconnected.
It's disconnected.
Yeah.
Okay.
Yeah, it's not lecture is not over.
Over here. Can you hear, Nandika?
Yes, we can hear you, but not seen yet.
Yeah, it suddenly got disconnected.
I can understand.
I'll go back to my. Okay. Hello.
Hello, we can hear you, Dr. Queenie, but not yet the screen.
Okay. Wait. Can you see the screen now? Can you hear?
Not yet, Dr. Queenie.
I'm sharing the screen. Can you hear? Can you see? No, not yet.
Not yet. In Dr. Roshan, can you please make a screen share?
No, I have nothing
It's
to do
there,
with
need, yeah.
Yeah,
Oh,
madam, you have co-hosted. What you have to do is close the existing presentation and open
Yeah.
it and reshare it.
yeah, 1 minute.
Yeah, sure. I'm sorry, I didn't hear I just came in from a meeting.
Now wait. It says that my hello. Can you hear?
Can hear, madam.
Can hear, no? Right. It says my microphone is muted. Which I don't know how to get over it.
It's not muted. You can hear you. Now muted.
Now it's not muted, isn't it?
Yes.
Yeah. Okay. Now how do I
Open the presentation and then share it.
Okay. Can you see now? No.
Madam, your name goes as what? May I check again?
Senujala Gevanna.
Sorry, come again. Sorry.
Senujala Gevanna. It's my son's name.
Tinujaga Lagivanam, no?
Yeah.
Yeah.
Now I can't share my screen. Why is that?
Madam, can close the previous this presentation and just open it again and
Okay,
go
I'll
to
do.
screen sharing and just once you get blue color, then you start sharing it.
Okay, right. Thanks. Sorry about that.
We can see you now, madam. The presentation we can see. Just share to start your phone.
Okay. Is this seen?
Yeah, we can see your WhatsApp now. Yes.
Can you see the screen?
Now, yes.
Can see the screen?
Yeah.
Okay.
Yeah.
Okay. I'm on the slide. Okay. Right.
Thank you, Dr.
Okay. I'm unable to. Thank you. Sorry for the delay. Now I'm unable to put it into the slideshow. Wait a minute. Can you hear? Can somebody respond?
Yes, Dr. Queenie, we can hear you now. Screen also we can see.
Screen on. Okay. I'll go to the screen, the place where I just stopped. Okay. Right. So I was trying to intubate a patient. Okay. Right. So this patient is going to be a difficult intubation because you can't do head extension or neck flexion. So you have to call the anesthetist actually because it's a difficult intubation. And here we pre-oxygenate the patient before intubation, and we do only chin lift and jaw thrust. Now you will see in that picture, we didn't extend the neck or flex the neck. Okay. Right. So for that, we use what is called a manual inline stabilization. Somebody else will prevent the head extension and neck flexion, right? And we do what is called a rapid sequence induction because all these patients are considered full stomach, so they can regurgitate their gastric contents. So we have to apply a cricoid pressure before intubation, and we do this intubation with opioids like fentanyl or midazolam and thiopentone or propofol and succinylcholine. Right, so we use a analgesic opioid, we use a sedative, midazolam or thiopentone or propofol, and we use a muscle relaxant. Three drugs we use mainly. Right. So apply the cricoid pressure when the patient goes to sleep and intubate, cuff, and check air entry. Tape the endotracheal tube around the mouth, and you shouldn't tie the endotracheal tube around the neck, because if you tie the endotracheal tube around the neck with the gauze bandage, it will compress your venous drainage from the brain, like it will compress your internal and external jugular veins, and then intracranial pressure will rise. Right. So after intubation, this patient has to be sedated with morphine and midazolam, either infusions or intermittent boluses. This patient has to be paralyzed till the patient goes to a traumatic brain injury center. So the preferred muscle relaxant is vecuronium. I said it's cerebral protective, but if you don't have vecuronium, you can use atracurium. You must at all costs avoid coughing, bucking, straining to prevent increase in intracranial pressure. Right. So after intubation, you must maintain that adequate sedation with opioids and benzodiazepines. You must give analgesia and muscle relaxation. So you have to give all those three till you go to the neurotrauma center. And also you avoid hypertension and reduced ICP. Now, when you give this sedation analgesia, you tend to have hypotension. You have to correct them with IV fluids or even vasopressors, because hypertension can reduce your cerebral perfusion pressure. And all these patients get ventilated either AMBU or with a portable ventilator to achieve oxygen PaO2 in your blood gas above 100 and carbon dioxide of 35, right? So if you don't have blood gas analyzer, you must make sure that the oxygen saturation is 100 with a pulse oximeter. And if your transport monitor has a ETCO2 monitoring, around 35, right? So some monitors might not have a ETCO2 monitor, entitled carbon dioxide monitor. So your inspired oxygen should be guided by blood gas estimation before departure. So everything has to be stabilized before departure, and expired carbon dioxide should be 35 millimeters mercury. So it's always preferable to have a transport multi-monitor with analyzing carbon dioxide. If your patient has pneumothorax, it can increase intracranial pressure by transmitting. So pneumothorax have to be drained with a chest drain. And also please don't clamp the chest drain during transit, because that can increase the intrathoracic pressure, which can eventually increase the intracranial pressure. Right. During transfer, you have to monitor all this. You have to monitor pupil size and reaction to light, your ECG, blood pressure. So your blood pressure has to have mean arterial pressure above 80. Mean arterial pressure automatically comes in those automated non-invasive blood pressure monitors. Urine output has to be monitored. The patient has to be catheterized. Pulse oximetry, capnography. So pulse oximetry saturation, you have to keep always above 95. It's good to have a saturation 100. And capnography, ETCO2 35. CVP is monitored when needed only. It's not mandatory. And temperature, preferably core and peripheral temperature, because hyperthermia also kills. Before transfer, you have to do all these investigation, blood gas blood gas analysis, X-rays. So chest X-ray, lateral cervical spine X-ray, pelvic and other appropriate X-rays before transfer. And blood investigations like full blood count, coagulation strain, blood sugars, and appropriate other investigations. If you need blood, please cross-match. You have to immobilize this patient's head and neck. So head immobilization could be manual with hands and legs at some certain times, like during intubation, and simple assist device like sandbags, towels, foam pads, etc. You can have straps to immobilize the head, and head neck immobilizers, like in here. Right, there is a strap and there are sandbags on either side to immobilize the head. Right. Neck immobilization is by means of collars. You can use a Philadelphia collar, stiff neck, or other options. So here there is a collar with a central hole through which we can have a tracheostomy done. Okay. The patient's body has to be immobilized by backboards. It's important for transport patients and keeping them from possible injuries during transport. And you have to use straps, right? So these are spinal boards that you can see at the head end. There is a head immobilizer, and all these holes are meant for strapping the patient. Right. Other things you should do is to elevate the head end of the bed 30 to 45 degrees angle up. Then it will promote venous drainage and reduce intracranial pressure. Always adjust the head to midline position. Right? Don't keep the head turned, because in the midline position only the venous drainage will be better and the perfusion will be better. Always sedate with propofol, morphine, midazolam, said earlier, and maintain a normothermia. Treat fevers. If you have fever, there will be cerebral vasodilation and more blood in the brain. So please treat fevers before they are sent. Neuromuscular blockade is a must. Please don't allow the patient to breathe. Paralyze them and ventilate. And a decompressive craniotomy if facilities are available at your hospital. So anticonvulsants may be used to prevent early seizures within 7 days of head trauma seizures, but not recommended for post-traumatic seizures. Right. So it's a summary. In head traumatic brain injury, there's a primary brain injury, the secondary brain injury. The primary brain injury is your initial insult on the brain. Example, EDH, SDH, SDH, ICH, IVH. Secondary brain injury is due to worsening of cerebral edema, leading to increased intracranial pressure, herniations, and coning. So factors which worsen the secondary brain damage is hypoxia, hypercarbia, acidosis, hypertension, hypothermia, hypoglycemia, and extreme hypocarbia, carbon dioxide below 27. And all these patients have to be paralyzed and ventilated. Sometimes the neurotrauma unit might tell you to paralyze and ventilate for 24 to 48 hours. You have to give IPPV, intermittent positive pressure ventilation, targeting a carbon dioxide around 35 millimeters mercury. You have to repeat the patient's CT scan if the patient is not improving. So sometimes it's beneficial to give furosemide because it reduces cerebral edema, but be careful, furosemide can drop your blood pressure also. Seizure prophylaxis is mainly with phenytoin sodium, but you can use benzodiazepines or thiopentone sodium for that matter. If your brain injury is associated with hematomas or tumors, you can use dexamethasone, 4 to 8 milligrams 6 to 8 hourly. Always monitor the GCS and pupil size after taking off the patient from sedation. And intracranial pressure monitoring is done in traumatic brain injured patients' neurotrauma centers. Cerebral protected drugs have to be used on all these patients. These are thiopentone sodium, propofol, benzodiazepine, vecuronium, and norfloxacin. Okay, thank you. If you have any questions, I am prepared to answer. If you have any questions, I'm prepared to answer.
Yes, if you all have any questions, please type in or you can unmute and ask. So I think, madam, no questions. So thank you very much for the detailed lecture, madam. So thank you once again. So that's all, Dr. Nandika. Yeah, so
Dr. Roshan, you say that for the day.
Okay, madam.
Thank you.
Right. Thank you very much. So join tomorrow by 8:45. Thank you.
Excuse me. Is there any attendance that we are taking today?
No, we will let you know that. One of the days we will take, then we'll share the link on the WhatsApp, on the chat box, or you can enter.
Good, thank you.
Thank you.
No, that's fine. Yes. Okay, thank you.